Hello students, hope all of you are doing well. So today was CBOT and we are going to discuss the dermatology questions. And let us move on directly to the first question which was asked from dermatology. And here this is a repeat question. As you can see that the patient complaining of severe pain over chest, and in the image you can see that the lesions are unilateral. And these are which type of lesions? These are vesicles. So grouped painful vesicles which are unilateral along a particular dermatome is suggestive of shingles or herpes zoster. So obviously the answer here is herpes zoster. All of you know herpes zoster is due to reactivation of varicella zoster virus. So all of you know that varicella zoster virus causes chickenpox, and this virus lie dormant in the nerves and later on it can reactivate and cause such painful grouped vesicles which are generally unilateral along a particular nerve segment. The drug of choice for this condition is acyclovir, and the dose which is used is 800 mg 5 times a day for 7 days. Moving to the next question, here they are saying that the patient presented with recurrent painful orogenital ulcers, and always remember that whenever they ask you about recurrent orogenital ulcers, then the test which helps in the diagnosis is, so they are recurrent orogenital ulcers are suggestive of which condition? Yes, can you type in the chat box? Behçet's disease. Behçet's disease. And other findings other than orogenital ulcers which are seen in Behçet's disease are, it can be form of skin lesions, that is erythema nodosum, eye lesions, and which test positive? Correct, PATHOLOGY test positive. Yes, so PATHOLOGY, Pushpen Singh have answered it correctly. Correct. Yes, the answer is C, that is PATHOLOGY test. Okay, and here the examiner is talking about which disease? Behçet's disease. In Harrison, you might have read about the diagnostic criteria, that is recurrent oral ulcers with any two of the following 4 things, that is genital ulcers, skin lesions, eye lesions, and positive pathology test. If you get any 2 among these following along with the oral recurrent ulcers, then it is Behçet's disease. Moving to the next question, a patient is presenting with pruritus where interdigital cleft, that is web spaces, and as soon as you see web spaces, what is the first thing which comes to your mind? Yes, it is scabies. So scabies, the most common site is flexors, and here initially these papillary lesions can be present. So because cleft is involved, that is web spaces are involved, and it is very itchy condition. And which type of itching is seen in scabies? Yes, nocturnal, that is which is more at night. Okay, so this is a case of scabies. Now who will tell me the most characteristic lesions which are seen in scabies? Yes, please type in the chat box. Most characteristic lesions of scabies are burrows, and 3 important points about burrows: they are generally S-shaped, they are usually seen in web spaces, and they are formed by the sarcoptes mite which causes scabies, where in the stratum corneum. So burrows are the most characteristic lesions. Yes, so Kapil Dev Chaudhary, correct, you are correct, nocturnal pruritus. Moving on to the next question, here they are saying that a patient on multibacillary MDT therapy. So because the patient is on MB-MDT, what is the diagnosis? Diagnosis is MB type of leprosy. So from this question you know that the patient is suffering from MB, that is multibacillary type of leprosy, and that's why we give MB-MDT. Yes, Shivangi Tiwari, Pushpen Singh have answered it correctly. Burrows are the most characteristic lesions. Yes, absolutely correct. Now again they are saying that patient is on MB type of MDT, presented with inflammation and edema over pre-existing lesions. Now what this tells you, see, exacerbation of pre-existing lesions or disease due to change in the immunological status of the patient is seen in lepra reaction. So this sentence, that is inflammation and edema over pre-existing lesion, is suggestive of lepra reaction. Now this is which type of lepra reaction? As shown in the image, and there is nerve involvement, what is the next line of management? Now you can see that the patient is having lot of edema and nerve involvement, that is neuritis. So this is type 1 lepra reaction. While in type 2 lepra reaction, ENL develops, that is erythema nodosum leprosum, in the form of new lesions develop. So patient is suffering from MB type of leprosy along with lepra reaction, which is of type 1. So how you're going to manage this patient? For MB type of leprosy, patient is already taking MB MDT. For type 1 lepra reaction, the drug of choice is steroids. So if patient develops lepra reaction, we will continue MB MDT and we will add steroid, that is prednisolone, and this becomes the answer. This is a repeat question and already such type of question have been asked. So always remember that drug of choice for both, that is type 1 and type 2 lepra reaction, is same, and that is steroids. Prednisolone. What is the dose? 1 mg per kg body weight. So if the patient is of 60 kg, we will give 60 mg prednisolone, and this will be given for 2 weeks, and then we will taper, then 50 mg for next 2 weeks, and then gradually we will taper off. So that is how we treat lepra reaction in a case of leprosy. So never stop MDT, you have to continue MDT and add steroid for that lepra reaction. So Manu Chaudhary is saying it was about ATT. So here remember that this patient is suffering from leprosy. MDT is given in leprosy. So this is not ATT, this is MDT. So some of the students are saying, Pushpin Singh, question was not like that. Okay, so I'll see if there is some change in the question, but this is the question which I gave. So probably you can just read this question and this will be the answer of this question. If there is some change, I'll get back to you. Then a farmer presents with swollen foot and multiple sinuses as shown in the image. So what you can make out by seeing this image? So right now you can read this question and tell me what will be the answer here. So Kapil Dev and Anil Soni is saying thalidomide. So why not thalidomide? So remember that here this point, that is inflammation and edema over pre-existing lesion, is suggestive of type 1 lepra reaction. Edema is very prominent feature and neuritis, nerve involvement, is very prominent feature of type 1 lepra reaction, and thalidomide is not effective in type 1. It is very effective in type 2. So that's why we will not give thalidomide, we will give steroid. And remember that the drug of choice for both type 1 and type 2 is steroid. So anyways, you have to choose steroid even if this is type 2 lepra reaction. Okay, thalidomide is used in type 2 lepra reaction, but that is not drug of choice. The drug of choice for type 2 is also steroid. So I hope this is clear. Now a farmer presented with, why farmer? Because this condition usually occur after plant injury. Okay, so farmer presented with swollen foot and multiple sinuses as shown in the image. What is the likely diagnosis? So you can see multiple swellings. So multiple swellings and multiple sinuses with discharge. And in this discharge, there is one very characteristic feature which is seen, and that is granules. Granules. Okay, and this is a feature of Madura foot. So foot is the most common site, and multiple sinuses and swellings are seen. This is suggestive of mycetoma. Mycetoma, and mycetoma can be of two types: eumycetoma and actinomycetoma. Eumycetoma, which is generally fungal, and actinomycetoma, which is bacterial. So this is the common presentation, and remember this image. If multiple swellings over foot, which is the most common site, with multiple sinuses and discharge are seen, then it is suggestive of mycetoma. Moving to the next question. So Vinod is saying that fifth question was not there. It's okay. So fifth question, if it was not there, then at least you now know that if such type of image comes in the exam, then it will be Madura foot. Then sixth question, a psoriatic patient showed good response to oral steroids. Okay. So patient is already suffering from psoriasis, the diagnosis is given and it responded well to oral steroids, but on stopping these drugs he developed such type of lesions, and what you can see in the lesion, you can see multiple pustules. What is the diagnosis? So in psoriasis, all of you know psoriasis is an inflammatory condition, okay, and in any inflammatory condition if we give steroids, what happens? The inflammation subsides. So is the case with psoriasis, that when we give steroids there is good response, but when we taper off these steroids in these patients, what happens? Rebound phenomena occurs and more severe type of psoriasis develops in the form of erythrodermic psoriasis or pustular psoriasis. Here in the image you can see there are multiple pustules, so this is pustular psoriasis which patient has developed. And why patient has developed this? Because of the rebound phenomena due to tapering off of the steroids or taking off or stopping the steroids. So that's why the answer is pustular psoriasis. Pustular psoriasis. So Manu Chaudhary is saying that silver lesions were seen. Okay, so remember that over the lesions of psoriasis, silvery white scaling is seen, okay, but that is seen in psoriasis. But when pustular psoriasis develops, such type of pustules start developing. Pustules means pus-filled lesions. So pus-filled lesions in a case of psoriasis on tapering of the steroid is suggestive of pustular psoriasis. And yes, majority of you have answered it correctly. Sony and Sohail Ahmed, yes, correct. Okay, so Dipender is saying why not other options? So remember, see, Staph aureus infection. Okay, so why not Staph aureus infection? Because patient is already suffering from psoriasis. Okay, so in a psoriatic patient, what happens when we taper off these steroids? What happens? There are more chances for pustular psoriasis, and if there is staph infection, that will be only localized to one place, but here multiple pustules are developing. So this is not Staph aureus infection. This is what? This is pustular psoriasis. Then generalized erythema pustulosis and subcorneal pustulosis, both these present separately. Subcorneal pustular dermatosis is a condition which is also known as Sneddon-Wilkinson disease, and this is due to defect in desmocollin. Okay, so this presents like a blistering disorder, and generalized erythema pustulosis will involve whole skin, while here only over the lesions the patient is developing pustules. So that's why the answer will be pustular psoriasis. Which of the following causative organism is responsible for this condition? So all of you know that this is what? This is hand, foot, mouth disease, where patients start developing ulcerative lesions over the buccal mucosa and very painful ulcerative lesions over hand and foot. This is known as hand-foot-mouth disease, which is due to Coxsackie virus infection. Coxsackie virus infection, A16 is also a very common causative organism, that is Coxsackie A16. Yes, so all of you know pox virus is causing molluscum contagiosum. Molluscum contagiosum is a disease where lesions have central umbilication, and human herpes virus 7, all of you know, causes other condition. So that is why, so KU is saying that, sir, please explain the wrong options as well. Okay, so this is the wrong option here. Pox virus will cause molluscum, and the lesions of molluscum are something like this. Okay, then all of you know HHV7, which is also known as Kaposi virus, so that causes Kaposi sarcoma, which does not present something like this. Let us move on to the next question. Here they are saying image of the lesion is given which is associated with itching. Okay, and in the image what you can see annular lesion with central clearing. So central clearing, it appears as if the central portion is healing and the margins are quite prominent, so active margins. So what this is suggestive of? Yes, this is suggestive of tinea corporis. Tinea corporis presents with central clearing and ring-like lesions. That's why annular lesions are seen. Now, why this is not granuloma annulare, as one of you were saying that explain the wrong option also. So tell me why it is not granuloma annulare. It is not granuloma annulare because granuloma annulare is asymptomatic. But here itching is present, and itching is feature of tinea, that is the fungal infection. Similarly, psoriasis is generally asymptomatic and it have lot of scaling, silvery white scaling, which is not present here. So this is not psoriasis. And why this is not tinea cruris? Because cruris means involvement of groin. Here the lesions are not in the groin. So this is not tinea cruris. This is tinea corporis. So I hope this was helpful for all of you. Thank you very much.
कट रहा फेस अभी भी. हेलो एवरीवन, वेरी गुड इवनिंग. तो बच्चे लोग, कैसा रहा आप लोगों का पेपर? आई होप आई एम विजिबल टू एवरीवन. Yes, I can see your names in the comment section. I am reading your chat also along with discussing with you. So please give me a thumbs up if you are able to hear me loud and clear. So then we'll start with the discussion of ENT today. Yes, doctors, can you hear me? Pranam, Pushpinder, Gurudev, Pranam, Pranam आपको भी बेटा. So I hope the paper was good. You all attended the paper. It gave you an actual feeling of how the paper will be. So before I start with my ENT discussion, there are a few things that you should prepare yourself for. आपको पता है कि the exam is going to happen 10 days later. So minus today, only 9 days are left for the exam now, right? So first thing, this is very, very important. Before you do anything else, this is very, very important. First thing is that you have to change your sleep pattern now. Okay? So many students, they feel sleepy in the exam hall. So you don't have to do that. Now everybody start waking between 5 a.m. and 6 p.m. Okay? And you have to sleep after 6 p.m. Even after 5 p.m. is okay. या अगर आपको दिन में नींद आ रही है तो उसको अवॉइड करो. You will need at least 1 week so that you are fully awake between 5-6 a.m. to 5-6 p.m. राइट आपको सेंटर पे जाना होगा एग्जाम देने के लिए, सो यू हैव टू वेक अप अर्ली एट 5 o'clock, you will have to start from your hostel or from your PG at 6 o'clock, you have to reach the exam hall between 7 and 7:30 and then you have to start the exam. So you should not be feeling sleepy at 9 AM कि अब मुझे नींद आ रही है, एग्जाम स्टार्ट हो गया है, और even at 2 PM, right? So this is the first thing जो कि you know you have to be aware. Second thing is, you know, whatever you meal you have in between your exam, in the break time, don't take a heavy meal, keep a light meal in between. तो ये आपको एग्जाम सेकंड वहाँ पे उस डे पे आपको याद रखना है कि ऐसा ना हो कि सेकंड पार्ट से पहले आप बहुत ज़्यादा खाना खा लें और यू फील स्लीप इन द सेकंड पार्ट. सो दैट शुड नॉट बी देयर, राइट. थर्ड थिंग, यू शुड बी रेडी फॉर ऑल इवेंचुअलिटीज. इट इज़ पॉसिबल कि आपका जो है यू नो आपका कंप्यूटर हैंग हो जाए, आपका माउस स्लो चल रहा है, आपका कीबोर्ड जो है वो प्रॉब्लम कर रहा है, समथिंग इज प्रॉब्लम, एसी नहीं चल रहा. सो मैं बोलूँगा लास्ट 9 days फॉरगेट द एसी, स्टार्ट लिविंग विदाउट द एसी. It is going to be very hot and very dehydrating because monsoon is here, rains are here, so it is possible that it may be raining that day, then the weather will be good, but it is possible that there may be no rain, it is so sweaty and dehydrating. So prepare yourself for that, right? डॉक्टर हरजीत ने बोला है कि सर कैसा इस बार का पेपर रहेगा, मे बी सोमी अली सेइंग सर क्या इस एग्जाम का लेवल सेम है ना लाइक FMG. So I'll come and discuss that. Okay, so exam paper can be clinical, it can be one-liners, doesn't matter. Next अभी नहीं हो रहा है, but we are expecting that the paper will be clinical, one-liners will be minimal. Clinical paper per se, you know, as per me is easy. क्यों? क्योंकि उसमें आपको बहुत सारे hints मिलते हैं. one-liner में सिर्फ एक ही hint मिलता है, clinical में आपको 3 या 4 hint मिलते हैं. So it is easy for you. Okay, so लेकिन आपका पूरा टॉपिक को समझा और पढ़ा होना चाहिए क्योंकि उसमें ट्विस्ट ज़्यादा होते हैं, राइट. तो रास्ते के हिंट बहुत मिलेंगे लेकिन ट्विस्ट भी मिलेगा, तो समझ के जाना है. इसीलिए मैं कह रहा हूँ इट्स वेरी इंपॉर्टेंट दैट यू रिमेन काम. अगर कंप्यूटर हैंग कर रहा है, कोई प्रॉब्लम हो रही है, अपने इंजीनियर को बोलो, दे मे करेक्ट इट, दे मे नॉट करेक्ट इट. ओके, बट मोस्ट इंपॉर्टेंट थिंग इज दैट यू शुड नॉट लूज योर काम. इफ यू डोंट लूज योर काम, वट एवर टाइम यू हैव, वट एवर यू नो रिसोर्सेज यू हैव, दैट विल बी ओके फॉर यू टू क्लियर द एग्जाम, राइट. ओके, एंड नेक्स्ट थिंग इज प्रे टू गॉड, क्योंकि जहाँ इंसान की मेहनत खत्म होती है वहीं भगवान का काम शुरू होता है. आपको अच्छा सेंटर मिलना, आपको अच्छा उस दिन सब कुछ अच्छा होना आपके साथ, यू शुड रीच ऑन टाइम, देयर शुड नॉट बी एनी डिले, एग्जाम में कोई प्रॉब्लम नहीं हो. आई नो, यू नो, वन ऑफ द स्टूडेंट्स शी केम एंड टोल्ड मी, जिस दिन मेरा एग्जाम हुआ उस दिन मेरे फादर को हार्ट अटैक आ गया, MI हो गया, एंड द इन्विजिलेटर को इन्फॉर्मेशन आई एंड ही केम एंड इन्फॉर्म मी एज वेल, सो आई कुड नॉट गिव द एग्जाम. The student next to her also came and told कि sir, because she was, you know, in such a panic, even we could not give the exam. We were consoling her. So ऐसा होता है बेटा. You know, there are things which are out of your hand, you just can't do about it. So pray to God. God is also very important, right? Okay. December exam attempt मिलेगा अब, but you know, don't think about the December exam. Think that this is the only attempt that you have to do and clear it. Right, and that was the first thing that I want to say. Second thing I want to say about one of my idols. My idol right now is no more, but his name is PAATHOLOGY. तो कौन है PAATHOLOGY? He was a Hungarian. हंगरी में born हुआ था, and he was a sharpshooter, right? And he wanted to participate in Olympics. His only aim was that 1936 में I have to go into the Olympics and I have to win the Olympic medal for my country. But he was not allowed to participate. Why? Because only commissioned officers were allowed. तो इसको allow नहीं किया because he was just a sergeant at that time. बोला sergeants cannot, soldiers cannot go and go and play in the Olympics. So मना कर दिया. He said कि बाकी countries में allow करते हैं, but इनकी country में they didn't allow him. So he said, okay, no problem. I'll try next time and I'll become officer. So कुछ टाइम बाद जर्मनी ने उसको कॉन्कर कर लिया, हंगरी को. जर्मन्स दे यूज्ड टू अलाउ द सोल्जर्स आल्सो, सो नाउ ही वाज इन द जर्मन आर्मी. लेकिन 1938 में क्या हुआ, इसके हैंड में ग्रेनेड, एक फॉल्टी ग्रेनेड था, वो बर्स्ट कर गया एंड हिज राइट हैंड वाज डिस्ट्रॉयड. तो हिज कैरियर वाज ओवर, राइट. बट इसने हिम्मत नहीं हारी, दैट वाज वेरी इंपॉर्टेंट. व्हेन एवरीबडी थॉट दैट हिज कैरियर इज ओवर, इन 1 year उसने बोला मेरे को मेडल जीतना ही है. तो इन 1 year राइट हैंड पूरा डिस्ट्रॉय हो गया. बोला कोई बात नहीं, मैं लेफ्ट हैंड से शूट करूंगा. 1939 में ही केम बैक टू द शूटिंग चैंपियनशिप्स, जो नेशनल शूटिंग चैंपियनशिप्स होते हैं, और लोगों को लगा शायद ये ऐसे ही देखने आया है या हमारे को कंसोल करने आया है, हमारे को चीयर अप करने आया है, बट ही केम टू पार्टिसिपेट एंड ही वन ए मेडल इन दैट। ओके, और फिर उसके बाद वो 1939 के अंदर ही विद इन 1 ईयर ही बिकेम अपनी कंट्री के थ्रू वर्ल्ड चैंपियनशिप में गया। अब ओलंपिक जीतना था, 1940 का वेट करा था, लेकिन क्या हुआ 1940 के अंदर वर्ल्ड वॉर स्टार्ट हो गया, तो ओलंपिक्स वर कैंसल्ड। बेचारे की किस्मत देखो, 1940 में ओलंपिक्स वर कैंसल्ड, बोला कोई बात नहीं, मैं 44 में ट्राई करूंगा, 4 ईयर्स बाद ओलंपिक होता है। तो 1944 में क्या हुआ, वर्ल्ड वॉर 2 जो थी वो 45 तक चली थी बेटा, तो 44 वाज आल्सो कैंसल्ड, राइट? ओके, राइट, एंड देन व्हाट हैपेंड, यस जय श्री राम, बेटा सॉल्यूशन स्टार्ट कर रहे हैं, टाइम बहुत कम है, मैं जस्ट थोड़ी सी एक बात कर रहा हूं कि 1948 में ओलंपिक्स हुआ, फिर उसके बाद, और 1948 में जब ओलंपिक्स हुआ तो उसमें लाइक ही वॉज बॉर्न इन 1910, 39 ईयर्स का ही हो गया था, और तब तक एक स्पोर्ट्समैन की लाइफ खत्म हो जाती है। लेकिन उसको वो अटेम्प्ट मिला और उसने बोला अब मैं गोल्ड लूंगा, सिल्वर ब्रॉन्ज से मेरा कोई मतलब नहीं, मुझे सिर्फ गोल्ड चाहिए, और ये गोल्ड ले करके आया। तो ऐसे ही बेटा ये आपका एग्जाम है, आपको अपने लिए इस एग्जाम के अंदर मार्क्स लेके आने हैं, और 150, 160, 170 नहीं सोचना है, 200 प्लस का सोचना है, राइट? चलो इसके बाद हम पेपर स्टार्ट करते हैं। लेट्स स्टार्ट विद द क्वेश्चंस। ज़्यादा टाइम नहीं लेते आपके क्वेश्चंस का, आई नो योर टाइम इज वेरी वेरी इंपॉर्टेंट, बट हैव फेथ इन योर सेल्फ, हैव सेल्फ बिलीफ एंड यू विल डू इट, राइट? सुभाष चलो स्टार्ट करते हैं। फर्स्ट क्वेश्चन इज ओवर हियर, ए 30-year-old मेल वर्किंग इन एन आयरन फैक्ट्री प्रेजेंटेड विद एपिस्टैक्सिस फॉलोड बाय फोर्सफुल। अच्छा, ये फॉलोड नहीं होना चाहिए, फॉलोइंग होना चाहिए, ठीक है? तो इस तरह की ग्रामेटिकल मिस्टेक्स आपको पेपर में मिल सकती है, जनरली कम होती हैं, राइट? ओके, सो yes Subhash 201, so following forceful removal of nasal crest, he gives this history that he has been having similar episodes of crust formation since long। देखो बेटा इंपॉर्टेंट क्या है यहाँ पे, पेशेंट इज वर्किंग इन एन आयरन इंडस्ट्री, तो वहाँ पे बहुत सारी हीट है, बहुत सारा फ्यूम है जो नाक में जा रहा है, एंड बिकॉज ऑफ दैट ही इज हैविंग क्रस्टिंग, राइट? तो क्रस्टिंग हो रही है, राइट? क्रस्टिंग हो रही है, इस कंडीशन को हम बोलते हैं राइनाइटिस सिक्का। एट्रोफिक राइनाइटिस में भी हमारी क्रस्टिंग होती है, ड्राइंग होती है, बट दिस इज ए टाइप ऑफ एट्रोफिक राइनाइटिस विच इज लिमिटेड टू ओनली एंटीरियर 1/3। ओके, सो लिमिटेड टू, यहां पे भी होना चाहिए लिमिटेड टू एंटीरियर 1/3 ऑफ सेप्टम। ओके, सो दैट्स अ करेक्शन। सो आंसर इट्स अ टाइप ऑफ एट्रोफिक राइनाइटिस, कौन सा? राइनाइटिस सिक्का। सो राइनाइटिस सिक्का इज द आंसर ओवर हियर, दैट इज द करेक्ट आंसर, right? It's not angina. Angina is atrophic rhinitis. That is because of infection by Klebsiella anginae. Now this is a type of atrophic rhinitis which is limited to anterior 1/3, or it is because of occupation, right? So that is the answer in this question. Let's come to the next question. Okay, very interesting question. 8-year-old child. Okay, 8-year-old child. So age is important over here. Okay, so age is very important over here. 8-year-old child brought to an ENT clinic with complaint of hearing loss, which has developed along with nasal obstruction. Following is the examination finding. तो examination finding में हमें क्या देखने को मिल रहा है? Examination finding में we can see over here that there are air bubbles on the behind the tympanic membrane. There are air bubbles. अगर air bubble है तो किस में बनेगा? It will form in water, fluid. तो fluid है, 8-year-old child है, we know what is the answer. Answer is going to be otitis media with effusion. Okay, right? Spot diagnosis है, अगर आप ये photograph देखोगे you can say otitis media with effusion, that's the other name for serous otitis media. ये confuse नहीं होना है, बहुत लोग इस नाम में confuse हो जाते हैं, OME otitis media with effusion, that's the other name for serous otitis media और glue ear. हाँ बेटा, किसी ने पूछा कि वाई इट कैनॉट बी राइनोस्क्लेरोमा, प्रीवियस क्वेश्चन, वाई इट कैनॉट बी राइनोस्क्लेरोमा। तो बेटा राइनोस्क्लेरोमा के में क्या होता है? राइनोस्क्लेरोमा में क्या होता है? राइनोस्क्लेरोमा में 3 स्टेजेस होती हैं। नंबर 1 स्टेज ऑफ एट्रोफी। तो स्टेज ऑफ एट्रोफी भी जो है वो फर्स्ट स्टेज है, मैं मानता हूं, लेकिन वो थ्रू आउट होगी। और यहां पे बहुत इंपॉर्टेंट, बहुत टिपिकल है हिस्ट्री। ओके, किस चीज की हिस्ट्री? हिस्ट्री ऑफ वर्किंग इन एन आयरन फैक्ट्री, राइट? और ये क्रस्ट रिमूव करने पे ही हो रहा है। एपिस्टेक्सिस राइनोस्क्लेरोमा में इंपॉर्टेंट फीचर नहीं है। ओके, नेजल ऑब्स्ट्रक्शन इंपॉर्टेंट होता है, एनोस्मिया इंपॉर्टेंट होता है, राइट। ओके, सेम इज द केस विद एट्रोफिक राइनाइटिस ऑल्सो, कि उसके अंदर एनोस्मिया इंपॉर्टेंट है, उसके अंदर जो है आपका फाउल स्मेल ओजाइना इंपॉर्टेंट है, उसके अंदर ऑब्स्ट्रक्शन इंपॉर्टेंट है। यहाँ पे एंटीरियर 1/3 में ही क्रस्टिंग ज़्यादा और उसको रिमूव करती है एपिस्टेक्सिस हो रहा है। तो आंसर मैं वापस से बता रहा हूँ, इसके अंदर इसका आंसर क्या है, राइनाइटिस सिक्का, राइट। ठीक है बेटा, सेकंड क्वेश्चन ओके ब्लर आ रहा है क्वेश्चन, परवेज सलीम। सो बेटा क्या क्वेश्चन आपको ब्लर आ रहा है? इमेज इज ब्लर, image is quite visible over here, as I can see that the image is quite visible. You can see the air bubbles over here, right? Okay, let's go to the next question. Identify the structure marked with the arrow in the given image of paranasal sinuses. तो ये हमारे पास इमेज है, इमेज में क्या है बेटा? What can you see in this image? Come on, tell me. Now this image, as you can see, this is a water's view with open mouth. Mouth open है, जो आपको दिख रहा है, ये आपको पता होना चाहिए। ओके, इसको हम पियर्स व्यू भी बोलते हैं एक्चुअली में। क्लासिकल वाटर्स व्यू इज विद क्लोज माउथ, याद रखना है, क्वेश्चन आया हुआ एग्जाम में। ओके, राइट। नाउ एरो इज ओवर हियर, सो व्हेन द एरो इज ओवर हियर, दिस इज द इजीएस्ट क्वेश्चन, आई विल से दिस इज द इजीएस्ट क्वेश्चन फ्रॉम दिस एक्सरे। ओके, क्योंकि ये क्या है, ये है मैक्सिलरी साइनस, राइट। इसके ऊपर ये क्या है, ऑर्बिट है, यहाँ पे क्या है, फ्रंटल साइनस। ओके, और क्या देखता है आपको, अगर आप देखेंगे ये नेजल बोन है और ये ऑर्बिट है, तो इनके बीच में यहां पे होते हैं एंटीरियर इथमोइड्स, राइट। ओके, मीटा इट इज वाटर्स व्यू विद ओपन माउथ, याद रखना। ओके, सो इट इज पियर्स व्यू, राइट। वाटर्स व्यू विद ओपन माउथ बोलो या पियर्स व्यू बोलो, डॉक्टर अनिल आप भी ध्यान रखें इस बात को। अगर इसमें और क्या दिखता है हमारे को वाटर्स व्यू के अलावा, वी ऑल्सो सी द स्फिनॉइड साइनस ओवर हियर, open mouth के through we can see the sphenoid sinus, right? Clear? So answer to this question is maxillary sinus. चलो next, let's go to the next question. अच्छा, ये इंटरेस्टिंग क्वेश्चन है, बिकॉज ये क्वेश्चन तो हमेशा हर एग्जाम में आता है। वेरी वेरी इंटरेस्टिंग क्वेश्चन। 18-year-old मेल, तो टीन मेल प्रेजेंटेड विद चीफ कंप्लेंट ऑफ रिकरेंट एपिस्टेक्सिस। तो मैंने आपको बताया बेटा 3 थिंग्स आपको देखनी है, टीन एज ग्रुप, मेल एपिस्टेक्सिस, योर डायग्नोसिस शुड बी GNA। बिना सोचे 3 चीजें हैं तो आंसर सीधा क्या होना चाहिए, GNA, राइट। ओके, नो कंफ्यूजन इन इट। ओके, प्रेजेंटेड विद रिकरेंट एपिस्टेक्सिस along with nasal blockage. On examination, polypoidal mass is seen going from nose to nasopharynx, completely occupying the posterior corona as seen in the following image. On CT scan, enhanced uptake of कंट्रास्ट इज गिवन। भाई सब बोल दिया, ठीक है। एंड एनहांस अपटेक एनहांसिंग मास है, तो क्या हो गया आंसर? यस, आंसर इज क्लियर, GNA, नेजोफ्रेंजियल एंजियोफाइब्रोमा। वैसे ही फर्स्ट 3 इनसे हमें पता लग गया था, राइट। सो फर्स्ट 3 से ही हमें पता लग गया था कि ये मेल एंड एपिस्टेक्सिस की आंसर हैज टू बी नेजोफ्रेंजियल एंजियोफाइब्रोमा। Okay, so Meeta approaches, surgical approach, तो Sardanas approach we can use. There are a lot of approaches. The treatment of choice is endoscopic excision. Right? Let's go to the next question. Shall we? Okay. So most common adult carcinoma. Beta, this is not a carcinoma. GNA is a benign lesion. Okay, it is a benign lesion, benign tumor. All right. Following is the endoscopic image of nasopharynx. Identify the encircled site. तो बेटा ये आपको the arrow site जो है, जो arrow लगे हुए हैं यहाँ पे, this arrow represents the eustachian tube, और उसके posterior superior जो हमारा encircled site है, that is we know is the fossa of Rosenmuller. तो ये भी spot diagnosis था, right? This was also a spot diagnosis. It's image based question, very easy question. You have studied this image, I have taught you many times. ओके, फोसा ऑफ रोजनमुलर का इंपॉर्टेंस क्या है अगर मैं पूछूंगा तो, दिस इज द मोस्ट कॉमन साइट फॉर ओरिजिन ऑफ नेजोफरेंजियल कार्सिनोमा, राइट। ये याद रखेंगे क्योंकि क्वेश्चन नेक्स्ट ट्विस्ट भी आ सकता है। ओके, बोले इससे क्या ओरिजिन होता है, तो नेजोफरेंजियल कार्सिनोमा, राइट। यस यस नायरा, यू आर करेक्ट। ओके, नेक्स्ट क्वेश्चन, 40-year-old ट्रम्पेट प्रोफेशनल ट्रम्पेट प्लेयर, तो यहाँ देखो आपको फिर से हिंट मिला, प्रोफेशनल ट्रम्पेट ब्लोअर 40 years has developed a right-sided swelling in upper part of neck. The swelling keeps changing in size off and on. तो swelling is changing off and on. Following is the X-ray finding. तो X-ray में क्या दिख रहा है बेटा हमारे को? X-ray में क्या दिख रहा है हमारे को? What can we see in the X-ray? X-ray में हमको एक air pocket दिख रहा है. Both AP view and lateral view are given. In the lateral view also you can see that there is a air pocket. Okay? So दोनों में हमें air pocket दिख रहा है. Both of them we can see the air pocket. Right? So come on, spot diagnosis. Yes, everyone is guessing it right. I'm very happy कि आप लोग सही guess कर रहे हैं. Answer is laryngocele. Air-filled cystic swelling of the neck that develops from saccule of larynx. कहाँ से develop होता है? Saccule of larynx से develop होता है. किस में मिलता है? Trumpet blowers में. ओके यहाँ पे एक साइन भी होता है जो आपको याद होना चाहिए, ब्राइस साइन. अगर आप इसको प्रेस करोगे तो इट विल रिड्यूस इन साइज विद गर्गलिंग साउंड ऑफ एयर एस्केप. सो स्वेलिंग कीप्स चेंजिंग इन साइज ऑन एंड ऑफ ना. सो व्हेन यू प्रेस दिस स्वेलिंग इट विल रिड्यूस इन साइज. ब्राइस साइन. यस कपिल देव, वेरी गुड, ब्राइस साइन. ओके चलो नेक्स्ट क्वेश्चन पे चलते हैं. जहां आपको प्रॉब्लम हो, डाउट हो, आई एम रीडिंग योर ऑप्शंस, आई एम रीडिंग योर कमेंट्स ओवर हियर. तो आप प्लीज बाकी ऑप्शन किसी में कुछ पूछना है आप पूछ सकते हो मेरे से. फॉर एग्जाम्पल इन क्वेश्चन नंबर दिस फेरेंजियल पाउच ज़ेंकर्स डायवर्टिकुलम, यहाँ पे जो साइन मिलता है उसको बोलते हैं बॉयस साइन. इसमें गर्गलिंग साउंड ऑफ फ्लूइड एस्केप होता है. राइट? ओके, ज़ेंकर्स डायवर्टिकुलम फेरेंजियल पाउच, हाइपोफेरेंजियल पाउच. लेट्स कम टू द नेक्स्ट क्वेश्चन, 7th क्वेश्चन. ए टीचर विद हिस्ट्री सजेस्टिव ऑफ गैस्ट्रोइसोफेजियल रिफ्लक्स. अच्छा, तो गैस्ट्रोइसोफेजियल रिफ्लक्स हो रहा है मैम को. मैडम है, सर है, पता नहीं, मैडम है. हाँ, शी लिखा हुआ ना तो मैडम है. शी हैज़ बीन टेकिंग फ्रीक्वेंट लॉन्ग uninterrupted sessions. So ma'am is taking a lot of sessions which are uninterrupted sessions before the final examination of students. She has been complaining of hoarseness of voice for last 1 month. And laryngoscopy photograph is seen. So क्या दिख रहा है photograph में? Photograph में we can clearly see development of vocal nodules. देखो bilateral हैं. कैसे होते हैं? Bilateral, symmetrical. और क्यों डेवलप होते हैं? Because of vocal misuse. Misuse मतलब long term. तो मैडम हैज बीन टेकिंग फॉर लास्ट 1 month. ओके, लॉन्ग टर्म है. सो क्या होगा आंसर? व्हाट इज द ट्रीटमेंट ऑफ चॉइस? सो बहुत बच्चों ने इसका आंसर वॉइस रेस्ट मार्क किया होगा. देखो ये ट्रिक होता है. चॉइस ए इज ऑलवेज ट्रिक. यू डोंट हैव टू जंप. ओके, यू हैव टू रीड ऑल द 4 ऑप्शंस. सो लास्ट ऑप्शन देखो क्या है? वॉइस रेस्ट एंड प्रोटॉन पंप इनहिबिटर. सर्जरी नहीं करते हैं इसमें. ओके, सो वॉइस रेस्ट एंड प्रोटॉन पंप इनहिबिटर. वैसे भी गैस्ट्रोएसोफेजियल रिफ्लक्स की हिस्ट्री दी हुई है एंड दैट इज कंट्रीब्यूटिंग टू फॉर्मेशन ऑफ दिस वोकल नोड्यूल्स. राइट? ठीक है, बहुत अच्छा बेटा. एवरीबडी इज मार्किंग इट करेक्ट. लेट्स कम टू द नेक्स्ट क्वेश्चन. 5-year-old चाइल्ड प्रेजेंटेड इन ENT OPD विद रेस्पिरेटरी डिफिकल्टी. ठीक है, तो हिस्ट्री देखो. 5 years old child presented in ENT OPD with respiratory difficulty, fever and drooling of saliva. So you know I always tell you 3 things. अगर पेशेंट को सिर्फ डिस्फेजिया, अगर आपके पास चाइल्ड आ रहा है, उसको फीवर है, सोर थ्रोट फीवर, बहुत सारी हिस्ट्री दी हुई है एंड साथ में सिर्फ क्या दिया हुआ है? डिस्फेजिया. सो आंसर कैन बी क्विंसी और इट कैन बी पैराफ्रेंजियल एब्सेस. ठीक है, राइट? इफ द क्वेश्चन इज अबाउट डिस्फेजिया प्लस डिस्पनिया, ये याद कर लो. दीज आर माई फॉर्मूलाज मेड फॉर यू. ओके, सो डिस्फेजिया एंड डिस्पनिया, ये कभी गलत नहीं होंगे आंसर. अगर ये दोनों हैं, मतलब डिफिकल्टी इन ब्रीदिंग, डिफिकल्टी इन स्वेलोइंग, बोथ ऑफ देम आर देयर. ओके, देन आंसर इज यस, एक्यूट एपिग्लोटाइटिस. और अगर सिर्फ डिस्पनिया है, ओके, देन द आंसर इज क्रूप. ये आपके लिए हिंट है. ओके, तो आपको तीनों में डिफरेंशिएट करने में प्रॉब्लम होती है, तो दिस इज हाउ यू हैव टू डिफरेंशिएट एंड फाइनलाइज द आंसर. ओके, सो क्या है आपको यहाँ पे? रेस्पिरेटरी डिफिकल्टी, ड्रूलिंग ऑफ सलाइवा, दोनों है, डिस्फेजिया एंड डिस्पनिया. सो आंसर इज एक्यूट एपिग्लोटाइटिस. एक्सरे दिया हुआ है. एक्सरे में क्या दिख रहा है हमारे को? थंब साइन. यस, हिमांशु, कपिल देव, श्रवण, वेरी गुड. Thumb sign. Okay, very good, very happy with you. तो मोस्ट कॉमन कॉजेटिव ऑर्गेनिज्म, राइट, यही पूछा ना, मोस्ट कॉमन ऑर्गेनिज्म। सो हमें पता है कि मोस्ट कॉमन कॉजेटिव ऑर्गेनिज्म फॉर दिस कंडीशन वाज अर्लियर हिब, हीमोफिलस इन्फ्लुएंजा टाइप बी, बट इसके अगेंस्ट अब वैक्सीन आ गई। ओके, इसके अगेंस्ट वैक्सीन इज इन यूनिवर्सल वैक्सीनेशन प्रोग्राम इन इंडिया एज वेल। Okay, so now Hib is not the most common causative organism. Now the most common causative organism is Streptococcus pneumoniae. ये चेंज हो गया है। ओके, तो ये क्वेश्चन इसलिए दिया ताकि आपको पता लगे कि दिस इज Streptococcus pneumoniae, दैट इज द आंसर, Hib इज नो मोर द आंसर, मोस्ट कॉमन कॉजेटिव ऑर्गेनिज्म। ठीक है, तो ऐसा नहीं हो कि आपने सब डायग्नोस कर लिया, सब कुछ कर लिया और फिर भी आप रॉन्ग आंसर मार्क कर रहे हो। सो बी वेरी केयरफुल ओवर हियर। Right? Yes, doc vaccine. Vaccine has made the answer Streptococcus pneumoniae. Let's come to the next question over here. A 42-year patient presented to you with hoarseness of voice. Upon examination, this is your finding. Image shown below, abnormal side. Okay, तो क्या है? Hoarseness of voice है. Right? On examination क्या दिख रहा है आपको? आपको दिख रहा है one side vocal fold is paralyzed. Although more should be mentioned over here, the condition and everything, or the movement of vocal fold, but you can see by the examination, ठीक है, by this examination that the vocal fold is in which position? It is in which position? It is in cadaveric position. Okay, तो क्या करोगे आप? hoarseness of voice हो रही है तो इसको आपको बीच में लाना है, आपको बीच में लाना है। कैसे करेंगे? टाइप 1 थायरोप्लास्टी, दैट इज नीडलाइजेशन थायरोप्लास्टी। टाइप 2 क्या होती है? उल्टा होता है, लेटरलाइजेशन थायरोप्लास्टी। Anyways, I have taught thyroplasties in detail, you can go there. Okay, so answer to this question is type 1 thyroplasty. Okay, cadaveric position में है vocal fold, right? Okay, अमित लतवाल, बेटा पेंटावेलेंट वैक्सीन आ गई है अब, जिसमें डिफ्थीरिया, पर्ट्यूसिस, टेटनस और हेपेटाइटिस बी और ये हिब, हीमोफिलिक इन्फ्लुएंजा टाइप बी, ये पांचों के पांचों हैं, तो जो वो है आपका पेंटावेलेंट वैक्सीन आ गई है। ओके, नेक्स्ट क्वेश्चन, क्वेश्चन नंबर 10, बेसिलर मेम्ब्रेन सेपरेट्स। तो बेटा कॉक्लिया का डायग्राम याद करो, बहुत स्ट्रेट फॉरवर्ड क्वेश्चन है। कॉक्लिया का डायग्राम होता है, उसमें दो मेम्ब्रेन्स होती हैं, ऊपर वाली मेम्ब्रेन का नाम होता है रीजनस मेम्ब्रेन, नीचे वाली का नाम होता है बेसिलर मेम्ब्रेन, स्केला वेस्टिबुलाe, स्केला मीडिया, स्केला टिम्पेनाe। ओके, तो किसको किसको सेपरेट कर रही है? स्केला मीडिया एंड स्केला टिम्पेनाe, राइट। ओके, और आपको पता है इसमें आपको इंपॉर्टेंट क्या है? बेसिलर मेम्ब्रेन के ऊपर यहाँ पे होता है ऑर्गन ऑफ कॉटी, ठीक है, तो ऑर्गन ऑफ कॉटी इंपॉर्टेंट है, राइट। नंबर 2, यहीं से आपकी न्यूरॉन्स जा रहे हैं, 8th नर्व फाइबर्स आपसे यहाँ से जा रहे हैं। तो हम क्या करते हैं? हम जो कॉक्लियर इम्प्लांट करते हैं वो कॉक्लियर इम्प्लांट भी हम करते हैं किसमें? स्केला टिम्पेनाe में, राइट। ओके, केवल 180 वधेर, बेटा आई एम ट्राइंग टू एक्सप्लेन ऑल द इनकरेक्ट ऑप्शंस, बट अगर आपको कुछ समझ में नहीं आ रहा, यू कैन आस्क मी, आई एम हेयर फॉर यू, द आइडिया इज टू क्लियर ऑल योर डाउट्स। ओके, सो ऑर्गन ऑफ कॉटी, और यहां पे क्या करते हैं हम? कॉक्लियर इम्प्लांट, राइट। ओके, नेक्स्ट क्वेश्चन, क्वेश्चन नंबर 11, ड्यूरिंग सर्जरी ऑफ इंटरनल acoustic meatus, the surgeon identifies a structure named Bill's bar. This bar separates. So हमें पता है कि internal acoustic meatus, we can divide it like this. Okay, so it is divided into two parts. You divide upper part and lower part. और upper part में, let's say this is the okay, let me draw over here so that everyone is able to see it. Okay, so I have drawn the internal acoustic meatus and I am dividing over here into two parts, upper and lower part. तो upper part में let's say this is the anterior, this is the posterior. तो upper part में बीच में यहाँ पे एक Bill's bar होती है. This is named after Dr. William House. Okay, named after Dr. William House. उनके घर का नाम बिल था तो इसको Bill's bar कर दिया, right? And इसमें क्या होता है बेटा? इसमें anteriorly over here, anterior to the Bill's bar, we have the facial nerve. ओके, राइट। तो याद रखेंगे 7 अप, 7 अप, कोल्ड ड्रिंक है ना। ओके, और नीचे क्या होती है? यहाँ पे नीचे होती है यहाँ पे कॉक्लियर नर्व। कौन सी नर्व? कॉक्लियर नर्व। ओके, तो पीछे क्या होती हैं? तो राइट बेटा, पीछे होती हैं आपके यहाँ पे वेस्टिबुलर नर्व। कौन कौन सी वेस्टिबुलर नर्व? ऊपर हो गई आपकी सुपीरियर वेस्टिबुलर नर्व और पीछे हो गई आपकी इंफीरियर वेस्टिबुलर नर्व। तो क्वेश्चन आया था बिल्स बार किसको और किसको सेपरेट कर रहा है, तो आपको आंसर मिल गया होगा सुपीरियर वेस्टिबुलर नर्व फ्रॉम फेशियल नर्व। ओके, 7 अप निमोनिक याद रखेंगे, राइट। और यहाँ पे 7 अप ऊपर, 7 अप ऊपर है और कोका कोला नीचे है, तो कोका से कॉक्लियर नर्व हो गई, ठीक है। कोका कोला नीचे है, 7 अप ऊपर है, राइट। तो कॉक्लियर नर्व नीचे, 7 अप। और वेस्टिबुलर नर्व तो बहुत इजी है, दोनों आगे हैं तो पीछे वाली वेस्टिबुलर होगी, सुपीरियर वाली सुपीरियर होगी, इंफीरियर वाली इंफीरियर होगी। करेक्ट आंसर। ऑलराइट, क्लियर टू एवरीवन। चलो लास्ट क्वेश्चन ऑफ ईएनटी। तो ये क्वेश्चन और ये सर्जरी पहले करते थे, अभी नहीं करते हैं, बट यू नो लेट अस, क्योंकि क्वेश्चन ऐसे आ जाते हैं कभी कभार, लेट्स डिस्कस दिस क्वेश्चन। दिस पेशेंट वॉज प्रिपेयर्ड फॉर सर्जरी, योर सीनियर रेजिडेंट डिड दिस मार्किंग बिफोर द इंसिजन। तो आप यहाँ मार्किंग देखो, मार्किंग कैसी है, ये क्लियर मार्किंग आप देखो यहाँ पे, ये मार्किंग यहाँ से लेकर के ऐसे जा रही है। तो ये है हमारी लेटरल राइनोटमी अप्रोच। ओके, क्या बोलते हैं इसको, लेटरल राइनोटमी अप्रोच। यहाँ पे लेटरल पार्ट ऑफ द नोज से आप इंसिजन देते हैं एंड देन यू कैन गो इनसाइड, यू कैन डू मीडियल मैक्सिलेक्टमी। ये करते थे पहले फॉर बेनाइन ट्यूमर्स ऑफ नोज एंड नेजोफेरिंग सच एज जेएनए, ठीक है। उसमें पहले ये सर्जरी यूज होती थी, लेटरल राइनोटमी, उसके बाद मीडियल मैक्सिलेक्टमी, राइट। और इस इंसिजन का नाम क्या है, सबसे इंटरेस्टिंग बात तो ये, इंसिजन का नाम क्या है, तो इस इंसिजन का नाम है वेबर फर्गुसन इंसिजन। ओके, वेबर फर्गुसन इंसिजन, ठीक है। और इसमें सुप्रा सिलियरी और सब सिलियरी अप्रोचेस हो सकती हैं। तो यहाँ पे जो है आपको सब सिलियरी अप्रोच दिखा रखी है साथ में, वो इसका लेटरल एक्सटेंशन है। डोंट वरी अबाउट दैट, जस्ट रिमेंबर द वेबर फर्गुसन इंसिजन। ओके, ऑन ग्रेन्स लाइन के बारे में बात कर लेते हैं। ये सीए मैक्सिला में यूज होती है फॉर क्लासिफिकेशन, राइट। देन वी हैव लेडरमैन इंसिजन। लेडरमैन इंसिजन नहीं होता, लेडरमैन लाइंस होती हैं, लेडरमैन क्लासिफिकेशन होता है, वो भी जो है सीए मैक्सिला में यूज होता है, राइट। एंड फ्रंटल साइनोसोटमी, तो फ्रंटल साइनोसोटमी करने के लिए क्या करेंगे बेटा, फ्रंटल साइनोसोटमी करने के लिए आप यहाँ पे इंसिजन दे करके, ओके, यहाँ पे जा करके आप इसको ड्रिल करके बोन को, यू कैन गो इनटू द फ्रंटल साइनस, दैट्स द वे टू गो इनटू द फ्रंटल साइनस। तो फ्रंटल साइनोसोटमी इस तरीके से करते हैं, राइट। सो थैंक यू बेटा, आई होप यू। सो ओरल कैंसर के लिए बेटा नॉर्मली वी डोंट यूज, यू कैन यूज दिस इंसिजन फॉर मैक्सिलरी कार्सिनोमा ऑल्सो। अगर आपको टोटल मैक्सिलेक्टमी करनी है, मीडियल मैक्सिलेक्टमी करनी है, सो वी कैन यूज दिस इंसिजन इन लॉट ऑफ अदर वेज, राइट। ओके, सो आई होप दैट वाज यूजफुल, थैंक यू वेरी मच। और बेटा फोड़ के आना पेपर को, राइट। सिर्फ और सिर्फ अब रिवाइज करना है, कुछ भी नया नहीं पढ़ना, जो आप पढ़ चुके हैं सिर्फ उसी को रिवाइज करना है। एंड बेस्ट ऑफ लक टू एवरीवन।
पेन कहाँ है? चाय पी लूँ? चाय पीते पीते पढ़ा देंगे हो गया. Okay guys, am I audible? So let's start our discussion. I hope the exam went well. Okay, starting with question number 1, which antibody is used to diagnose neonatal SLE? So just try to answer in the comment box. Try to answer this. Antibody used to diagnose neonatal SLE. Good evening everyone, am I audible? Okay, let's start this question. Neonatal SLE. Neonatal SLE, understand this. The first thing, neonatal SLE, how this will present? This will present with complete heart block. So there will be third degree heart block. Just remember, or we call this complete heart block. Okay, so what is the name of antibody? So the antibody name is anti-Ro. So anti-Ro, remember, this is seen in neonatal SLE. It is also seen in Sjogren syndrome. It also seen in Sjogren syndrome. So we sometimes also call this as anti-SSA. Coming to anti-histone. Anti-histone antibody, this is seen in drug-induced lupus. It is seen in drug-induced lupus or drug-induced SLE. Okay, anti-topoisomerase, where we see anti-topoisomerase. Anti-topoisomerase is also called as the commercial name. Commercial name for this antibody is anti-SCL70. And this is seen in a patient with, yes, come on. कहाँ मिलती है anti-SCL70? राम राम. Good evening guys, बताओ कहाँ मिलती है? बाकी सारे आंसर भी सॉल्व करने हैं ना? So try to answer. Where we see anti-topoisomerase, it is seen in systemic sclerosis. Systemic sclerosis. Anti-U1-RNP. U1-RNP means anti-U1 ribonucleoprotein. This is seen in MCTD, mixed connective tissue disorder. So एक बार फिर से देखते हैं. Anti-Ro, Sjogren syndrome as well as neonatal SLE. Just anti-Ro is also called as anti-SSA. SSA means Sjogren syndrome A. Anti-histone, drug-induced lupus, anti-topoisomerase also called as anti-SCL70. We see in systemic sclerosis, anti-U1-RNP, MCTD. ओके आगे चलते हैं. अब बताओ आंसर. व्हाट इज योर आंसर? अ पेशेंट presented to OPD with complaint of progressive enlargement of hands. So first hint in the MCQ is progressive enlargement of hands and feet. हाथ पैर बढ़ रहे हैं, right? And was diagnosed with acromegaly. So आपको आंसर दे दिया. So they are asking you what is the most common cause for this condition. Okay, so understand this. There is more growth hormone, that is clear. There is more growth hormone, that is clear. So there is no role of GHRH. Now see, it could be a growth hormone and prolactin secretion from mixed. Any role of galactoria, gynecomastia that's given in MCQ? No. Only they are asking about just growth of body, means growth, progressive enlargement of arms and limbs, right? So these patients will have tau-like, so that is nothing. It is a case of increased growth hormone due to growth hormone secreting adenoma. And this is most common cause of acromegaly. Clear? So GHRH secretion from hypothalamic hematoma, unlikely. Then what we have, growth hormone and prolactin secretion from mixed. So here patient will also have, along with this patient will also have galactoria and gynecomastia. Growth hormone and prolactin from mixed, somatotrop, thyrotrop, no. Thyrotrop will release TSH. So thyrotrop will never release prolactin. Then what we have, growth hormone secretion from somatotropic adenoma. Answer is D. Okay, clear? Coming to next one. Following types of non-Hodgkin lymphoma and its corresponding grades are correctly matched. बताओ इसका आंसर बताओ. What is the answer for this question? Try to answer. Types of non-Hodgkin lymphoma corresponding grades are correctly matched. So understand this. We can have a non-Hodgkin lymphoma. In short, we call this NHL. So NHL, either it could be due to B cell proliferation or it could be due to T cell proliferation. या तो B cell का होगा या T cell का होगा. So what are the B cell proliferative tumors? So understand this. We have follicular cell lymphoma. So since we have less time, so I'll be writing in short. So first is follicular cell lymphoma. Then what we have? We have Burkitt lymphoma. Burkitt lymphoma. diffuse large B cell lymphoma, DLBCL. Then we have mantle cell lymphoma. We have marginal zone lymphoma. And we have maltoma. And last one is hairy cell leukemia. So these are due to proliferation of B cell. Now coming to T cell, we have adult T cell leukemia. Adult T cell leukemia. Mycosis fungoides. Mycosis fungoides. And anaplastic large T cell lymphoma. Anaplastic large T cell lymphoma. So these are T cell tumor. Now understand this. They ask you a question in exam, like which of these is high grade. So understand this. Now Burkitt lymphoma is considered one of the one of the highest growing human tumor. Means it's having high mitotic index. And more than this, what we call this, like any of this, I told you in the class also, you know this, DLBCL is most common diagnosed because most of the non-Hodgkin lymphoma, the patient will not have any symptom. They are asymptomatic. तो ज़्यादातर पेशेंट को सिम्टम नहीं होते, जब सिम्टम होते हैं तब वो स्टेज में आता है. तो दीज टू कैंसर्स आर द दोस विच आर हैविंग हाईएस्ट माइटोटिक इंडेक्स. ये भी एक क्वेश्चन आया हुआ है. These are the two which have high mitotic index. High mitotic index means more cell division. More cell division means more cell growth. So let's see, small lymphocytic lymphoma is high grade. They're asking you correctly match. You know, it is a low grade tumor. So high grade, what we have these two, BL and DLBCL. These two are high grade. So these two are considered high grade human tumor. Follicular lymphoma, intermediate grade. Diffuse large B cell lymphoma, is it low grade? Is it low grade or not? ये तो high grade है. ये तो high grade है. So it's not correct. So understand this. Follicular cell lymphoma is considered low grade. Small lymphocytic lymphoma is considered low grade, and this Burkitt lymphoma is considered high grade. So this is a statement that is correctly matched. So remember, question क्या पूछा है? Which of the following types of non-Hodgkin lymphoma and its corresponding grades are correctly matched? So Burkitt lymphoma हमेशा कैसा होता है? High grade. Is it clear? तो समझ आया? Diffuse large B cell lymphoma उससे भी ज़्यादा high grade. Is it clear? So if I ask you out of this most dangerous type will be DLBCL. Am I clear? Okay, आगे चलते हैं. Try to answer this question. So first MCQ in the question itself is the age of the patient. So very important thing is first hint. First hint you will get is age. So 33-year-old female. First hint. Then you can see chronic bacterial prostatitis. तो पेशेंट को क्या है? क्रोनिक बैक्टीरियल प्रोस्टाटाइटिस वॉज ट्रीटेड विथ कोट्रीमोक्साजोल. तो ड्रग की हिस्ट्री हो गई. विद इन अ फ्यू डेज ही डेवलप्ड मलीज, जॉन्डिस, एब्डोमिनल पेन, डार्क यूरिन. सो दीज आर द हिंट इन द एमसीक्यू. इन सिंपल लैंग्वेज दे आर आस्किंग यू. अब बार बार क्वेश्चन को नहीं पढ़ सकते बिकॉज इट्स अ बिग केस. इन सिंपल लैंग्वेज यू हैव टू अंडरस्टैंड दिस क्वेश्चन. दिस इज लाइक अ पेशेंट जिसने दवाई ली प्रोस्टाटाइटिस के लिए, देन पेशेंट डेवलप मलीज, जॉन्डिस, एब्डोमिनल पेन एंड डार्क यूरिन. सो बिगेस्ट हिंट इज डार्क यूरिन. The blood picture is given below. What is the likely diagnosis? Okay, so understand this. First thing you have to look at the screen. This is looking like a bite cell. Am I right? It is looking like a bite cells. Bite cells means, suppose, understand, it's like there is a dark urine. Dark urine means there is hemoglobinuria. So it's a case of hemolytic anemia. अभी आंसर पर नहीं पहुँचे, अभी धीरे धीरे करके जा रहे हैं. It's a case of hemolytic anemia. Now see, out of these all options given are hemolytic anemia. Am I right? Hemolytic uremic syndrome, autoimmune hemolytic anemia, G6PD, PNH, all are hemolytic anemia. तो सब में डार्क यूरिन होगा. Now see, if you see AIHA will have spherical RBC, ऐसे कटे हुए RBC नहीं होंगे. So it is ruled out. PNH will not have characteristic smear findings, so it's ruled out. Now understand, hemolytic uremic syndrome, it will have broken RBCs. Is it clear? But here the patient is having drug history. So understand this, hemolytic anemia due to some drug. And mostly these drugs are sulfonamides or older antimalarial which are quinine derivative. So what happened? There is precipitation of hemoglobin within RBCs. Hemoglobin के अंदर RBC रह गई. So if you see, suppose this is RBCs, these RBCs are having hemoglobin residue. Hemoglobin residue. Now who will take action? कौन action लेगा? Now see, these are macrophage. Splenic macrophage. Macrophage, they are like possessive boyfriend. They cannot see anything abnormal attached to their RBCs. So what they will do? They will remove these precipitated hemoglobin. So when they remove this point is what we call this Heinz body. This precipitated hemoglobin is Haynes body, but now when it is removed, we call this as yes, very good, bite cell. Am I clear? We call this as bite cells. So you can see chronic bacterial prostatitis treated with drug, within a few days develop malaise, and here you can see bite cells. So this is what a case of G6PD deficiency anemia. Am I clear? G6PD deficiency anemia. So answer is G6PD deficiency anemia. Coming to next one, a patient with rheumatoid arthritis. So first hint in the MCQ is rheumatoid arthritis. So patient की history क्या है rheumatoid arthritis की? Treated with methotrexate. So you know, like a DMARD of choice or drug of choice. The first drug that we start is methotrexate. और साथ में क्या दिया? What we have given, low dose steroid for the past 4 months. However, the disease is still progressing. What would be your recommendation for further management? So understand this in any case. Okay, so we have a doubt in G6PD deficiency can lead to deficiency of NADPH, and it has got antioxidant property, but in patient due to G6PD deficiency, patient will not have NADPH and it's susceptible to infection. Yes, Meeta Sumaya, that's a good point. If someone score more than 200 in this mock exam, will she be able to clear FMGE? Of course. If you are getting 200 plus, you will get a good score in exam. If you are getting lesser score, don't dishearten yourself. Just remember, this is like a time to change your strategy in last 10 days. अगर आपके नंबर कम आए हैं, इससे मोटिवेट होइए और इसका अगले 10 दिन में 10 घंटे रोज पढ़ना है. That's it. Just follow the simple concept. 10 दिन में 10 घंटे रोज पढ़ना है. अगर आपके 10-20 नंबर कम है, then you can cover. Trust me, I can give you the assurance. आगे चलें. ओके, सो पहले मुझे बताओ पेशेंट क्या है रूमेटॉइड आर्थराइटिस का. द ड्रग ऑफ चॉइस, डिमांड ऑफ चॉइस इज methotrexate. आई टोल्ड यू द इनिशियल डोज. क्या होता है इनिशियल डोज? दैट इज 7.5 mg वंस इन अ वीक. नॉट ODBD. हफ्ते में एक गोली देनी है. 7.5 to 15 mg. अगर इससे कंट्रोल नहीं हुआ, देन व्हाट वी डू, वी ऐड अदर डीमार्ट्स. अदर डीमार्ट्स में क्या ऐड करोगे? Okay, let's see option. Stop oral methotrexate, start parenteral. No, methotrexate is very toxic drug, so we should not give a parenteral form of this. So इसमें हम orally देते हैं. Start only anti-TNF. Anti-TNF कब देते हैं? When we use at least 3 DMARD. अगर आपने 3 DMARD यूज़ कर लिए, उसके बाद भी improvement नहीं है, then only we use anti-TNF. Anti-TNF like etanercept and monoclonal antibodies, right? Like infliximab. Continuous steroid का right now there is no role of steroid. Is it clear? So what we do, if there is no improvement from methotrexate, we add SARS. एक tablet आती है SARS. SARS is sulfasalazine, so we can add sulfasalazine, and we can add HCQS, hydroxychloroquine. So we will continue methotrexate, we will add sulfasalazine, we will add HCQS. HCQS is hepatitis B, C and alcohol. These are 3 common conditions where we need liver transplant. तो यहाँ पर तो ट्रांसप्लांट करते हैं. एंड वंस लाइक वायरस डिड कम्प्लीटली डैमेज, देन वी हैव टेकन एंटीवायरल डोज. बट उससे अगर सिरोसिस हो गई, वंस यू ट्रांसप्लांट द लीवर, वायरस दोबारा इन्फेक्शन नहीं करेगा. अल्कोहल इंड्यूस, अगर पेशेंट शराब नहीं पिएगा तो दोबारा नहीं होगी. विल्सन डिसीज, अगेन इट्स अ जेनेटिक म्यूटेशन, सो वी डू ट्रांसप्लांट. बट अंडरस्टैंड, व्हेन वी हैव autoimmune hepatitis means here even we have changed the liver, but still the source of antibody is still in the body. So body में antibodies कभी जाएंगी नहीं, even we remove. Is it clear? So antibodies, they will never go back from your body. So that is why autoimmune hepatitis is something which can reoccur even after transplant. This is expected question in this attempt. Expected question in this attempt. Understand this. Autoimmune hepatitis, कोई भी autoimmune condition, in another autoimmune condition, what will happen is like if you treat, there is no point of improvement. Patient ठीक नहीं होता. We keep on giving steroid. So it's having like a relapsing and remitting pattern. कभी बहुत सारे symptom होते हैं, कभी कोई symptom नहीं होता. Am I clear? So this is called autoimmune hepatitis. Clear? आगे चलें. Shall we go ahead? Okay. Any doubt, guys? Yes, Sharvan, Pranit, Anil, Pushpendra, Fentanyl, Sneha, Mita. Any doubt to anyone? Okay. Coming to next question, try to answer. Elderly man is evaluated. बॉडी में एंटीबॉडी होंगे तो सिरोसिस होगा? नहीं, ऐसा नहीं है. बॉडी में एंटीबॉडी होती है. दिस एंटीबॉडी स्लोली दे कीप ऑन डिस्ट्रॉइंग द लीवर, एंड वंस योर लीवर इज टोटली डैमेज, दैट्स व्हाट वी कॉल सिरोसिस. अगर आपने अब लीवर ट्रांसप्लांट कर दिया, तो जो नई एंटीबॉडी, दोज ओल्ड एंटीबॉडीज आर स्टिल इन द बॉडी, दे कैन डैमेज द न्यू लीवर. इज इट क्लियर? ये 300 MCQ कर लिए तो कितने मार्क्स का कवर हो जाएगा? देखो इसमें से कुछ तो आएगा ही, बहुत सारे मार्क्स का कवर होगा। है क्लियर? आगे चलते हैं। Elderly man is evaluated for exertional dyspnea, cough and weight loss. So you can see like more blackishness. You can see prominent vessels here. This is like a more shady CT images that is seen where a patient is having exertional dyspnea, cough, weight loss. CT is given below. What is suggestive? It's not pneumonia. It's not granuloma. It's emphysematous lung. It is emphysematous lung. Okay, coming to next one. Drug not given in Wilson disease. बताओ विल्सन डिसीज में कौन सी दवाई नहीं दी जाती? ट्राई टू आंसर. सो विल्सन डिसीज, आई टोल्ड यू इट इज़ ड्यू टू ATP7B gene mutation. So to treat this condition, the treatment of choice is zinc acetate, or I can say the drug of choice, that is zinc acetate. Zinc के अलावा what we can use, it's a defect of copper, so we use copper chelating agent, like we can use D-penicillamine. D-penicillamine is like a chelating agent which will have a side effect, like it can cause AKI, it can lead to a KFT derangement. So that's why nowadays we prefer to use trientine. Trientine is relatively a nephro-safer drug, means it's safe for a kidney. So चौथा ड्रग कौन सा देते हैं? द फोर्थ ड्रग विच वी गिव इज दैट इज कॉल्ड टेट्राथायोमोलिब्डेट. टेट्राथायोमोलिब्डेट. And this is like what Harrison says, it is emerging DOC. It's a future drug of choice, right? So it's a future drug. So these are the four options. Even these all three question came. अगला क्वेश्चन अगर पूछेंगे that will be tetrathiomolebrate. So coming to C, trientine देते हैं, yes. कैल्शियम देते हैं, no. पेंसिलामिन देते हैं, yes. जिंक देते हैं, yes. So which is not given us, so answer will be yes, calcium. Am I clear? आगे चले. Okay, coming to next question, what we have? Try to answer. A 52-year-old female present with dyspnea. First, try to make a diagnosis of this case. So, see, you can see 52-year-old. Then what we have dyspnea, shortness of breath. General physical examination revealed deformity of hand. So, deformity पहले देख लो, हाथ में कुछ दिख रहा है. What deformity you can see? You can see just shiny fingers, right? So, we can see shiny fingers and some folds are missing. You can see few redness in the fingers. आगे देखते हैं. Then you can see there is restriction in movement of small joint. Restriction in movement of small joint and loss of wrinkle lines on the facial skin. Skin के facial के wrinkles line loss हो रही है. HRCT of thorax shows diffuse subpleural symmetric ground glass opacity of the lung. Following histopathology finding is likely to be seen in lung biopsy of this patient. तो पहले मुझे बताओ what could be the diagnosis. Okay, so what diagnosis you can see here? You can notice like this is a patient who is having a shiny skin. Then you can see the facial appearance. You can see loss of wrinkles lines on the facial skin. That is again a feature that we see in a patient with scleroderma. So diagnosis for this case will be scleroderma. And they are asking you like what is the finding? You will see, so understand this. In scleroderma what we see a homogeneous, it's like it will lead to ILD. ILD means interstitial lung disease, and in most cases the cause of death will be respiratory failure, that is due to pulmonary artery hypertension, right? So what we see here, we see homogeneous interstitial involvement because this will lead to ILD. ILD is interstitial lung disease, and ultimately patient will develop PAH. PAH is pulmonary artery hypertension और respiratory failure से death हो जाती है. Is it clear? So what you will see like there will be homogeneous interstitial involvement. Clear? वॉइस नॉर्मल है. किस का सही हुआ है? आगे चलते हैं फिर. कमिंग टू नेक्स्ट वन, ट्राई टू आंसर. पहले कुछ से आंसर ट्राई उसको कोशिश करो. फीमेल पेशेंट इज हैविंग फीवर फॉर पास्ट 3 days. 3 दिन से फीवर है. कैन नॉट टच नेक टू चेस्ट. नेक टू चेस्ट मीन्स गर्दन को फ्लेक्स नहीं कर पा रही. तो व्हाट इज दिस? दिस इज लाइक सजेस्टिव ऑफ नेक रिजिडिटी. दिस इज सजेस्टिव ऑफ नेक रिजिडिटी. तो पेशेंट के नेक में रिजिडिटी है. CSF फाइट है. सेल्स न्यूट्रोफिल्स. Cells neutrophils, so understand this. Cells are neutrophils, so what you can see, अगर neutrophils हैं तो viral meningitis is ruled out. CSF sugar is 15. अब इसको समझो. Normal CSF sugar is 2/3 of blood sugar. So if like suppose if my body right now my blood sugar is 100, तो मेरे CSF का sugar कितना होगा? 2/3 of 100 is 66.66. So normal CSF sugar is in the range of 60 to 80 milligram per deciliter. And remember, bacteria they love sugar. Bacteria fungus को sugar पसंद होती है, so they will eat all the sugar. Virus they don't like sugar, so that's why in bacterial meningitis sugar will be less. So that is the hint. Now see, neutrophils are there. Now see, TB meningitis में क्या होंगे? Neutrophils नहीं होंगे, lymphocytes होंगे. In virus also there will be lymphocytes. In fungal meningitis there can be neutrophils, but they will not be in this number. अब देखो, simple hint is there is neutrophils, sugar कम है. Protein pressure किसी भी meningitis में बढ़ेगा. So answer for this question will be bacterial. Fungal meningitis is rare, so there will be history of like HIV. So you can see like Cryptococcus neoformans is more common in patient with HIV. So उसको कैसे solve करना है आपको? Just try to understand this. Suppose if I want to make a simple drawing to give you an idea how this patient will come to you. So just try to understand this. So let me make a flow chart. So this is suppose bacterial, fungal, tubercular. So understand, bacterial, fungal, they more or less they resemble same. So let me say bacterial, tubercular meningitis and virus. How we can differentiate? How we can differentiate? Understand this. Protein pressure will increase in all. So अगर बात करूँ प्रोटीन की या प्रेशर की, ये सब में क्या होगा? This will increase in all meningitis. If you see bacterial meningitis, if you ask me what are the main cells, this will be PMNs. PMNs means polymorphoneutrophin. In tubercular it will be lymphocyte, viral it could be lymphocyte. Then third important thing is sugar, CSF, glucose or sugar. So bacteria they love sugar, so sugar को खा जाएंगे, क्या होगा? Sugar कम. TB is also bacteria, sugar कम. Virus, sugar will be normal. So this is something which you should remember. Now let us see. So based on this, sugar कम है, CSF sugar is less, cells are neutrophils, so this is bacterial. Now some student they are confusing कि सर bacteria होगा तो कुछ ना कुछ color देगा, ऐसा नहीं होता हमेशा. There are certain bacteria which will not give any color. Is it clear? Okay. There are few doubts, so let me see your doubt. As neutrophils are predominant, proteins is increased, so it is bacterial meningitis. If lymphocytes are predominant, then it could be viral. Yes, Smita, very good. This is the correct explanation. History से important नहीं होगा. Sherman Thori, you are asking about history. देखो history 3 दिन की history could also be in viral. It could be in malarial encephalitis also. Is it clear? So history is not that significant here. Sometimes it could be acute tuberculosis that can also present like this. So history is not important. You have to see on the findings, CSF findings. Am I clear? Okay. How to differentiate sarcoidosis and TB? In TB you will see caseating granuloma, in sarcoidosis you will see non-caseating. Now understand, अगर TB का patient होगा, there will be history of some contagious disease. For example, patient there will be history of aerosol spread. There will be history of use of contaminated things, or there will be like aerosol droplet, person sneezed or coughed. Sarcoidosis generally they will give you MCQ like black African female, and most of the report will be normal. तो जो मेन डिफरेंस हम करते हैं दैट इज बेस्ड ऑन सीरम कैल्शियम. सार्कोइडोसिस में कैल्शियम बढ़ेगा, टीबी में नहीं बढ़ता. सीरम कैल्शियम इज इंक्रीज इन सार्कोइडोसिस. एस एंजियोटेंसिन कन्वर्टिंग एंजाइम दैट इज इंक्रीज इन सार्कोइडोसिस. Is it clear? And sarcoidosis diagnosis we make after ruling out other disease. Sarcoidosis is common in MCQs but very rare in practice. Is it clear? तो practice में काफ़ी rare होता है, so we make a diagnosis after ruling out other. Right? Acute TB में lymphocytes ज़्यादा रहेगा. Yes, mainly it will be lymphocyte, but it can also be neutrophils. In acute tuberculosis, you will see both lymphocyte as well as neutrophils. Am I clear? Yes, this session will be in the YouTube. क्यों अभी कहाँ जाना है आदित्य? कहीं नहीं जाना. अभी पढ़ो पहले चुपचाप. 10 घंटे पढ़ना है. वो बुलाती है मगर जाने का नहीं. पढ़ ले भाई. Spot diagnosis, type of leukemia, you can see what you can see here. You can see gingival infiltrate, gum infiltration. Gum infiltration, and you can see if I zoom this, you can see this is like intracytoplasmic rod-like structure. This intracytoplasmic rod-like structure is called Oyer rods. We call this Oyer rods, and here you can see gum infiltration. Gum infiltration. Is it clear? Okay, Jack Sparrow. हाउ टू डिफ्रेंशिएट देन, डिफ्रेंशिएट कैसे करेंगे, किसको डिफ्रेंशिएट करना है, टीबी को और बैक्टीरिया को. सो अंडरस्टैंड दिस, वेन एवर वी डू ए लंबर पंक्चर, जैसे आपने लंबर पंक्चर किया, यू विल सेंड अ सैंपल. तो एक सैंपल जाता है दैट इज़ फॉर एडीए, एडिनोसिन डीएमिनेज. Adenosine deaminase is a test for tuberculosis. If that sample is positive, one more sample is going to microbiologist lab. One more sample is going to microbiology lab. So there they will tell you about culture. So उसमें culture में आ सकता है, right? Gram stain, AFB stain. So that is how we differentiate. Am I clear? Okay. So where we see, so I have given you the hint. Oil rods, where you will see gum infiltration. कहाँ मिलेगा बताओ? कहाँ पर गम इन्फिल्ट्रेशन होगा, कहाँ पर ऑयल रॉड्स होंगे? यस, इट इज सीन इन AML. इट इज सीन इन AML. है मैं क्लियर? आगे चलें. फॉलोइंग इज डिफाइंड एज पोस्चुरल हाइपोटेंशन. ओके ओके. डिक्रीज इन सिस्टोलिक ब्लड प्रेशर 20. सो एक्चुअल डेफिनेशन, लेट मी राइट योर डेफिनेशन फर्स्ट. पोस्चुरल हाइपोटेंशन वी डिफाइंड व्हेन सिस्टोलिक ब्लड प्रेशर will decrease by more than 20 and diastolic blood pressure decrease by more than 10 mmHg. It is within or after 3 minutes of standing. Is it clear? Within or after 3 minutes of standing. So understand this. Let us see the option. Decrease in 20 mmHg after 3 minutes. This is correct. Decrease in 10 systolic? No. Decrease in 20 systolic after 1 minute? No. 5 minutes, 1 minute, 2 minutes तो है नहीं. Answer is 3 minutes. So let's see the question in a more simple way. It is fall in systolic blood pressure by more than 20 mmHg and fall in diastolic by more than 10 within or 3 minutes of standing. That is called postural hypotension. My question is how you will treat this. क्या दवाई दोगे इसमें बताओ. फार्माकोलॉजी वैसे पढ़ी आज ज़्यादा. अब बताओ फार्माकोलॉजी क्या दवाई दोगे. What is the drug? What are the drugs that we use in postural hypotension? Come on, what we use midodrine. What else we use? We can use steroid, that is we can use hydrocort. Hydrocort का drawback होगा ये blood sugar भी बढ़ाएगा. This will also increase blood sugar as well as BP. So instead of this, what is preferred? We preferred fludrocortisone. So we can use hydrocortisone, fludrocortisone, and we have a new drug that is called doxydropa. So these are the drugs available for postural hypotension. Clear? आगे चलते हैं. ECG of a pregnant lady with history of preeclampsia is shown. Her vitals were stable. Next management is. So first look at the ECG and tell me what is the diagnosis. So what you can see in the ECG, बताओ क्या दिख रहा है. पुष्पेंद्र सिंह, देख तू टैमसोलोसिन दे दे भाई. टैमसोलोसिन से बीपी कम होगा कि बढ़ेगा. पुष्पेंद्र सिंह, डिलीट कर दिया आप कमेंट. टैमसोलोसिन से बीपी कम होगा या बढ़ेगा. बीपी बढ़ाना है, कम नहीं करना. एम आई क्लियर. टैमसोलोसिन बीपीएच में देंगे तो टैमसोलोसिन बीपी कम करेगा या बढ़ाएगा, मुझे ये बताओ. बी मैं समझ गया, मुझे ये तो बताओ टैमसोलोसिन वाले कहाँ गए. यही गलतियाँ एग्जाम में नहीं करनी. ओके, फर्स्ट मेक ट्राई टू टेल मी द डायग्नोसिस. व्हाट इज द डायग्नोसिस इन दिस केस. Yes, it's the case of TDP. Not Jack Sparrow. It's not VFib. It is TDP. You can see like more than 3 different type of QRS. We call this ribbon pattern. So it's a case of torsades de pontis. And torsades de pontis patient will have history of preeclampsia. So आप क्या दोगे? क्या दोगे आप? Tamsulosin. What you will give? You will give MgSO4. Sorry, torsades में क्या दोगे? MgSO4. Okay, DC shock we can use, but remember it's not given in this condition. Calcium we give whenever there is hypocalcemia. Amiodarone we can use as the like pharmacological cardioversion, but in some other condition. So answer is MgSO4. My question is, okay, माफ़ी कर देंगे, अब तुम बता दोगे MgSO4 के use. Tell me the uses of MgSO4. Come on guys. MgSO4 एक use मैं बता रहा हूँ, rest you will tell me. First use is TDP. TDP means torsades de pontis. Where else we use MgSO4? Come on. Gajendra, Naira, Prem, Anil, John, Ananya, Abhi, Anil, Meeta. Try to answer me. Where we use MgSO4? Magnesium sulfate और कहाँ देते हैं? फेंटानिल देखकर ही मैं बेहोश कर दूंगा अभी। पीएसवीटी में क्या देते हैं, एडेनोसिन। ओके, दैट इज फाइन। जैक स्पैरो, ट्राई टू आंसर। हेल्पर सिंड्रोम, ये कौन सा सिंड्रोम आया नया? हेल्प सिंड्रोम करना चाह रहे हो? टर्साडिस दे पॉन्टिस, देखो अब जो आ रहा है सब बकवास करे जा रहे हो। नीजर जो पता है उतना उतना नहीं पूछा, मेरे को ये बताओ NbSO4 का लॉजिक, यूज लॉजिक। MgSO4 क्या है? मैग्नीशियम। सो हाइपोमैग्नीसीमिया में नहीं दोगे लॉजिक? हाइपोमैग्नीसीमिया, मैग्नीशियम कम होगा, देंगे, सिंपल। हेल्प सिंड्रोम, न्यूरोप्रोटेक्शन पे एक्लेम्शिया, वो देखो वो ट्रायल की बात है, बट अगेन दैट इज नॉट बेसिकली न्यूरोप्रोटेक्शन, दैट इज गिवन फॉर व्हाट? दैट इज गिवन टू प्रिवेंट टॉर्साइडिस डिपॉन्टिस। यस, वेरी गुड। क्रोनिक प्रोक्रास्टिनेटर, जैसा नाम वैसा जवाब। यस, वेरी गुड, दैट इज स्टेटस अस्थमाटिकस। इट इज गिवन इन refractory cases, or I can say sometime refractory severe asthma, we use MgSO4. और बताओ कहाँ देते हैं? Where else we use MgSO4? Antidote of calcium gluconate is MgSO4. और कहाँ देंगे MgSO4 बताओ? It is used in many poisoning. बहुत सारी पॉइजनिंग में इसका यूज़ करते हैं, राइट? वी गिव MgSO4 बिकॉज it's have some like protective as well as like absorbent action. Is it clear? ये तुम इलेक्ट्रोलाइट में कंफ्यूज हो गए। हाइपर मैग्नीसीमिया में देते हैं, मैग्नीशीमिया में देंगे कैल्शियम ग्लूकोनेट। इज इट क्लियर? हाइपर कैल्सीमिया में नहीं देंगे मिता। एम आई क्लियर? कैल्शियम ग्लूकोनेट का एंटीडोट नहीं है ये। ओके, कमिंग टू नेक्स्ट, ड्रग ऑफ चॉइस फॉर ट्रीटमेंट ऑफ रोमैटिक कोरिया। बताओ, वेयर वी यूज रोमैटिक कोरिया। रोमैटिक कोरिया का ड्रग ऑफ चॉइस बताओ। यस, वेयर वी यूज, यस दैट इज दिस इज करेक्ट, ये सही बताया किसी ने, Praveen Pratap Singh. We use this in treatment of eclampsia. We use basically this in eclampsia. Okay, drug of choice for treatment of rheumatic chorea. Diazepam. Diazepam देंगे rheumatic chorea में? No, diazepam. This is benzodiazepine. Risperidone is antipsychotic. Haloperidol is also antipsychotic. These two are typical antipsychotic. So drug of choice is sodium valproate. Is it clear? Sodium valproate. So suppose you are having a patient with rheumatic chorea. Rheumatic chorea, सबसे पहले क्या दवाई दोगे इसके अंदर? We will give valproate. If it is not working, there is no improvement with valproate. Valproate से काम नहीं हुआ तो क्या दोगे? Then we give haloperidol. Then we give haloperidol. Right? Suppose there is no improvement, then we can try benzodiazepine. And again there is no improvement, then what we label this as refractory chorea. So this could be an expected question, refractory chorea, अब क्या दोगे बताओ? जैक स्पैरो, दीपेंद्र, प्रेम सिंह, बताओ what you will give in refractory chorea. Refractory chorea means that is not responding to first line drugs of like anticonvulsant like valproate, haloperidol. What you will give now? Then what we give, remember, then we give IVIG. इसको आपको याद रखना है. IV immunoglobulins are given in case of refractory chorea. Is it clear? IVIG. In refractory chorea, we give IVIG, intravenous immunoglobulin. Okay, आगे चलते हैं. बताओ, a 60-year-old female patient has left-sided weakness since 1 hour and left-sided facial weakness with BP 160/100. So first hint in the MCQ is this left-sided weakness. BP 160/100, CT scan is normal. So these are 3 hints in the question. Try to make a diagnosis. What is your diagnosis? बताओ diagnose बताओ. Left sided weakness, understand this. कोई भी stroke का patient होगा, if there is any patient with stroke, how this will present to you? This will present to you with either muteness, sudden onset speech loss, or hemiplegia. Am I right? तो patient कैसे आएगा? So there is hemiplegia, left side weakness, right? Then you can see since 1 hour. So time is money. Very, very important. The most important thing in stroke management is time. Since 1 hour, BP 160/100, CT scan is normal. What is the next best step? So let's see. Now understand this. So it could be like a patient is having stroke. So first thing, whenever you have a patient with stroke, so आप क्या कराओगे? You will go do a CT scan. आपको एक CT scan कराना है. अब CT scan, the purpose of doing CT scan is to rule out hemorrhagic stroke. So CT scan, either if there is a hemorrhage, I am writing in short, or it could be ischemia, that is infarct, or we call it infarct or ischemic stroke. So understand this, sometimes CT can be normal. So if it is a normal CT, or it is like I can say a blackishness, this will look white in hemorrhage, bleed will look white in CT scan. अगर नॉर्मल आ रहा है इसका मतलब पेशेंट टाइम पे आ गया. इट मीन्स पेशेंट इज कमिंग ऑन टाइम. एंड व्हाट इज द टाइम? द टाइम इज 4.5 आवर्स. वेरी गुड. बस रिमेंबर इट्स नॉट 4 आवर्स, इट्स 4.5 आवर्स. दिस 4.5 आवर्स इज द विंडो पीरियड. सो पेशेंट का देखो बीपी ठीक है, सीटी स्कैन नॉर्मल है. इफ सीटी स्कैन इज नॉर्मल इट मीन्स वी हैव रूल्ड आउट हेमोरेज. सो व्हाट वी डू, वी शुड गो फॉर थ्रोम्बोलाइसिस. समझ आया? सो व्हाट इज द पर्पस ऑफ डूइंग थ्रोम्बोलाइसिस? अंडरस्टैंड दिस. अगर पेशेंट 4.5 घंटे के अंदर आ रहा है, सो लेट्स द अदर ऑप्शन, नो इंटरवेंशन नीडेड. मैनेजमेंट बीपी अलोन, बीपी इससे ज़्यादा कम नहीं करना है. दिस इज द टारगेट बीपी विच इज अचीव्ड. गिव लोडिंग डोज ऑफ एस्पिरिन एंड क्लोप्रोजल. व्हाट वी गिव, वी शुड स्टार्ट थ्रोम्बोलाइसिस एज सून एज पॉसिबल बिकॉज पेशेंट इज कमिंग टू यू इन द विंडो पीरियड. यही 4.5 घंटे के बाद आता, देन वी हैव ओनली वन ऑप्शन, दैट इज मैकेनिकल थ्रोम्बेक्टोमी. तो आंसर इज ए, स्टार्ट थ्रोम्बोलाइसिस. क्लियर? ओके, ये क्वेश्चन का सही करो फटाफट. Try to answer. A male came to emergency room after car accident, had dyspnea, chest pain with ecchymosis on the anterior chest wall. सांस फूल रही. On examination, pulse is 120 means tachycardia, BP is 80/50 means BP is low. Hypotension. Breath sounds were decreased on left side. JBV was raised and tympanic node was present on percussion. What is your diagnosis? अनिल सोनी, इफ पेशेंट 7 to 8 आवर में आए तो दुआ करो. दैट इज ऑब्जर्वेशन. वी विल गिव सिम्टोमैटिक ट्रीटमेंट. इज इट क्लियर? इन WPW सिंड्रोम, सपोज इफ दे आस्क यू लाइक अ केस ऑफ WPW सिंड्रोम अगर पूछा गया है, वोल्फ पार्किंसन वाइट सिंड्रोम, दैट इज पेशेंट इज सिक, उसका बीपी कम है, देन व्हाट वी गिव IV प्रोकेनामाइड. इन स्टेबल केसेस व्हाट वी रिकमेंड फ्लेकेनाइड. इज इट क्लियर? अगर पेशेंट सिक है, प्रोकेनामाइड. DOC इज प्रोकेनामाइड. इज इट क्लियर? बस यहीं तो फंसा दिया मैंने तुम्हें. जैक स्पैरो, स्पैरो इज इन माई नेस्ट नाउ. फंस गए. बेकस्ट्राइड, किस किस को दिखा बेकस्ट्राइड? व्हाट इज बेकस्ट्राइड? लेट अस डिस्कस व्हाट इज बेकस्ट्राइड. द सेम मिस्टेक यू शुड नॉट डू इन एग्जाम. ओके, बेकस्ट्राइड क्या होता है? व्हाट इज बेकस्ट्राइड? देयर इज, बताओ तो सही क्या होता है बेकस्ट्राइड? देयर इज इंक्रीज JVP. एम आई राइट? और बताओ क्या होता है बेकस्ट्राइड? हाइपोटेंशन. तो BP कम है, हाइपोटेंशन, JVP इज रेस्ड. व्हाट इज थर्ड कंपोनेंट ऑफ बेकस्ट्राइड? व्हाट इज थर्ड कंपोनेंट ऑफ बेकस्ट्राइड? बताओ बताओ, थर्ड कंपोनेंट ऑफ बेकस्ट्राइड. मफल्ड हर्ट साउंड. muffled heart sound. muffled means diminished. muffled का मतलब होता है धीमी आवाज. am I right? okay, now see where you can see decrease heart sound. कहीं लिखा हुआ है? कहीं लिखा हुआ है muffled heart sound? जैक स्पैरो, फेंटानिल. ब्रेथ साउंड दिया है बच्चों, ब्रेथ साउंड, हार्ट साउंड नहीं. देयर इज अ डिफरेंस बिटवीन ब्रेथ साउंड. समझ आई बात? नहीं आई? गलती हो गई ना. सो ट्रायड ही नहीं दिया पहली बात तो. इट इज नॉट ट्रायड नहीं दिया. एंड यू कैन नोटिस टिम्पैनिक नोट. टिम्पैनिक नोट मीन्स आवाज आ रही है छाती में से, हवा भरी है. whenever there is air, then only you will get tympanic note. So answer for this question will be tension pneumothorax. Am I clear? So कहाँ फंस गए हम? दो ऑप्शन दिखे ट्रायड के, तीसरा अपने मन से बना लिया जल्दबाजी में. सो दिस इज लाइक अ मिस्टेक विच इज बिकॉज ऑफ सॉल्विंग एमसीक्यू इन अ हरी. सो अपनी गलती होनी चाहिए. जस्ट सी दिस क्वेश्चन केयरफुली. इट्स अ वेरी गुड क्वेश्चन. इन एग्जाम यू कैन नोटिस ब्रेथ साउंड वेयर डिक्रीज, नॉट हार्ट साउंड. इट्स नॉट मफलिंग. एम आई क्लियर? ओके. 17 क्वेश्चन. बताओ. A patient came to emergency room with headache that he described as worst headache in his life. Okay, diagnosis is clear. So most of you are knowing the diagnosis. I hope सबको पता है diagnosis क्या होगा. This is the case of SAH, subarachnoid hemorrhage. Subarachnoid hemorrhage. What is the next best step? बताओ. Nitin, John, Fentanyl, Fahim Ahmed, Jack Sparrow, try to answer what is the diagnosis. Next best step, diagnose SH. बताओ. Answer CT brain. Oh, understand this. रजिया फिर से फंस गई. Next best test, investigation of choice, best test for SAH is lumbar puncture. तो क्वेश्चन क्या पूछा है? नेक्स्ट बेस्ट स्टेप. Next best step. So best means investigation of choice for subarachnoid hemorrhage is lumbar puncture. So answer is lumbar puncture. समझ आया? Same question if I ask you, suppose if I remove this word, if I remove this statement, what is the next step? If I ask you this much only, then answer will become CT brain. Am I clear? अरे MRI वालों रुक जाओ. दीपेंद्र चहल एंडोवॉस का क्लिपिंग ट्रीटमेंट पूछा ही नहीं है. बेस्ट टेस्ट इज LP. नेक्स्ट टेस्ट इज नॉन कंट्रास्ट CT, NCCT ब्रेन. इज इट क्लियर? सो रीड द क्वेश्चन केयरफुली. कितने लोगों का सही हुआ है ये क्वेश्चन? सही बताना. हाउ मेनी ऑफ यू मार्क द करेक्ट आंसर? अरे अभी भी CT is next test. Best test is lumbar puncture. Okay, try to answer this one. बताओ इसको. ओके, इन क्वेश्चन से घबराना नहीं है. जानबूझ के मैंने फंसाया है जिससे तुम एग्जाम में ना फंसो. ओके, नेक्स्ट. अनकॉन्शियस पेशेंट वॉज बॉट टू इमरजेंसी रूम फॉलोइंग इज फर्स्ट लाइन इन्वेस्टिगेशन टू डू. बताओ. एक बेहोश आदमी आया है. वाई बी सर? काली. वाई बी? बिकॉज बेस्ट टेस्ट पूछा है बेटा. बेस्ट टेस्ट इज lumbar puncture. How we diagnose in SAH? What we see xanthochromic CSF, right? You will see with a blood, I can say a red CSF with yellow tint. Is it clear? तो बेस्ट टेस्ट क्या होता है? लंबर पंक्चर होता है. इसलिए आंसर इज लंबर पंक्चर. इफ आई आस्क यू नेक्स्ट टेस्ट, देन आंसर विल बी CT स्कैन. ओके, देखो लॉजिक से सोचो. एक बेहोश आदमी, अनकॉन्शियस पेशेंट कमिंग टू इमरजेंसी रूम. फॉलोइंग इज नॉट फर्स्ट लाइन इन्वेस्टिगेशन टू डू. आप क्या नहीं करोगे? सो जस्ट रिमेंबर, लाइक वेन एवर अ पर्सन इज कमिंग टू इमरजेंसी रूम, देर आर 5 वाइटल्स दैट वी शुड चेक. वॉट आर दीज 5 वाइटल्स? आपको ये 5 वाइटल्स पे काम करना है. दैट इज लाइक अ प्रोटोकॉल फॉर इमरजेंसी पेशेंट इन कैजुअलिटी. व्हाट वी डू? सो वी चेक फॉर पल्स रेट, दैट इज रिफ्लेक्शन ऑफ योर हार्ट रेट. सो पल्स रेट और हार्ट रेट देखनी है आपको. सेकेंड थिंग इज वी विल चेक फॉर BP. थर्ड थिंग वी चेक फॉर SpO2, saturation pressure of oxygen. Fourth, we check for temperature, that is body temperature. So आपने देखा होगा इमरजेंसी रूम में पेशेंट आया, BP चेक करते हैं, पल्स, SpO2, टेम्परेचर. एंड फिफ्थ, व्हाट इज फिफ्थ वन? फिल इन द ब्लैंक प्लीज. बताओ. फिफ्थ इज व्हाट? RBS, random blood sugar, because sugar is diabetes is very common. So these are 5 vitals that we should check. If suppose like you are seeing the patient reflex, patient is having history of I can say sudden onset hemiplegia, in that case we will also do CT scan. So random blood sugar is a part, yes, that we do. CT scan do we do? अगर आपको लग रहा है patient clinically is having symptom of stroke, then we'll definitely order CT scan. Now coming to 2 points B and C. अब इनमें से आपको चूज करना है. इमरजेंसी रूम में लंबर पंक्चर और EEG क्या नहीं करेंगे? ट्राई टू आंसर दिस, अंडरस्टैंड दिस. EEG is generally done in neurology department or sometime in where it's not available. We do this in physiology department. And lumbar puncture, if you see lumbar puncture, it's done in like with the physician, like in medicine department. So lumbar puncture से पहले we rule out a raised ICP. कहीं पेशेंट को पैपिलेडिमा तो नहीं है, ICP तो नहीं raised. That's an absolute contraindication of doing lumbar puncture. EEG की there is no as such contraindication. So EEG we can also do. तो what they're asking, what you will not do, lumbar puncture. Lumbar puncture से पहले आपको पेशेंट का फंडस एग्जामिनेशन कराना है. Am I clear? वैसे EEG भी नहीं करते बट कर सकते हो. It's not a big deal. We can do. If we are suspecting अगर पेशेंट बेहोश हुआ है सीजर्स के साथ में, we want to know what is the type of seizure, we can do EEG also. Clear? तो again tricky question. आगे बताओ. Identify the instrument so you can clearly see this is what? This is a bone marrow. No, it's not bone marrow. Bone marrow के ऊपर T type का handle होगा. You can see bone marrow needle will be like this. It will be having a T-shaped screw. Then for liver biopsy, we have liver biopsy gun. Pleural tap needle will be small. So this is small, long needle. What we call this LP needle. It is lumbar puncture needle. Okay, patient started on anti-diabetic drug 5 months back. HbA1c reduce. Sugar कम हो गया. But patient complaint of vulval pruritus. What is that drug? So they are simply asking you like which drug can cause vulval pruritus, means it can lead to inflammation of the vulva. It can lead to like genital infection. So what is that drug? That is, come on, बताओ. कौन सा ड्रग कराएगा vulval pruritus? Which drug? बताओ. This is a drug that SGLT2 inhibitor, that is canagliflozin. If you ask me acarbose, this is alpha glucosidase inhibitor. This will cause bloating. It will lead to osmotic diarrhea. And this is contraindicated in patient with IBD. Gliclazide or glipizide, glimepiride, these are sulfonylureas. Sulfonylurea side effect is they will lead to hypoglycemia. And sitagliptin, this is a DPP4 inhibitor. Canagliflozin, this can lead to UTI. So it can lead to urogenital infection and sometimes it can lead to euglycemic ketoacidosis. Sitagliptin is gliptin, so in long term use only this will cause few side effects, like this can lead to pancreatitis. But as such there are no critical side effect with this drug. So answer is canagliflozin. Following is not a reversible cause of dementia. So understand this question, it's very simple. Yes, gangrene also. We can also see, yes, Dipinder, very good. 4 years gangrene, we can see. Flatulence, yes, we see via acarbose, that is good. Meta, gangrene means 4 years gangrene, you can also see with canagliflozin. Yes, black box notes रटे पड़े, तुमने सारे notes रट लिए. Black box warning sign किस में आती है? Thiazolidine diones में. तो बस फिर क्यों टेंशन लेना है? What can understand is reversible cause. Now understand, it's very simple. Reversible means जो बीमारी ठीक हो जाए. So dementia due to any deficiency, it could be mineral deficiency, vitamin deficiency, hormone deficiency, that is reversible. Is it clear? So deficiency dementia is reversible, and dementia due to neurodegeneration, this is irreversible. समझ आया? अगर कोई डेफिशिएंसी से हो रहा है उसको आप ठीक कर सकते हो, राइट? तो डेफिशिएंसी और अ कंडीशन विच इज क्यूरेबल, दैट विल लीड टू रिवर्सिबल डिमेंशिया. सो लेट अस स्टडी वन बाय वन टू सी दिस. Hypothyroidism, patients having dementia, you will give T4, right? You will give levothyroxine, तो dementia ठीक हो जाएगा. Deficiency state. NPH, normal pressure hydrocephalus. This is normal pressure hydrocephalus. This is a condition like when you do shunting procedure or do some surgery, ठीक हो जाएगा. Again corrected cause. Vitamin B12 deficiency, आप B12 दोगे ठीक हो जाएगा. Lewy body dementia is an example of neurodegenerative disease. So in short, I can tell you like Alzheimer disease, Parkinson disease, dementia with Lewy bodies, Huntington disease, Creutzfeldt-Jakob disease. These are neurodegenerative condition. इनका dementia कभी ठीक नहीं होगा. Is it clear? दिसंबर में एग्जाम होगा, मेरे 165 मार्क्स आए हैं, दिसंबर में एग्ज़ाम होगा, लेकिन तुम्हें अभी क्लियर करना है, इसलिए अभी क्लियर करना है। ओके, 57 ईयर ओल्ड प्रेजेंट टू इमरजेंसी रूम विथ हेमीप्लेजिया 8 hours प्रायर। अब देखो उसको, अंडरस्टैंड दिस क्वेश्चन, ट्राई टू अंडरस्टैंड अगेन वन मोर क्वेश्चन ऑन स्ट्रोक। Yes, frontotemporal dementia, Alzheimer, Lewy body dementia, pick disease. These are irreversible. Very good. सर इतने सिंपल क्वेश्चन तो नहीं आते हैं एग्जाम में, ये सिंपल नहीं है बेटा, तुमने पढ़ लिया इसलिए तुम्हारा सही हो रहे हैं, सिंपल नहीं है क्वेश्चन, दीज आर नॉट सिंपल क्वेश्चन। और वन थिंग आई कैन अश्योर यू, एग्जाम में क्वेश्चन इससे सिंपल आते हैं। इज क्लियर? Okay, now see, male 57-year-old male present to emergency room with hemiplegia 8 hours prior to consult. Hemiplegia 8 घंटे हो गया, तो it means we have crossed the window period, right? Window period is gone. So window period कौन, दो thrombolysis तो नहीं करोगे, TPS tissue plasminogen activator, that's alteplase, तो thrombolysis अब नहीं करोगे। BP is 192, understand, BP आपको कब कम करना है, when BP is more than 220. Only then you have to decrease the BP. So anti-hypertensive drug you will not give. Stroke का patient है, BP you will, anti-hypertensive you will give when it's more than 220 and window period is 4.5 hours. So यहाँ पे क्या लिखा हुआ, 8 घंटे। तो क्या आंसर होगा इसका, कुछ नहीं करना, observation, very very important. I know many of you have marked the answer labetalol, but remember BP when it should be decreased when it is more than 220. Otherwise BP will automatically come down. Chronic liver disease patient present to OPD. Ascitic fluid examination will neutrophils 500. So understand, when neutrophils count are more than 250 and total WBCs count are more than 500 in ascitic fluid. Neutrophils 250 से ज़्यादा, WBC 500 से ज़्यादा. In ascitic fluid, if you see this thing, what we call this SBP. SBP means spontaneous bacterial peritonitis. So this, it's the case of SBP. So SBP, how you will manage, what we give, the drug of choice is IV cefotaxime. And to prevent this, so this is for treatment. And for prophylaxis, what we give norfloxacin. अब देखो cefotaxime ऑप्शन में नहीं दिया है, but they have given ceftriaxone. So that is again a third generation cephalosporin. So now understand, in this question neutrophil is given 500. यहाँ तो neutrophils is 500 ज़्यादा दे दिए. It means it's a short. Normal what happened? WBCs are more than 500 and out of this 250, more than 250 is neutrophils. Here in this question already neutrophils are given more than 500. Is it clear? Okay, neutrophils more than 250, WBC more than 5. This you have to remember. Yes, this you have to remember. ये आपको याद रखना. It's a case of SBP, spontaneous, and they have asked this question next time. This could be expected question for prophylaxis. What we give? Remember, norfloxacin. Okay, ये question पिछले 5 बार से आ रहा है, and again expected question in this attempt. Okay, which bacteria causes more SBP? Pushpendra, most common cause of SBP is E. coli. SBP का most common bacteria that can cause SBP is E. coli. This you have to remember. E. coli. Clear? Okay, try to answer. Diabetic patient is brought with complaint of vomiting and abdominal pain. Examination patient to have hyperventilation, hypotension. Hyperventilation. Blood sugar is 320. Ketones are present. So clear cut. You can see patient hyperventilate कर रहा है, hypotension में है. What we call this Kussmaul breathing. Patient is having Kussmaul breathing. So first hint I am getting here, Kussmaul breathing. Then you can see blood glucose बढ़ा हुआ है, ketone positive है, so diagnosis will be DKA. It's a case of DKA. So what they ask you in DKA, what you will give? What is next step? So what is next step in DKA? क्या हम देंगे सबसे पहले? Insulin, soda bicarb, blood ketone दोबारा check कर लो? No. Answer is IV fluid. So remember, the first thing that we do in DKA is first you have to give IV fluid. After this you have to give insulin. Am I clear? So first line, सबसे पहले क्या देना? IV fluid. Is it clear? So first thing is you have to give IV fluid. Okay, coming to next, 70-year-old man with history of diabetes mellitus and hypertension. Then what is happening? On regular medication, but then with history of progressive worsening dyspnea. On examination, there is elevated JVP. JVP बढ़ा हुआ है. Positive hepatojugular reflex. crackles at the lung base, hepatomegaly, ascites, pedal edema. What is your provisional diagnosis? क्या है बताओ ये? What is your diagnosis? So just try to understand this. Is it hypertrophic cardiomyopathy? Okay, there are two things. First is symptom and sign. Symptom means what patient complains, sign means what doctor observe. So suppose you are having a patient who is having symptom like there is shortness of breath, there is fatigue. Sometimes the shortness of breath is more severe, that patients are waking from the bed. इसको बोलते हैं PND, paroxysmal nocturnal dyspnea. So patients are having shortness of breath, there is fatigue, there is paroxysmal nocturnal dyspnea. Then you can notice like this patient, what else he is having? He is having low blood pressure, hypotension. If you see sign, so what sign you will see? Sign means the patient will have edema. If you see, there will be S3, S4, we call them gallop rhythm, S3, S4. On auscultation there will be creps. On auscultation there will be creps. Then you can see like this hypotension can be both sign and symptom. Similarly, edema can also be both in sign and symptom. और क्या होगा? You can see like patient will have ascites. There will be raised JVP. So ascites, JVP increase is seen when there is more right side heart involvement, and there can be a tender hepatomegaly. Tender hepatomegaly. There will be like a hard liver. We call this tender liver or tender hepatomegaly. So इनमें से कोई दो sign, कोई दो symptom, plus a positive biomarkers like anti-proBNP, then we make a diagnosis of heart failure. So let's see. देखो एक बार dyspnea दिया हुआ है, that is shortness of breath, elevated JVP, JVP पड़ा हुआ है, positive hepatojugular reflex, crackles means creps, hepatomegaly is given, ascites भी है, pedal edema भी है. So edema can be considered both sign as well as symptom. So this is a classical case of heart failure. And what is the marker for heart failure? We have anti-proBNP. Anti-proBNP is a marker for heart failure. Am I clear? Coming to next question. A middle-aged man present to emergency room with severe pain and swelling as shown. And then you can notice he had consumed 2 bottles of beer few hours before. Following drug is not used in management for this patient. So understand. Patient ने शराब ली है. So which type of, I can say, disease occur due to precipitation by alcohol? शराब पीने से कौन सी अटैक होता है? That's called gout. So alcohol can precipitate the attack of gout. So it's a case of gout, and it's a case of acute gout. It's a case of acute gout. So in simple language, question they're asking is which drug is not used in acute gout. Is it clear? So in acute gout, understand this. The main modality of treatment is आपको start क्या करना है? You have to start with NSAID. So NSAID means indomethacin. Question पूछा है not used. So first thing you have to give is indomethacin. Indomethacin the control नहीं हुआ, then we can use steroid. Then we can use colchicine. Allopurinol is given in chronic gout. Am I clear? Allopurinol chronic gout में देंगे. It is a case of acute gouty attack. So I can say acute gouty attack. अगर भूल जाओ तो याद रखना, this is acute gout, this is chronic gout. So understand this. In acute gout, what we give NSAID, but we also give colchicine. And in chronic gout, what we give allopurinol. So कैसे याद करना है इसको? How to remember? Look at the screen carefully. A to C, acute colchicine. C to A, chronic allopurinol. Simple. Acute colchicine, chronic allopurinol. A to C, C to A. A to C, C to A. Complete absence of dystrophin, that is called Duchenne muscular dystrophy. Just remember this mnemonic. D4, don't make dystrophin. Bad quality dystrophin. Don't make dystrophin, bad quality dystrophin. So understand. D4, Duchenne. So Duchenne muscular dystrophy is a condition where there is no dystrophin at all. And B for bad quality means B for Baker's. Baker's having a bad quality dystrophin. And always remember, something is better than nothing. Am I clear? यहाँ कुछ तो है. So Baker's is considered a milder variant. and Duchenne is considered a severe variant. Yes, both will have Gower sign. In chronic febuxostat or allopurinol, yes, these all can be given, just remember, but we start with allopurinol. Febuxostat we give whenever there is a patient who is having deranged KFT. अगर किसी का AKI हो रहा है, CKD हो रहा है, यूरिया क्रिएटिनिन बढ़ा हुआ है, then what we give? Then we give febuxostat. Probenecid we give in very rare condition, आजकल उसको यूज़ नहीं करते. Rasburicase we give in refractory gout and in gout due to tumor lysis syndrome. So this is about the questions. So remember, 10 days, 10 hours, nothing less, nothing more, nothing new. That is your strategy for the next 10 days. जितना है उतना पढ़ना है, take a proper sleep, take a proper diet और अच्छे से एग्जाम देना है. Is it clear? The simple rule, 10 hours daily for 10 more days. And always remember, you can, you will. With this, we'll conclude the session. Thank you so much. Keep working hard. Bye-bye.
Okay, so hi, evening friends, evening everybody bache, evening everybody, and let's start with pathology. Now, इससे पहले we start with pathology, सबसे पहले मुझे ये बताओ पैथ का पेपर कैसा था firstly, and we had about I think 18 to 19 questions in pathology, कितने attempt कर पाए firstly. Secondly, if just a sec, okay. Secondly, if you have not given the paper, बिल्कुल चिंता की ज़रूरत नहीं है. I'll be giving you sufficient time. Hi, नमस्ते पुष्पेंद्र, नमस्ते दोस्त. So I'll be giving you sufficient time with all the questions. I want कि end में everybody tell me कि मेरे कितने questions ठीक हुए, because this is the kind of paper we expect to come actually. And let us start with pathology. Now सबसे पहले फटाफट से आंसर देते जाना है. I agree. If you think कि paper was easy to comfortable, that means you are going to have a buffer and you are going to pass. So 18 questions हैं. Let us see करते जाएंगे. Starting with the first question, macrophages of the placenta are called as. देखो, do not confuse between macrophages and giant cells. Giant cells of the placenta. Giant cells of the placenta are syncytiotrophoblasts. Syncytium, that is, they join together to form a syncytiotrophoblasts. They are the giant cell. The macrophages are the Hofpire cells. हमें pregnancy से डर है. Hof है. Macrophages of placenta, Hofpire cells. Macrophages of the spleen. Spleen, littoral cells. Macrophages of the blood, monocytes. You already know that. Liver का question आपकी बार पूछा गया था. Macrophages of the liver, Kapha cells. You obviously know that. Next question. 20 a male with past history of upper respiratory tract infection. बच्चे ये जो 18 topics है ना, these are the most commonly asked 18 topics. So you have to be right in these. Kidney function test is deranged. Creatinine is elevated. Anti-GBM antibody is present. Most probable diagnosis. The minute you have presence of anti-GBM antibody, Goodpasture syndrome. It is type 2 hypersensitivity. MCD कब mark करेंगे? Most common nephrotic syndrome in children. Most common nephrotic syndrome in children is MCD.
जैसे ही हमारे पास हिस्ट्री आई है दैट अ चाइल्ड प्रेजेंटिंग टू योर ओपीडी विद हाइपोअल्बुमिnemia, edema, generalized edema and anasarca, diagnosis MCD, minimal change disease, electron microscopy shows diffuse effacement of foot processes of podocytes, वो MCD, versus most common nephritic syndrome in children, most common nephritic syndrome in children, PSGN, which is associated with post-streptococcal glomerulonephritis, streptococcal infection, 1 to 2 weeks after which there is development of kidney disease. It is associated with cola colored urine. ये हो गया PSGN, cola colored urine. Versus अगर malignancies के बाद हो रहा है nephrotic syndrome, that is MGN. Next question. Splenectomy is indicated in which hemolytic anemia? So सबसे पहले किस में इंट्रावास्कुलर हेमोलिसिस होते हैं, किस में एक्स्ट्रावास्कुलर? G6PD and sickle cell anemia, both of these have both extravascular and intravascular hemolysis, but more common is extravascular hemolysis in spleen of the patient. First point. लेकिन इनमें स्प्लीनेक्टमी नहीं करते. G6PD deficiency, it is a benign self-limiting disease. ये self-limiting है. Versus what is the classical history of G6PD deficiency? G6PD की classical history है बच्चे कि a patient took antimalarials, primaquinol sulfonamides, as a result of which it is associated with jaundice. That is G6PD. Sickle cell anemia में तो वैसे ही autosplenectomy हो रही है, so splenectomy is not indicated. PNH is intravascular hemolysis. So splenectomy is indicated in HS, hereditary spherocytosis, HS. Agreed. B नहीं दोस्त, B नहीं. The answer was D. Answer was D. अच्छा मुझे HS का inheritance pattern भी बता दो. Till the time you come to this question, tell me the inheritance pattern of hereditary spherocytosis. We write it as capital HS ना, autosomal dominant. Next question. Agreed. Jack Sparrow agreed. जब भी antimalarials, primaquine, sulfonamides, intake of fava beans की history हो, in that case we think of G6PD deficiency. Next, answer बच्चे. Answer ABCD. RBC casts are seen in. देखो, whenever you will get one question from urine examination, there is no doubt about it. RBC casts, they are seen in glomerulonephritis versus WBC casts, which are seen in pyelonephritis. Next, which are most commonly seen normally and are composed of TAM horsefall protein, that is hyaline casts. Hyaline casts. नहीं दोस्त, इस question में many of you went wrong. Answer is B. RBC casts, glomerulonephritis. Hyaline casts, most common and are associated with TAM horsefall protein. That is hyaline cast versus granular casts. Which are associated with ischemic renal diseases. Next question. Now this is a question that is always examiner's favorite, लेकिन there is a catch in this. तो इस question को ठीक से पढ़ के I want everybody to answer me. Elderly male, ABCD, answer बच्चे. Elderly male presented to OPD with multiple lytic lesions in the hip. So diagnosis is obvious, multiple myeloma. Serum calcium levels are increased. So CRAB features are also coming in. CRAB is calcium is increased, renal insufficiency, anemia, lytic lesions in the bone. So CRAB features be a multiple myeloma. Next, peripheral smear is given. Which of these will be seen intranuclearly? ABCD. Answer बच्चे, I'm waiting for your answer on this. देखो सबसे पहले have a look at this slide. What do we see here? Examiner has told you कि this is peripheral smear. RBCs are stacked upon each other. That is, it is associated with rouleau formation. What is stacking up of RBCs called as rouleau? It is associated with rouleau formation. As compared to an RBC, you see the presence of very large cells with abundant cytoplasm, eccentric nucleus. All these are the plasma cells, making this as multiple myeloma. Now, multiple myeloma में intranuclearly क्या नज़र आता है? देखो इसमें थोड़ा सा गड़बड़ हो गया. You were right with the diagnosis of multiple myeloma. It is of course not a flame cell. M band is seen on protein electrophoresis. Protein electrophoresis of multiple myeloma shows the presence of an monoclonal band, M band. Multiple myeloma has two bodies, Dutcher bodies and Russell bodies. DNA. Dutcher bodies are intranuclear versus Russell bodies which are intracytoplasmic in nature. So the answer to this question was C. This is an important point. Please have a good look. DNA. Dutcher bodies are intranuclear, Russell bodies are intracytoplasmic. Next question. कोई बात नहीं, हम लोगों का देखो आउट ऑफ 19 एक दो क्वेश्चंस तो गलत होंगे ही होंगे. दिस क्वेश्चन मेजॉरिटी ऑफ यू वेंट रॉन्ग, डजंट मैटर. नेक्स्ट क्वेश्चन, ABCD. Everybody बचे. Elderly male who is a known case of carcinoma urinary bladder now is presenting with features of glomerulonephritis. Which is the most common nephrotic syndrome associated with malignancies? You know this. Answer, MGN, membranous glomerulonephritis. Which is the one associated with HIV? FSGS. It is associated with poor prognosis. What is the special subtype of FSGS with HIV? I want you to answer this. Or it can even be asked as, which is the worst prognostic variant of FSGS? HIV के साथ है ना, patient went to have some fun, but his whole world collapsed around him. So collapsing glomerulopathy. Collapsing glomerulopathy is associated with HIV. Again, a prospective question. Don't ask me why, but I have a very strong suspicion कि अब की बार पूछा जा सकता है. HIV, FSGS, worst prognosis called as collapsing glomerulopathy. Patient went to have some fun, but his whole world collapsed around him. And malignancies के साथ कौन से है? MGN. Next question. 100% right answers. Patient died of MI, myocardial infarction, which is the stain used for gross diagnosis, ABCD. For making an early diagnosis on gross, early means it is diagnosed at 2 to 3 hours. We use TTC staining of the heart. TTC staining of the heart. Alizarin redis is the most specific stain for calcium. Most common, von Cosa. Most specific, alizarin redis. Methylene blue is for reticulocytes. It is a supravital stain for reticulocytes versus MT, Mason's trichrome, which is for collagen. Agreed, bache. Agreed. Next question. Adult female with headache. Radiology shows frontal dural based tumor. Examiner ने dural based tumor भी बता दिया. But doesn't matter. Think of it as you are sitting in the paper. CNS tumor has been asked. I always stress this. You always mark the most common. अच्छा, एक तो ABCD भी बता दो and tell me the answer to this also. Most common CNS tumor, and अब की बार गलत नहीं करना है. I mean, I love doing this when almost everybody is going right. So, most common CNS tumor? Metastasis. Metastasis. Most common primary CNS tumor? Meningioma. So have a good look at what the examiner is asking you. Firstly. Secondly, जैसे ही examiner ने CNS tumor बोला है, you will go for meningioma. That is, it shows semoma bodies with one leg. Next, your answer was right. Question का answer C ठीक था. But do not go wrong in this one also. That is what I wanted to impress upon. Next, neural tube defect have which pattern of inheritance? Now, the last face-to-face class that I took in LN, I have no idea why so many students were saying it as autosomal dominant in this. Nahi bache. Think of it as your crush said yes, you married her also, मतलब शिद्दत वाला प्यार था, ऐसे ही नहीं. And before pregnancy, which tablet is taken? Folic acid. 3 months before pregnancy, folic acid is taken to prevent the development of neural tube defects, that is spina bifida and anencephaly. It is multifactorial. Meeta bache, semoma bodies are also seen in meningioma. Meeta, this is for you. They are also seen in meningioma. Next question. Asha dekho. Again, I want you to tell me this ABCD. Everybody, you are going to have one RBC image, one question either from CNS tumors, thyroid, or ovarian tumors, one question from vasculitis. This is how every time the paper is made. So vasculitis is a topic जो हम लोगों को आना ही चाहिए. Child with lower abdominal pain, rashes, arthritis. Most probable diagnosis HSP, Hinox online purpura. Giant cell arthritis का क्या history है? Touch your forehead once and you will never forget it. Elderly with thick palpable temporal artery involvement. That is giant cell arthritis. temporal artery is involved. It is also associated with ophthalmitis. Takayasu. Tuk are the pulses. So Takayasu syndrome, pulseless disease. It is pulseless disease. These are large vessel vasculitis versus Kawasaki, which is a medium vessel vasculitis associated with coronary involvement. These are the vasculitis. Next question. Easy tha, mushkil nahi hai, but there was a slight googly in this. So ABCD, female with history of liver disease. Microscopically, the examiner has told you that hepatocytes have ground glass appearance. So agreed, Mita agreed. Pulseless, tuk are the pulses na Takayasu. So acha, which is the most common vessel affected in Takayasu? Left radial pulse is not there. So which is the most common vessel affected? Arch of aorta or the left subclavian. Upar wali vessel affected hai, so the left radial pulse is not there. Next question. Ground glass appearance. Ground glass, ABCD. Answer bache. Ground glass appearance is associated with hepatitis B virus. But point to be noted is chronic HPV. Very good. You did not confuse it with acute HPV. So this is what hepatocytes look like. They are large cells, abundant granular cytoplasm with presence of a nucleus. This is what hepatocytes look like. Diagnosis, till that time keep on telling me the diagnosis. Which is the abnormal cell? The center one. It is a small contracted apoptotic hepatocyte. Apoptosis of hepatocytes, that is called as Councilman bodies. Seen in acute hepatitis. Very important. Councilman body is acute hepatitis. Versus, look at all these cells. Large cells, abundant cytoplasm, granularity is lost. Ground glass hepatocytes, which is a feature of chronic hepatitis. And which chronic hepatitis? Chronic hepatitis B virus, chronic HPV. Next question, ABCD. Now, a middle-aged male presented with splenomegaly. TLC is very high and there is presence of all the cells, that is myeloblast, promyelocyte, myelocyte with basophilia. Diagnosis, CML. Diagnosis, chronic myeloid leukemia. Diagnosis, CML. Next, answer, which of the following will be true? BCR, ABL. Translocation 814 is seen in Burkitt's lymphoma. Burkitt's gene mutation, MIC. Which MIC? I want you to write me this. कौन सा MIC gene mutation is seen in Burkitt's? C-MIC, N-MIC या L-MIC? Firstly, बच्चे, MIC is a proton oncogene. Genes are of two types, na? Tumor suppressor gene and proton oncogene. C-MIC, Burkitt's lymphoma. N-MIC, neuroblastoma. Agreed. L-MIC, small cell carcinoma, lung. L-MIC, small cell carcinoma, lung. This is about MIC gene mutations. MIC is a proton oncogene. Translocation 1418, follicular lymphoma versus 1114, mantle cell lymphoma. 1114, mantle cell. Perfect. Agreed. Bache agreed. Gaucher cells are also present in CML. 814 Burkitt's. Perfect. Next question. ABCD. Asha, please tell me कि everybody that you are noting कितने questions अपने गलत हुए हैं. Last 3-4 minutes we are going to wrap up the questions. Do commit to the answers side by side while I am speaking. Last 4 minutes, 4 questions we are wrapping up. But please tell me in the end कि हमारे कितने questions ठीक हुए. Macrocytic anemia. देखो, which is the most common type of anemia seen in ACD? ACD is normocytic normochromic. Thalassemia is microcytic hypochromic. Any female with anemia, most common cause is iron deficiency anemia, followed by thalassemia. It is microcytic hypochromic. Acute blood loss is again normocytic normochromic. Liver diseases is macrocytic. Next, disease transmitted from grandmother to father, father to son. आंसर अभी तक 2 गलत हुए हैं, कोई बात नहीं. हम लोग ए और सी, प्रतीक नहीं बचे, 2 आंसर्स नहीं देने ना. ए और सी नहीं. द बेस्ट आंसर वाज लिवर डिजीज. नेक्स्ट, पुष्पिंदर दोस्त, लास्ट के 4 क्वेश्चंस भी देखते हैं. ओवरऑल 60. अच्छा, एक ना मुझे ओवरऑल भी बता दो, in the sense that tell me the answer to this question also, and I am sure that those of you who gave the paper, how many of you scored more than 60%? firstly, and that is option 1, more than 50%, option 2. मल्टीपल माइलोमा वाला थोड़ा सा ट्रिकी था. नहीं बच्चे, इस क्वेश्चन में भी ना मेनी ऑफ यू आर गोइंग रॉन्ग. इट इज़ नॉट वाई लिंक्ड. देखो, ग्रैंड मदर गेव विच क्रोमोजोम टू द फादर? शी गेव X chromosome, so it cannot be Y-linked. Father gave Y chromosome to the son, so it cannot be X-linked. It does not skip generations, autosomal dominant. Autosomal dominant. Next question. Cell responsible for type 1 hypersensitivity is, this is one of my favorite questions, which is the main cell of type 1 hypersensitivity? Mast cells. Mast cells followed by eosinophils, basophils and T cells. इसमें mast cell, eosinophil and basophil was not in the options. So answer to be marked was T cells. Answer was T cells. नहीं दोस्त, the best answer was 1. I guess इसमें भी थोड़ा सा गड़बड़ हुआ है. Which is the most potent cytokine or most potent activator of eosinophils? Interleukin 5 followed by interleukin 4. Easy to remember, A, B, C, D, E. E is the 5th alphabet, no? 5 followed by 4. Versus basophils, interleukin 3 followed by interleukin 4. Next question. Myasthenia gravis is which hypersensitivity? आंसर सही था, पढ़ने में गलती हो गई. यादव, आई नो, एक्चुअली दोस्त, इट विल, शुभम, इट विल हैपन मेनी टाइम्स. लेकिन हम लोगों को यही इंश्योर करना है कि silly mistakes will be happening in the paper. There is no doubt about it, but they are as less as possible. You guys know your stuff यार, but गलत को थोड़ा सा क्वेश्चन गलत पढ़ के जल्दबाजी में गलत मार्क नहीं करना. Next, answer. This was a recent question. Myasthenia gravis is which hypersensitivity? देखो, you very well know that type 2 hypersensitivity is antibody mediated hypersensitivity, and so is type 5. Type 5 hypersensitivity, there are only 2 examples. That is Graves' disease and myasthenia gravis. In दोनों में the best answer is type 5 if it is not given in the options, followed by type 2 hypersensitivity. Lastly, I guess this is the last question. Dystrophic calcification is seen in D for dystrophic, D for dead or damaged tissue. In dystrophic calcification, serum calcium is normal. Blood में calcium normal है. Still it goes and gets deposited in damaged tissue. So dystrophic calcification is seen in atherosclerosis. Multiple myeloma में तो as such graft features were seen now, so calcium was increased. Sarcoidosis is non-caseating granulomas with bilateral hilar lymphadenopathy. It is associated with secretion of vitamin D3 from granulomas. So बच्चे, इसमें also calcium is increased. In hyperparathyroidism, of course, calcium is increased. All these are examples of metastatic calcification. Dystrophic calcification, atherosclerosis. So this takes care of your pathology discussion. Needless to say, we are in this together. And I want you to tell me before I wrap up, last 10 seconds बचे, अपने कितने ठीक हुए out of 17? Quickly, फटाफट से write. I am very comfortable with more than or equal to 13 rights out of this 17, and I hope from the bottom of my heart, जो भी ठीक हो जो भी नहीं, कोई फर्क नहीं पड़ता. We have learnt from our mistakes, watch the further sessions, and one thing is certain, we will be passing in this FMGE exam. So on this positive note, let's wrap up pathology and start our next session. Thank you and take care.
Hello my dear friends, कैसे हो आप लोग? A very warm welcome to all of you in this CBOT session. Let's start with this first question. They have given a peripheral smear and they have not asked the disease. They have asked who is the transmitting agent for this disease. So the image shown here is of Maltese cross. This is Maltese cross, and this Maltese cross is something which is formed, I think, in which disease it is formed? I think you know, it is formed in Babesia or babesiosis, babesiosis. And Ixoid tick, which is also known as deer tick, it transmits two diseases. One of the disease is Lyme disease, which is caused by Borrelia burgdorferi. And this Lyme disease have bull's eye lesion, है ना? Bull's eye lesion को कहते हैं target lesion. ऐसा लगता है सांड की आंख, मतलब ना एकदम. This is bull's eye lesion. This type of lesion will be formed here. और इसको कहते हैं erythema chronicum migraines या target lesion. तो दूसरा इमेज बेस्ड क्वेश्चन इससे भी आ सकता है, erythema chronicum migraines. Good evening Mita, good evening Dr. Anil, Dr. Niaz Ahmed, Nitin bhai, hi, NK Sah, Assalamu alaikum bhai. A very warm welcome to all of you my friend. Or I think you people are enjoying the journey of last 10-day preparation. Whatever hard work you will do in your later life, you will remember this journey as one of the best journey of your life, and you will be happy remembering this hard work, because this is the time when you win over yourself. So keep doing the hard work and keep solving more and more PYQ every day, and you will rock. Okay. So this is target lesion of Lyme disease. Now, so do remember Ixoid tick or deer tick, it looks exactly like hard tick. And how will you differentiate a hard tick from a soft tick? Hard tick will have head visible. Soft tick head get covered in the back covering scutellum. So soft tick also have a small leg because the back covering cover it. Hard tick have long leg, head visible. And similar to hard tick, look Ixoid tick, deer tick, which transmit these two diseases, babesiosis with Maltese cross and Lyme disease with target lesion. Okay, I hope you will remember it. Now, a patient with cough was sputum AFP negative but chest X-ray was suggestive of TB. What should be the next step according to RNTCP? This was a direct repeat question from NEET and it was 2 times being asked already in NEET exam. So, of course, the answer is CBNAT test when 2 ZN smear we do first. And if both are negative, any one positive, we start treatment under lab confirmed TB. But if 2 ZN smear both are negative, then we go for CBNAT, cartridge based nucleic acid amplification test, which is also known as gene expert. But suppose आप किसी हिलालाला हो आदिवासी इलाके में, and in that tribal areas or peripheral areas, suppose CBNAT is not easy for people and they are not able to do it. In that case, CBNAT if not available, then what you can do is, if not available, then based on X-ray and clinical symptom, we can start the treatment under clinically confirmed TB. Okay, start ATT under clinically confirmed TB. So, clinically confirmed TB criteria is given only in case when patient cannot go for CBNAT. Otherwise, we will go for CBNAT, which is nucleic acid amplification test. Of course, cartridge based nucleic acid amplification test. And remember, CBNAT has one major advantage, that it detect TB bacilli but also detect rifampicin resistance at the same time. So by just one test we can know whether we have to start normal TB treatment or MDR treatment. Okay, do remember it. Yes, very good. Correct, Dr. Anil Soni, Rafiq Khan, Priti Rani, Nitin Bhati, all of you are right. Pasas, all of you are right. which RASes is shown in this image. So RAS based question is pretty common in PSM, microbiology, pediatrics, all, and derma again. 4 branches ask questions from RAS based thing. So RAS's concept should be clear. This is the RAS of definitely, what is this RAS? Measles or chickenpox or herpes zoster? Why not dengue RAS? Dengue RAS will be petechial RASes, small pinpoint RASes, pink dot will be there. So the chickenpox RASes, do remember CP is in chickenpox and chickenpox RASes are centripetal. So again there is CP and CP, and you can see CP, CP. The centripetal is chickenpox. So that's why chickenpox occur on trunk and body but do not occur on palm and sole. Second characteristic of chickenpox RAS is it is pleomorphic, which you can see here. If you look at the detail of this image, some RASes have ruptured, some have scaled form, some are new, like that. So they are centripetal on the trunk and they are pleomorphic. Plus, why we call chickenpox as chickenpox? Because just like beak of chicken, chickenpox come out from the skin. And this is the major difference between chickenpox and measles. Do remember, chickenpox, there was a doctor who have a poet inside it. He have written it like this, कि ऐसा लगता है जैसे गुलाब की पंखड़ियों पर ओस की बूंदें हों, dew drops on rose petal. This is the characteristic of chickenpox. It comes out. But when we look at measles RAS, first of all, they will give this hint that it start from back of hairline, then go to face. Do remember. Second point, measles RAS are in the skin surface. They do not come out and they are merged with each other. Okay. Third point is that measles RASes occur with cough, cold, coryza, conjunctivitis. So there will be water secretion coming from different part. But chickenpox RAS and rubella RAS, chickenpox and rubella, both RASes are without cough, cold, coryza. So there will be no secretion here. Okay. So whenever they give image based question from RAS, first look whether RASes are coming out or not. If coming out, it is centripetal. If not coming out, measles. Okay. And if they have given this hint that is start from back of hairline, then go to face, it is definitely measles. Okay, so this RAS is definitely chickenpox and you all were right. Now, next question is, in a population is BP is measured and then they are followed for next 20 years, and it is being found that people of low BP initially also found to have lower BP at older age. So if someone has low BP at initial, also have lower BP at initial age, or if someone has high BP initial, they also have high BP at older age. Okay. So this phenomena is known as tracking phenomena. Suppose we are writing BP with some people also have high BP later. So let's say BP we are comparing with age and we are starting with, let's say 20 year, 40, 30, 40, 50, 60, 70, 80. So if your BP is low at younger age, even at old age your BP will be low. If your BP is high at younger age, even at old age your BP will be high. So this is tracking phenomena. ऐसा लगता है कि BP इंसान का पीछा कर रही है ना? Or this is because mainly tracking phenomena is trying to tell us that we should start eating healthy from adolescent age, from early age, because once we are in habit of eating junk, we will continue that habit. So this is tracking phenomena, and in receiver operating curve, you can get another image based question, and that receiver operating curve will be something like this. This type of image will be receiver operating curve. It will have sensitivity on this side and 1 minus specificity here. This type of curve will be receiver operating. High risk strategy is something which we do in those people who are already diagnosed to have BP or who are at high risk for hypertension and diabetes. then we do testing in them and we focused on their exercise. That is high risk strategy, and high risk strategy is never better than whole population strategy, because if we focus on whole population, then we will even prevent the people from going into high risk. So population is better. Lesion showing below, being asked 3 times in MCI exam. What is this lesion? This lesion is honey crusted lesion of impetigo. Scabies lesion will have 2 hints. First, it will be in interdigital area or inguinal area. Second hint which they will give with scabies is other family member also have itching. So other family member also itching will also be there. And what is the drug of choice for scabies? Do tell me, my friend, what is the drug of choice? Herpes zoster, I think you know. Mostly herpes zoster occur in one dermatome. One dermatome का मतलब होता है स्किन का वो एरिया जो एक नर्व से सप्लाई हो, एक पेरिफेरल नर्व से सप्लाई हो. One patch of skin supplied by one peripheral nerve affected by herpes zoster. So sometimes you can find lesion just in the half face. है ना? That is herpes zoster. Herpes simplex lesion are like cold sores. ऐसे पानी भरे हुए दाने होंगे ओठों के कोने में, तो वो herpes simplex होगा, है ना? वो fluid filled vesicles on the corner of lips and all can be herpes simplex. And what is the drug of choice for scabies? The drug of choice for scabies is permethrin. Tell me? Yes, permethrin. 5% permethrin is the drug of choice which we give. Okay. Now, this rash, can you identify the rash of this child? Try to guess the rash of this child. One thing is sure, the rashes are not coming out from the skin surface. So it cannot be chicken pox. And you can see in this image, the child is opening the mouth to breathe. That means he had cough cold coryza conjunctivitis, then someone gave cetirizine and all those cough cold got dried up. So now he found it difficult to breathe, so he is opening the mouth to breathe. So that means this is a child with measles rash, because measles rashes are in the skin surface, you can see, and merge with each other, and they are with cough cold coryza conjunctivitis, and because of cough cold he is finding it difficult to breathe, opening the mouth to breathe also. So that is chicken pox. Vitamin K deficiency rashes will not be rashes, it can also be ecchymosis, bleeding patch, red patch. And do remember, milk is deficient in vitamin K. That is why we are giving vitamin K injection just at birth. Of course, vitamin D and vitamin C are very less in milk, but they are not deficient, they are very less. Vitamin K is very less. So vitamin K we can call almost deficient. In egg, vitamin C is deficient. Okay, so do remember, in milk vitamin D is there, it is written in part that in creamy part of milk, vitamin D amount is there in good amount. So remember, vitamin K is deficient, very common question. Now this rashes, can you identify? This is the rashes, pinpoint petechial rashes of dengue. This is dengue rashes. This is dengue rashes. And during recovery of dengue, a special type of rash will form, and that rash during recovery is known as island of white in sea of red. There will be red color thing, but on that there will be some white dots. So, लाल समुंदर में सफेद टापू, sea of red. This is seen during recovery. Next question was that a researcher wanted to prove the relationship between COPD and smoking. He collected patient record from government hospital and record of cigarette sale from finance and taxation department. This is an example of which this study design. So here, how to decide between study is the main question. And this question is simple, I hope you must have done it. But first thing which help us to decide which study is, you will try to know is there is one group or two group. Like in this question, there is only one group of COPD patients. There is no two group. And usually if there is one group, then it can be either cross-sectional or it can be ecological. In case of ecological, we do not ask question from any participant. We do not collect data from participant, we collect data directly from whole population. And after collecting data from whole population, we correlate population data with hospital data. Correlate hospital data with population data. Hospital data correlated with population data. And this is what you can see here. There is data of patient record from hospital. So this is hospital data of COPD, and they are correlating it with population data of sale of cigarette from taxation department. So whenever there is hospital data and population data, it is ecological study. For example, if they give the question that breast cancer more in US population with more McD store opened or Domino's store opened or with more fatty diet. So in this question again you can see fatty diet is based on whole America and breast cancer is coming from hospital. So it is hospital data correlated with population data. So this line also mean ecological study. But in cross-sectional study, we ask question from every participant. So cross-sectional study is prevalence study. So do remember, if there is one group and we are asking question from everyone, it is cross-sectional. That's why cross-sectional is prevalence. For example, if they give the example that in Gautam Nagar, a study is done where students are asked that are they feeling anxiety and what is the time they sleep. So they are trying to correlate sleeping, that the sleep deprivation is causing anxiety. And they are asking questions from every student of Gautam Nagar. So they are asking questions from every student, and there is only one group of students in Gautam Nagar like that. So that is a cross-sectional study because there is one group and question is asked from everyone about their present moment. It's not that do they have anxiety in the past, they are asking it about present moment. So do remember, one group, cross-sectional, ecological, cross-sectional, everyone, ecological, population data with hospital data. Now, if there is two group, in case of two group, the study can be cohort, case control or RCT. RCT, whenever they will give, they will use the word randomization or they will use the word that drug given to one group and compared with placebo, compared with old drug. So this is something which can easily be identified. There is no confusion in RCT, it's very simple. Main confusion is in case control and cohort. Both case control cohort have two group. But the difference is, whenever we have the case control study, case control start with case. Case means those who have disease, control means non-disease. So if studies start with these two group, disease and non-disease, that is a case control study. But if studies in cohort study start with exposed and non-exposed. Exposed are those which are doing something dangerous, non-exposed are those which are not doing anything dangerous. For example, if I say that, let's say I said that in a study, alcoholic driver have more accident. Okay, it is usually found that alcoholic driver do more accident. So in a study, alcoholic driver having more accident, two groups were selected. One driver with having accident, who drink and drive, having accident and they drink, and other group of driver who don't have accident, no accident. Okay, and drinking is being asked from both of the group that did they drink while driving. Okay, and drinking data is taken. data is taken. So which type of study is it? Can you tell me in this example, in this story, which is the type of study, case control or cohort? See, all this kind of question where you have to decide case control cohort, in your mind make the flow chart first. Ki where the study start, here the study start with alcohol, end with accident. So if the two group are accident present absent, it means the two group are outcome present absent, and it will become case control. If the two group are alcohol present absent, then it means it is exposure present absent, and the study will be cohort. So as you can see here, the two group are having accident and no accident. So that means the two group are, one is accident, and accident is a disease. So one is case, accident present, and one is control, accident absent. So because they have taken the two group as outcome present absent, this study will be case control. And of course, Dr. Anil Soni, humble doctor, Arjun Akvi, Preeti Rana, Rafiq Khan, Akash, all are right. Okay. But if it is alcohol present absent, drinking present absent will be the two group, then it will be cohort. Okay. Similar question they have asked in the past, that excess social media use lead to depression. In a study, one group with depression are compared with other group without depression in terms of their social media use. So again they took two group, one with depression, one without depression, that means disease present absent. So that was also example of case control. Okay, so I hope you can identify the study easily. Just look, first draw this flow chart in your mind and try to look whether the two group are exposure present absent or disease present absent, and you can answer it very easily. Okay, chalo, thank you. Now, this was the 8 question which came in the paper, but I had given 24 question for the paper, but due to some technical error only 8 question came, and in place of PSM some pharma question came there. So that was just while sending paper some technical error was there. So let me discuss those questions quickly. What was the question? Just answer question. One question was, what is the diluent for JE vaccination? The JE diluent, can you guess it? Do remember, for BCG we have normal saline, sterile water is for MMR. How to remember? बच्चा जैसे ही पैदा होता है हम उसकी ज़िंदगी थोड़ी नमकीन बनाने की कोशिश करते हैं. So we gave normal saline with BCG because this normal saline is something which some question came. Normal saline is something which is given with BCG at birth, है ना? तो पैदा होते ही नमकीन बना रहे हैं. And MMR stand for, of course, mumps, measles, rubella, and M also stand for mother love. And we all know mother love is like sterile water. So MMR is sterile water. The answer for JE is definitely phosphate buffer. And again, Dr. Anil Soni, Preeti Rani, Rafiq Khan, Yadav, Subham, Arjun Akvi, Ritya, all of you are right. Very good. Okay. Now, next question. Which of the following trace element is deficient in the diet can lead to low birth weight, preterm delivery, spontaneous abortion, or even congenital malformation, and then in children, dryness around mouth and nose? This was the question in NEET this time, dryness around mouth and nose. And the answer was zinc, definitely zinc. Now, if you found a child with cracking around the lip, that is vitamin B2 deficiency, which lead to angular stomatitis, riboflavin deficiency. But if it is dryness around mouth and nose, it is zinc deficiency, and that also lead to all this problem. Next question was, identify this RAS. So in this case, you can see the RASes are in the interdistal area. Okay, in the interdistal area, the RASes are there, and you can see some track also where the worm has walked. So interdistal area, remember, and other family also have itching. These two hint identify to scabies, and scabies is transmitted by itch mite. So answer is itch mite. Which disease is transmitted by trombiculid mite? Can you tell me? Tell me, which disease by thromboembolic mite? That is scrub typhus. And scrub typhus is caused by tushu gambuchi. Tushu gambuchi. One question they very commonly give is that there is a man with history of bite, then bite from insect, and then after bite from some insect there is SR formation and fever. So in 99% cases, if they give such history, this is the history from epidemic typhus. And then they ask what is the causative organism of epidemic typhus and who transmit it. So epidemic typhus is transmitted by louse, our childhood friend, head lice. Head lice or louse transmit 4 diseases: pediculosis, epidemic typhus. Epidemic is by louse, endemic is by rat flea. So pediculosis, epidemic typhus, relapsing fever and trench fever. Trench fever is also known as Quintana fever or Quintaniac fever. So these 4 diseases, what are the diseases? Pediculosis, epidemic typhus, relapsing fever, trench fever, which is also known as Quintaniac fever, are transmitted by louse. And the causative organism for epidemic typhus is Rickettsia prowazaki. These are recent year question. Do listen it carefully. So you can see there is a power, prowazaki. So prowazaki is causing epidemic, big thing. And endemic typhus is by Rickettsia typhi. Like typhoid is endemic in our country, so typhi, endemic typhus. Okay, so this is scabies, scrub typhus, and there is one more disease, rickettsial pox. These 3 illnesses are transmitted by mite. So you can remember these 3 illnesses very easily with the mnemonic RSS. RSS, R for mite, PUT is for louse. Okay, and then for rat flea, I think there is a question on rat flea also. No question. Yes, no question. So do remember that rat flea, I have sent it 28, but 24 was there, so it's there. Rat flea is something which transmits 4 diseases. You can remember it by the mnemonic BAME. B for bubonic plague. And they have asked what is the causative organism of bubonic plague. The causative organism is Yersinia pestis. Patient come with inflamed bubo, swollen lymph node. That is due to Yersinia pestis transmitting it. H is for hymenolepsis. And E is for endemic typhus, inside typhus. Endemic typhus is also known as murine typhus. So you can think that some Chota Bheem is sitting on rat flea with his gada, and because Chota Bheem is our local hero, local to India, so Chota Bheem is causing endemic typhus, inside typhus. Louse is here, so it is epidemic typhus. If you remember these 3 mnemonic, Chota Bheem, PUT and RSS, you can easily do the question of entomology. Now next question is on standardized mortality ratio. What is standardized mortality ratio? Standardized mortality ratio is percentage of total number of death in a population that occur to the number of death that are expected to occur. This is the correct answer for C. SMR is clearly written as observed death by expected death multiplied by 100. This is the formula for SMR. And what is the use of SMR? Suppose you want to get fund from the government to help those children who are working in houses of different people as servant, and you think in them the illness is more, death is high. So first you called all the hospital and you try to find out that out of 1,000 servant who are between 10 to 15 years working in different people houses, how many died in last 1 year. So suppose 30 servant or 30 street children, let's take servant example only, 30 died, and then expected death in 10 to 15 year normal Indian is only 3. So expected death is 3. You called all hospital and observed the death of servant, that is 30. So 30 by 3 will be 10 into 100. That means death in servant are 10 times more than death in normal children. So then you can go to government and ask for fund for them. This is the use of SMR, and do remember the formula. We first put observed death above, expected death below. If someone asks what is the best mortality indicator, that is also SMR. This is the best mortality indicator. Now, in a village, people are walking cross leg on toe. If people are walking cross leg on toe, they are suffering from neuroletharism. And neuroletharism is due to the poison BOA, beta-oxalyl aminoallyl. And what is the treatment which we give, that is being asked. So please do give me the answer. What is the treatment which you will give here? The answer is vitamin C. 500 to 1000 milligram, that is what we give in treatment. Vitamin B12 is given for subacute combined degeneration. B12 deficiency lead to that. And a very common question in MCI exam is, people come with liver cell carcinoma, hepatobiliary carcinoma. What is the poison? And they might also give you the history of eating contaminated groundnut. So if there is contaminated groundnut or maize, which lead to hepatocellular carcinoma, this is due to aflatoxin poison. Okay. So now next, which is not true about vaccines. 2 live vaccine can be given at same time at different site. Yes, this is true. 2 live vaccine at same site should be given at least 3 weeks apart. Yes, the difference should be at least 3 weeks, but we usually keep it 3 to 4 weeks. We keep it 4 weeks, but at least 3 weeks is correct. In vaccine vial monitor, if the color of the inner square is same as outer, vaccine is good. No, if the color is same as out, vaccine we will throw. The inner square, and like if this is the inner square, if it is same color or if the inner square is darker, in these 2 cases we reject the vaccine. Inner square should be lighter. And of course, live and killed vaccine can be given together. Which of the following is not a killed vaccine? To remember it, we can use the mnemonic CBoT. There are 5 vaccines which are both live and killed. C is for cholera, P is for polio, next P is for plague, I is for influenza, and J is for Japanese encephalitis. So these 5 are both live and killed. Then in the killed category, just remember 2 more vaccine, hepatitis A and rabies. Only 2 more vaccine. So in the option, you can see hepatitis A vaccine is given. This is a killed vaccine. In the option, cholera is given. This is also a killed vaccine. Hepatitis A is also a killed vaccine. Then polio is given, and we can see polio is there in CPPIGO. That is also a killed vaccine. So which is not a killed vaccine? Hepatitis B is not a killed vaccine. This is a recombinant vaccine. And they have asked in NEET exam that in hepatitis B vaccine, what are the subunit? The subunit was HBsAg, SAG plus DNA. Surface antigen is there. Okay. In live vaccines, 5 are this. 4 is something which you already know. You all know BCG, MMR, then OPV, polio is already written. BCG, MMR, yellow fever, which is not contraindicated in pregnancy. So BCG, MMR, yellow fever and rota. These 4 we all know is live. Only 2, if you remember, typhoral plus varicella. Then total 6 came here, and these 6 plus 5, total 11 are live. So to remember all the live, just remember typhoral, varicella, and you will not be wrong mostly. So typhoral, varicella are live. Similarly, hepatitis A and rabies are live. And then CPPIGO is both live and killed. Okay. Chalo. Identify this condition. So what is the condition they are showing? In the image, they are showing some blue color line on the upper gum. That blue color line is Burtonian line. And Burtonian line occur in plumbism. Plumbism has 2 things, Burtonian line and basophilic stippling. In basophilic stippling, they will give you image of RBC, and in the RBC images, there will be basophilic granules, dots will be there, like that. Okay. And they have asked what is the root of, most common root of lead poisoning. So most common root of lead poisoning is inhalation, by which it goes inside, inhalation. EDTA is the drug of choice. Ethylene diamine tetraacetate, EDTA is the drug of choice for treating plumbism. Now, next question is population norm of PSC in hilly area. Try to guess this question. Hilly area. Sub-center is at 3,000, 5,000. Please remember, ASA is at only 1,000. One ASA 1,000. And minimum education of ASA is not 10th. It is 8th is minimum. 10th we want, we prefer. So on the Google advertisement released by state government, it is 10th. But 3 places in Park they have written, it is 8th pass. So remember, ASA is minimum 8th pass, 1 ASA per 1,000, sub-center 3,000, 5,000, PHC is at 20,000 and 30,000. Of course, the lesser one is for hilly area, because in hilly area people live far apart. So 3,000 for hilly, 5,000 for plain. Okay, so here what is the answer? PSC in hilly 20, PSC in plain 30,000. Which of the following mosquito have a spotted wing? A lot of students answer Aedes. Aedes is not correct. Aedes don't have a spot on wing. Anopheles have a spotted wing. Anopheles ki chunri pe laga hai dag. It has a spot on wing, black spot, and Anopheles, I hope you know, do not touch while biting it. Lift the ano, then bite. Lifting and then biting is there. So do remember their name also. And just quick revision, Culex transmit JE, filariasis, and West Nile fever. So West Nile fever can be remembered as West Nali fever. Or Nali means sewage water. So Culex breed in dirty water, so Nali fever by Culex. Aedes, Anopheles only transmit malaria. Aedes transmit dengue, chikungunya, yellow fever, Zika virus fever, and Rift Valley fever. So don't you dare to forget these diseases transmitted by them. And in Zika virus, 2 things will occur. One is GB syndrome, other is microcephaly. Microcephaly, you know, na? A small head of newborn. And if I am a pregnant mother, I suffered from Zika during my pregnancy. So mere londe ki hogi, choti mundi. My child will be born with a small head. Microcephaly, GB syndrome will be there. Mansonii breed in root of aquatic plant and transmit only one disease, that is Brugian filariasis. It is a black color mosquito with very long biting area, very long teeth and biting area. Okay, so do remember, it breed in root of aquatic plant and transmit Brugian filariasis. A study was done to know that number of typhoid cases from exposure of a common well. So if it is a common well, this type of epidemic is common source continuous exposure, because people keep on drinking water and it is continuous exposure. If it is a student mess or student hostel food poisoning, most likely it is common source single exposure, but well or pond is continuous exposure. Question is that there are 2 group, carrier and disease. Which study is there? So carrier are those which are control, disease are those which are case. And we are asking them the past history, where they drink the water from. So it is case control study, because one group is carrier, which is control, one group is disease, which is case. Very good. Why it is not field trial? Because in field trial, we do something. Field trial is a type of RCT. So if we are giving them contaminated well water, then it is field trial. It cannot be field trial. Why it is not cohort? Because cohort start with exposure. So if let's say they started with 2 group, one drinking water from pond, one not drinking water from pond, then it will be cohort. Exposed, non-exposed. And then in the future, someone will develop diarrhea, someone will not. So if they start with drinking water, not drinking, cohort. If they start with disease present, absent, case control. Same logic. Okay. Which of the following program include developmental delay of child, that is राष्ट्रीय बाल स्वास्थ्य कार्यक्रम. Okay, कैसे ख्याल रखोगे अपने बाल का? तेल लगा के? You can. But in RBSK what happen is, Ayush doctor visit government school, Anganwadi worker visit of course Anganwadi, and this is the role of ASA worker, that ASA worker go door to door and search for any nutrition deficiency. Like it was asked in it that mothers have vitamin A deficiency, who will search and refer them? ASA. So ASA will visit home, Anganwadi will visit, Anganwadi Ayush doctor will visit government school, and by visiting these 3 places, these 3 people will screen for 4D. They will screen for 4D. What is the 4D in children? 4D, 1D is developmental delay. Second D is defect since birth. This is my case, hai na? Defect since birth. Then the third D is deficiency disease like anemia and all. Fourth D is disease of childhood. बचपन की गलतियां नहीं, बीमारियां, है ना, disease of childhood. So they will screen for these 4D, and either they can treat or they can refer to higher center. So that is RBSK. In JSY only money is given to mother and ASA after delivery. In JSSK 3 free thing is given: free food, free ambulance, free treatment to mother and up to 1 year child in all the government hospital of India. And in IMNCI we just manage the childhood illness. Chemoprophylaxis is which type of prevention? This is primary level of prevention, because in primary risk is present, disease is absent. So we are giving the drugs when someone is suspected that they are carrying the illness. For example, this question came that UK citizen went back from India. After living for some time in India, he went back. For how long he should keep taking chemoprophylaxis for malaria? For how long chemoprophylaxis of malaria is given? What is the answer? Chemoprophylaxis for anemia is given for how long? It is given for 4 weeks. After going back till next 4 weeks, chemoprophylaxis will be given. In secondary, we have all early diagnosis and treatment. For example, if they have asked this question that a son took his hemiparesis father for checkup. So they have used the word checkup. Even in hemiparesis father, if they are taking them for checkup, that is secondary level of prevention. Or if they ask BP taken in health fair, that is also for early diagnosis, so secondary. But if they say son took his hemiparesis father for physiotherapy, so then physiotherapy will be tertiary. Similarly, in recent INICT exam, they have give image of filariasis foot care. So if they ask filariasis or diabetic foot care, that will also be tertiary level. And in tertiary level, we do 2 things. We try to make the person self-dependent, that is rehabilitation, and we try to do disability limitation. We try to decrease the disability which they have. So do remember this main question being asked again and again. Now, a screening program is devised to identify the disease in which phase? A screening program is done in a phase where the disease has not spread, critical point has not came yet. Incubation period is the duration between entry and appearance of first symptom. Okay. So if we are able to diagnose it before appearance of first symptom by doing some screening test, then it will be the best thing. So in a screening program, we can focus on it, but it is very difficult. The easier way to diagnose is early part of clinical disease. When clinical disease has just started, then we can also diagnose. But now the confusion is between A and B, and whatever we do screening program is done on healthy people who are suspected of carrying infection. Like village health fair, गांव के मेले में हमने सबका बीपी लिया और सबको किसी और पैथोजेनिक ऑर्गेनिज्म के लिए पता लगाया. तो we try to diagnose it before appearance of symptoms, so the best answer will be incubation period. If we are unable to diagnose in incubation, then we try to diagnose it in early stage of disease. But our focus or attempt is mainly in incubation. So do remember it. Next question is government initiative to improve the facility in labor room in all government hospital is under. Improve the facility in labor room, that is Laksh program. Of course, I hope you all know Ayushman Bharat is 5 lakh insurance per year for economically weaker section family in secondary tertiary level hospital, private and government both. And Ayushman Bharat also have health and wellness center which focus on improving sub-center and PHC and changing it into health and wellness center. So this is Laksh program. Last question is, a study is conducted. This is a biostat question, but don't be worried, it's very simple to answer it, because I hope you all know that standard deviation is under root of variance. This is one simple formula which they can ask numerical on also, because it's easy to calculate. So variance is standard deviation square also, you can say. Now they have given two standard deviation. One is for diastolic BP, the standard deviation is 11. Second is for vitamin D, the standard deviation is 3. So vitamin D standard deviation is 3. What will be the variance? Variance is the standard deviation square. So variance will be 9. For diastolic BP, standard deviation is 11. So variance will be 11 square, 121. So there is two things. 121 is the variance of diastolic BP and 9 is the variance of vitamin D. So the correct answer will be B. This is a repeated question from NEET previous year, and this formula can be used to identify it. In recent 2 INICT, they have asked the formula of standard deviation to be recognized, and do remember the formula is mean minus number. We add all of them, square them, and n minus 1 if the sample size less than 30. Just they ask you to identify the formula of standard deviation. If they ask, you can identify it, keep it in your mind. So that's all from PSM. Thank you so much for your prompt reply and energetic way of answering and correct answering also. I wish you all the best for your upcoming exam. Keep doing PYQ and keep focusing on your present day performance. And whenever you are doing PYQ, try to do it in a block of 10 question so that you can put a competition and you can focus on recalling the answer correctly. Okay, so thank you so much. Keep rocking. Bye bye. Hasta la vista. Das ka dhaniya. Bye bye. Thank you. Bye bye.
Hello friends, so now let's start with the radiology discussion. So very few radiology questions, only 5. So let's finish them quickly. So I think most of the radiology questions today were very easy. I think most of them were taught in the class if you have attended my class. Let's just start with the radiology. So the first question, a newborn was referred to a higher center from a PHC after seeing the following X-ray. So let's just discuss the X-ray of a newborn. So first of all, remember we are talking about a neonatal pathology, and what do we see here? So in this present image, we see that there are absence of bowel loops inside the abdomen. Okay, there are no bowel loops inside the abdomen. So where have they gone? Yes, they have shifted into the thorax. So the answer here is a diaphragmatic hernia, and this is a congenital diaphragmatic hernia. Right, all of you are saying right. It was an easy question and I'm glad that every one of you has almost gotten it correct. Good evening everyone. Thank you so much. Good evening. So yes, the answer here is a diaphragmatic hernia. Now few pointers about CDH. So remember one important point, it will be asked in your exam. Remember bag and mask ventilation. Whenever you are doing a neonatal resuscitation, do we do a bag and mask ventilation in such patients or not? Tell me in the comment section, do we do a bag or mask ventilation? So we do not do a bag and mask ventilation. Yes, Rafiq, you're right, bag and mask ventilation is contraindicated because all of the air will go into the bowel and into the lungs and further compress the lung and increase the respiratory distress. Okay, so the answer here is a CDH. Now moving on to the next question. During the OPD teaching, your teacher pointed out at the area marked with arrow, name the dural venous sinuses on this given axial CECT image. So I think it's given in the question that it is a CT image, but again for recapitulation, revising, bones are white here. So this is a CT image, right? Now which is this arrow marked? Okay, which is this arrow marked? The answer here is a straight sinus. The answer here is straight sinus. Remember, this right here is the superior sagittal sinus. Superior sagittal sinus. This right here is the inferior sagittal sinus. And this, the arrow is pointing towards the straight sinuses. So sinus anatomy is very important in anatomy, and most of the questions related to sinuses will be asked from radiology. So this will be an anatomy or a radiology correlate. Now moving on to the next question. A young patient was brought to the OPD with difficulty in breathing. He gives history of tuberculosis and there is poor compliance to medication. X-ray reveals the following finding. What does the following X-ray shows? So there is difficulty in breathing, there is respiratory distress. Now what is this X-ray showing? So this is a PA radiograph view, this is a PA view of the X-ray, and what do we see? We see that there is this meniscus sign. The right CP angle is blunted. There is blunting of right CP angle. So what is the answer here? Yes, everybody has answered it correct. It is pleural effusion. Okay, everybody knows this. This is the meniscus sign that we see. And what is this curve known as? Tell me in the comment section, what is this curve known as? This is Ellis's S curve. Okay, so answer here is pleural effusion. Okay, now let's move on to the next question. A 30-year-old male present with dysphagia which is more to liquid. So remember this buzzword, first is dysphagia and more to liquid. So you have already made the answer from this line as well. So barium swallow is given, what is the image shown? So this image typically shows the bird beaking. This typically shows the bird beak appearance. Yes, the answer here is achalasia cardia. Yes, everybody has answered it correct in the comment section. The answer here is an achalasia cardia. Now let's move on to the next. This was a tricky question and very important question, and I want you all to listen to it very carefully. I'll give you some pointers why the answer is a particular answer. So in this sagittal view of the CT chest, what is the structure marked with the arrow? So first let's discuss very important pointers. First, it is a CT. There is no doubt about that it is a CT because the bones are white. So it is a CT. Now let's further dissect what we have. So which vessel is this? The vessel that I have marked with star. Which is this vessel? Answer me in the comment section. Which is this vessel which I have marked with the star? I'll wait for few seconds. Yeah, so the star marked vessel is the aorta. Okay, this is an aorta and you see various branches coming out of it. So this is an aorta, right? So this becomes the pulmonary artery. The plus artery becomes the pulmonary artery, right? So which is the chamber which is attached to this pulmonary artery? So this becomes the right ventricle. And also remember that right ventricle is an anterior chamber, so it is located just behind the sternum. So this has to be right ventricle. And so what are these vessels that are coming out of this chamber? So these vessels are pulmonary veins, and if you look carefully, the contrast density in the aorta and this chamber is almost equal. So it is a left sided chamber. Okay, so this is a left atrium. This is a left atrium. Okay, the answer here is a left atrium. You can see the pulmonary veins communicating, and the contrast density is similar to that of aorta. So remember, this is the left atrium. So these were all the radiology questions from today's grand test, and thank you.
Hello everyone, welcome to this session of orthopedics for the CBoT. As far as these orthopedic related questions are concerned, first of all, you have to identify something which is provided to you in the image. And majority of the times we have discussed, hundreds of the time we have discussed, that if in an orthopedic question, there is something asked about the metabolic abnormality and X-ray of the wrist is provided, then probably the answer is rickets for that particular question. Now, first of all, even before listening or even before reading the question, if we see what are the findings which are provided to you in this X-ray, one is the depressed metaphysis, that is cupping of the metaphysis. Second is irregularities in the borders of the metaphysis, that is fraying of the metaphysis. And the third one is increased contact surface area, that means increase in the surface area of the metaphysis, that is splaying of the metaphysis. All right. So all these X-ray findings, orthopedic question, asking about metabolic abnormality, X-ray of both the wrist, AP view are given, then probably they are asking about rickets. So before even reading the question, you are ready that possibly they are asking about ricket. Now rest is dependent on the question itself. Like 3-year-old child was brought by mother to your OPD with a complaint of limping. All right, she came with a complaint of limping. Now serum calcium was 9.8 milligram per deciliter. As majority of you know that 9 to 11 milligram per deciliter is the normal value for serum calcium. So it is within the normal confines, and alkaline phosphatase is given as 1023 international units per liter, which is higher than the normal. If the normal can be considered as 440 international units per liter, that is the normal upper limit for the alkaline phosphatase. So probably this alkaline phosphatase given to you is higher alkaline phosphatase. So every time you get a question related to rickets, you will get a normal calcium, normal serum calcium, and the reason for this normal serum calcium is because the blood calcium is regulated by parathormone. All right, because of the hyperparathyroid, or you can say because of the relative increase in the release of the parathormone, there will be mobilization of the calcium from its reservoirs into the circulation, and you are not measuring the calcium of the reservoirs, you are not measuring the calcium of the bone, you are not measuring the calcium in the skeletal muscle or in the nerve endings, you are measuring the calcium from the blood, and blood calcium is normalized by this excessive parathormone. All right, so that is why the normal calcium level will always be provided to you. This normal calcium level, you know, it can confuse you that possibly it is not the rickets we are talking about, but yes, this is how the serological markers goes with the rickets. All right, the calcium will be normal, alkaline phosphatase will always be found to be elevated. Now X-ray of the bilateral wrist joint shows the following finding. What is the most probable diagnosis the patient is suffering from? So answer for this particular question goes in the favor of rickets. Rickets, because it is a very common abnormality which is found on day-to-day basis regularly in your OPDs, and the same is the clinical finding with which majority of the patient comes with. So that question itself is the language of the patient which is mentioned in the question. All right, so answer for this question without any doubt is rickets. Now, you know, what are the things which would be provided for other options? Like in case of osteogenesis imperfecta, there would be multiple fractures in different stages of healing would be provided. In case of osteitis deformans, which is Paget disease, you know, there will be increased markers of both bone formation as well as bone resorption would be provided. As far as for vitamin C deficiency is concerned, the X-ray of the knee joint would be provided if they are asking anything related to the X-rays. And second thing, the hint in the form of bleeding gum, in the form of delayed healing of the wound would be provided to you. All right, so this is how you will rule out the other options. Now, next is following are the features of the anterior dislocation of the hip joint except. Now, you know, this is the kind of the question which you are getting every year about the dislocations of the hip joint, which could be anterior and posterior. If the patient is lying supine on couch with the limb abducted and externally rotated, this is anterior dislocation of the hip joint. Simple. So anterior dislocation of the hip, how the thigh will be presented to you. The position of the thigh would be abduction and external rotation. This is hundreds of the times we have discussed that what is the reason for this abduction and external rotation. And there could be associated flexion, or sometimes it could be kept in extension also. So it is not like that always the patient would be having a flexion deformity of the thigh. So it could be flexion or extension along with abduction and external rotation. So as you can very clearly see that among the options, flexion is the option, abduction, external rotation, all of them are correct. What is the only option which is the odd one out is the shortening of the limb. Now you already know that in anterior dislocation of the hip joint, if this is the acetabulum, this is the head of the femur, in anterior dislocation of the hip joint, there should be a proximal migration of the head of the femur, but this proximal migration is prevented by rectus femoris muscle, and this rectus femoris, because it prevents the proximal migration, so there is no shortening encountered in case of anterior dislocation of the hip joint. As far as the other counterpart, the commoner one, that is posterior dislocation of the hip joint is concerned, the position of the thigh when the patient will be presented to you lying on couch would be flexion, adduction and internal rotation. So there is going to be a flexion, adduction and internal rotation deformity of the thigh or the hip joint in posterior dislocation of the hip joint. Now, in posterior dislocation of the hip, there is nothing which is preventing the proximal migration from happening. That is why there is always shortening of the limb which is encountered. So, it is always associated with shortening of the limb, that is shortening. So, hopefully everything is clear related to this discussion, all right, clear cut answer. Now, coming on to the next question, that which of the following is correct for the figure shown. Now, before we read the options, first of all, let's check what is the abnormality which is provided to you in the question, all right. If you look at this image, now you can very clearly identify that this one is the right side and this one is the left side. So, the left axis is absolutely normal, you know, the carrying angle for the elbow is relatively normal, and there is an obvious abnormality in the right elbow. Now, in the right elbow, because the carrying angle is usually higher in comparison to the other one, and the apex is pointing towards the midline of the body. So, before even we read the question, the abnormality which is encountered in this image is that of a valgus deformity. So, you can very clearly identify that out of varus or valgus, the elbow abnormality over here is cubitus valgus. And you know, when you have, if you have gone through the text multiple of the times, we have already discussed it, that cubitus valgus commonly is the outcome of the complicated lateral condylar fracture, all right. Now, once you are ready with this image findings, now you can answer the question according to the options which are provided. Now, first option is medial opening wedge osteotomy for the correction. Now, if you correct this abnormality, like this is the humerus, and these are the two bones, and the patient is having a valgus abnormality. Now, in order to correct the valgus abnormality, you have performed the osteotomy at the supracondylar region. Now, you will decide whether to close it medially or open it medially. Now, as it is written that if you perform the medial opening wedge osteotomy, that means if you open this segment after performing the osteotomy, if you create a gap on the medial side, then it will further lead to a valgus deformity. It will increase the valgus deformity. So, medial opening wedge osteotomy obviously knows the answer for this question. Is it cubitus rectus which is due to supracondylar fracture of the femur, of the humerus? Because the cubitus rectus is carrying angle 0. You already are aware of this fact that cubitus rectus basically is when the carrying angle of the elbow joint is 0 degrees. That means there is the axis of the arm and the axis of the forearm is a single line. There is no deviation of the forearm laterally. All right. So, this also is not the answer for this question. Is it cubitus valgus which is due to lateral condylar fracture? So, obviously this is the answer for your question. And restriction of the elbow extension. You know, these movements or these abnormalities in the form of valgus or varus, it does not pose any threat to flexion or extension. The flexion or extension remains normal in case of a child. All right. It is only that the cosmetic appearance of the elbow is hampered. So, hopefully you get the answer for this question. It is clear cut cubitus valgus, which is probably because of the lateral condylar fracture of the distal end of the humerus. All right. Next question is, a 31-year-old male came to casualty with the fracture as shown. Which of the following is the likely neurological deficit the patient would be having? Now, you know, every time you get a question related to the shaft of the humerus fracture, like this is the shaft of the humerus, you already are aware that the nerve which passes along the shaft of the humerus, along the long axis of the shaft of the humerus is the radial nerve. All right. Now, this radial nerve is likely to get injured if there is a fracture in the shaft of the humerus in the mid 1/3 or in the distal 1/3 region. Now, when there is a fracture in these regions of the humerus, it might affect the radial nerve. And once the radial nerve is injured, which is likely to have the outcome of loss of extension of the wrist and loss of extension of the metacarpophalangeal joint. So, out of the options which are provided to you, will there be a abnormality in the extension of the elbow? No. Why? Because for this extension of the elbow to be lost, the radial nerve has to be injured before the level of the spiral groove. All right. If this is the level of the spiral groove, if the radial nerve is injured higher or above the level of a spiral groove, then only the triceps would be paralyzed. Otherwise, it is absolutely normal. inability to abduct the shoulder. You know, shoulder abduction is affected in case of axillary nerve injury, in case of suprascapular nerve injury. So here we are talking about the radial nerve injury. Inability to extend the metacarpophalangeal joint, yes, that is the correct answer, because the extension of the metacarpophalangeal and extension of the wrist is the function of the radial nerve. If the nerve is injured at this level, that means distal half of the humerus, then it is likely to cause the wrist drop or the finger drop. All right, so that is the answer for your question. If you want to rule out the other option, that means the last option, that is inability to flex the interphalangeal joint. You know, flexion of the interphalangeal joint of the finger is the function of both median as well as ulnar. We have talked multiple of the times, like flexor digitorum superficialis, flexor digitorum profundus. These are the two muscles which are responsible for bringing about the flexion, and both of them are supplied by median and ulnar nerve. All right, so that also is not the function of the radial nerve. So this is how the question could be formulated. Means it is considered to be a secondary question. They are not only asking about the name of the nerve which is likely to get injured, but what are the likely findings of that nerve injury. All right. Then finally, next question is a 38-year. First of all, before we talk about this question in particular, you know, before we talk about this question, as I told you, if you look at the image itself, then first of all, you would be able to identify the name of the tumor just by looking at the image. You know, the lesion is there in the epiphysis, that means distal radius, and it is touching the joint line. That means it is the epiphyseal tumor. You already are aware of the fact that epiphyseal tumors could be, one is a chondroblastoma and the other one is the giant cell tumor. All right. Whenever you get or encountered in a question related to the epiphyseal tumor, then you are provided with two options. One is chondroblastoma, other one is GCT. Now, in order to confirm whether it is chondro or GCT, you have to look at the growth plate. Now, already in the question, it is provided that a patient is 38-year-old. All right, 38 year, that means a skeletally mature individual. But if only X-rays are provided, then you have to search for the growth plate. And there is no growth plate visibility. That means the growth plate are already fused. That means the physis is already fused. That means the physis is already obliterated. That means it goes in the favor of GCT, because when there is an epiphyseal tumor without growth plate visibility, it is giant cell tumor. All right. So before even learning, before even reading anything related to that particular question, you are ready with the diagnosis actually, that it is a question related to GCT. Next, gradually increasing painful swelling left wrist as shown in the image with the cracked egg shell feel on palpation, because this is one such characteristic finding for the GCT on examination, that whenever you try to touch the GCT related swelling, it feels as if you are feeling the shell of a cracked egg. All right. Which of the following is true about the management of this case? Now, you already know about the treatment related to the GCT could be only two. One is surgical and the other one is chemotherapy. As far as this chemo is concerned, the only drug today which is approved for the management of GCT is the denosumab. All right. That is the only drug which is used or is approved, although there are some limitations like the possibility of recurrence, then the possibility of conversion into a malignant tumor, but all those things are of different scenarios. But as far as surgical management is concerned, you have to perform the extended curettage. All right. You have to not only remove the tumor, but the normal margins also. After performing this extended curettage, you have to fill the defect by providing or by performing the grafting, by performing the fixation, by performing the cementing, using the ablation of the margins. All right. So all those things are secondaries, but the principle of the management remains extended curettage. Now, if you look at the options, radiotherapy is the initial mode of management. Actually, radiotherapy has no role in the management. Rather, subjecting a giant cell tumor to a radiotherapy would result in a possibility of malignant transformation. So it is strictly avoided. Second, above wrist amputation and chemotherapy, for a benign tumor, although of aggressive category, amputation is of no necessity. Amputation is of no use. That means you are overdoing the management. All right. Extended curettage and grafting obviously is the answer for this particular question, as we have already talked about. And then finally, if you look at the last option, that is percutaneous thermal ablation. You know, percutaneous thermal ablation today is used in the management of osteoid osteoma tumor. Osteoid osteoma. All right. Percutaneous thermal ablation using electrocauteries are used in case of osteoid osteoma, not in case of GCT. So hopefully this gives you hopefully you have understood everything related to this particular question and all the questions which we have discussed in the CBOT. All the best for your examination. All right. Stay calm, stay confident. All the best. Thank you very much.
Hello, everyone. How was the CBOT today? I am Dr. Anupama Chaudhary Devgan, your physiology faculty, and I'll be discussing your physiology questions in today's CBOT. All right, so let's see the first question. Now, this says, a 25-year-old man meets with a road traffic accident that completely eliminates all nerve traffic in the right half of the spinal cord. So this is a case of Brown-Séquard syndrome. And as far as Brown-Séquard is concerned, how do we remember the features of Brown-Séquard? There are some important points. The first one is, remember bus stop. Bus stop, Brown-Séquard, temperature pane of the opposite side is lost. But this will be below the level of lesion. The second important point, touch is least affected. Why is touch least affected? The reason is because touch has a dual transmission. Touch is transmitted, or fine touch is transmitted by the same side posterior columns and crude touch by the opposite spinothalamic tract. So touch will be least affected. The third is all other sensations will be lost on same side. When I say all other sensations, that means basically posterior column. So that means vibration, conscious proprioception, localization, all of these will be lost on the same side below the level of lesion. Number 4, motor paralysis. Motor paralysis will also be on the same side. And number 5, remember bull. That is below the level of lesion, upper motor neuron paralysis, at level of lesion, lower motor neuron type. So these are 5 important points about Brown-Séquard. Now let us try and see. Temperature pane opposite side will be lost. So the question says, loss of which of the following is likely in the right half of this man? That means same side. So definitely not temperature and pain because they're lost on the opposite side. Touch is least affected, temperature opposite side. So this is also not your answer. Motor function and temperature sensation. Motor function will be lost on the same side, but temperature on the opposite side. So this is also not your answer. Motor function, same side. Vibration, same side. So the final answer is D. Let's look at the next question. It says, the GFR of a 25-year-old man with glomerulonephritis decreases by 50% and remains at that level. Which of the following substances will have the greatest increase in plasma concentration? Now, out of the 4 substances which are given, it is creatinine which is removed from the body mainly by the process of filtration. So if filtration is affected, the plasma levels of creatinine will begin to rise, right? And you know the clinical implication. In patients with kidney disease, we look at the serum creatinine levels. So creatinine will have the greatest increase in plasma concentration. Let's look at the next question. It says the rate of gastric emptying increases with an increase in which of the following? If I increase the intragastric volume, this will increase the rate of gastric emptying. If I increase the intraduodenal volume, this will reduce. It suppresses gastric emptying. It will prolong the gastric emptying time. It reduces gastric motility. Fat content of gastric chyme in the duodenum and acidity of the gastric chyme in the duodenum both will reduce the rate of gastric emptying. So the only one which will increase the rate of gastric emptying is intragastric volume. Let's look at the next question. It says, thirst is stimulated by which of the following? Now, there are two important stimuli for thirst. The first one is an increase in plasma osmolality. And increase in plasma osmolality will stimulate the osmoreceptors. Where are the osmoreceptors present? Osmoreceptors are present in the anterior hypothalamus. And these osmoreceptors will in turn send impulses to the supraoptic nucleus and increase the secretion of ADH. And number two, they will also send impulses to the thirst center, which is the lateral hypothalamus, and increase thirst. Right? And this is a very common thing which happens when there is sweating. Sweat is a hypotonic solution. Loss of a dilute solution from the body will cause an increase in plasma osmolality, and we find that there is increase in thirst. Commonly happens in summers. The second important stimulus is a loss of blood. Whenever there is a decrease in blood volume, this now causes an increase in the renin-angiotensin-aldosterone response. Now, angiotensin 2, this now acts on the thirst center and increases thirst. So these are the two pathways for thirst, or two mechanisms for thirst. So two important stimuli for thirst are increase in plasma osmolality and a decrease in blood volume. Isn't it? I don't know if you can correlate this with what you see, especially in older movies. The hero gets shot, he loses blood, and he starts asking for water, pani. So that is that increase in thirst because of loss of blood volume. So two pathways of thirst. So answer to this question is going to be C, increase in plasma osmolality and a decrease in blood volume. Let's look at the next question. Now, it says, during childbirth, a woman suffers serious hemorrhage and goes into shock. After she recovers, she displays symptoms of hypopituitarism. Which of the following will not be expected in this patient? So, hypopituitarism means there is a decrease in growth hormone. There is a decrease in the adrenocorticotrophic hormone. So there will be decrease in the adrenal cortical hormones. There is decrease in FSH, LH. There will be a decrease in the secretion of TSH. Now, so that means infertility, yes. Low basal metabolic rate, yes. Intolerance to stress, yes. Cachexia will not be seen because please remember, appetite is controlled by the hypothalamus. So, A will not be expected in this patient. Next, let's have a look at which of the following would you expect to find in a patient whose diet has been low in calcium for 2 months. A diet which is low in calcium is a very potent stimulus for the secretion of parathormone. So we will definitely find an increase in the parathyroid hormone secretion. But at the same time, let's see the other options. Increased formation of 24-25 dihydroxycholecalciferol? No, this will be reduced. Decreased amounts of calcium binding protein? This will also be reduced. A high plasma calcitonin concentration? No, this will also be reduced. So my answer to this question is an increased parathormone secretion. Parathormone will increase the calcium absorption from the kidney. It will increase the bone resorption and increase plasma calcium levels. Parathormone will also increase the levels of active form of vitamin D, which will increase intestinal as well as renal reabsorption of calcium. So the most potent stimulus for secretion of parathormone is a decrease in plasma calcium, and also if there is an increase in the plasma phosphate levels. Let's look at the next question. Given below is a histology slide of the cerebellum. Purkinje cells project to which of the following? Now, Purkinje cells are very large cells in the cerebellum, and these Purkinje cells project to the cerebellar nuclei, the deep nuclei in the cerebellum. And which are the four pairs of deep nuclei in the cerebellum? Fastigial, globose, emboliformis, dentate. So, as you can make out of these four, the one which is given here is dentate. So, Purkinje cells project to the deep cerebellar nuclei. Answer here is dentate. The rest are not the deep cerebellar nuclei. Let's look at the next question. It says, a neuroscientist is studying communication between the hypothalamus and pituitary in a rat model. She interrupts blood flow through the median eminence and then measures circulating levels of pituitary hormones following appropriate physiological stimulus. Right? She disrupts the blood flow between the hypothalamus and the pituitary and the anterior pituitary. The hypothalamo-hypophyseal portal system exists between the hypothalamus and the anterior pituitary. So secretion of which of the following hormones will be unaffected? Secretions of the posterior pituitary will be unaffected. Anterior pituitary hormone secretion is disrupted, but she stimulates the anterior pituitary, so circulating levels of the anterior pituitary hormones will increase. But remember, posterior pituitary hormones will be unaffected. Why so? Because the posterior pituitary hormones are synthesized in the hypothalamus and then transported into the posterior pituitary by axoplasmic transport. By disrupting the blood supply between the hypothalamus and the pituitary, she will only affect the secretion of the anterior pituitary hormones. So out of these, which is a posterior pituitary hormone? Vasopressin. The two posterior pituitary hormones are ADH and oxytocin. ADH is also known as vasopressin. Growth hormone, prolactin, TSH, these are anterior pituitary hormones. Next. A man lost his right hand in a road accident. 5 years later, he has episodes of severe pain in his missing limb, which is called phantom limb. A detailed PET scan of his cerebral cortex will show which of the following. So basically, in this question, we are trying to ask what is the mechanism of the phantom limb pain? And the latest theory is something known as cortical plasticity. What is cortical plasticity? Now, he has lost his right hand. Right hand is represented, fibers from the right hand will go to the left sensory area of the left cerebral hemisphere. So what happens in cortical plasticity is that the neighboring areas in the somatosensory area on the left side, which surround the hand area, neurons of these areas will project to the hand area. And so whenever a sensory stimulation is given in any neighboring area, the hand area is also stimulated. So answer to this question is projection of fibers from neighboring sensory areas into the right hand area in the left somatosensory cortex. So answer will be C. Projection of fibers from the neighboring sensory areas into the right hand area in the left somatosensory cortex, not the right somatosensory cortex. A and B are not the correct explanations of cortical plasticity. Remember, if you get a question on phantom limb, what is the major reason or explanation of phantom limb? Is it the law of projection or cortical plasticity? Your answer is cortical plasticity. And what is cortical plasticity? I have explained it in this question. Projection of fibers from neighboring sensory areas into the area which has been amputated is responsible for the phantom limb pain. Hypothyroidism due to disease of the thyroid gland is associated with increased plasma levels of. The answer to this question is cholesterol. The reason is the thyroid hormones, they increase the LDL receptors, and which in turn reduces the plasma cholesterol levels. So whenever there is hypothyroidism, it is associated with hypercholesterolemia. So many times in your clinical practice, you get a patient, you get his lipid profile done, and you find his cholesterol is elevated. So the next step should be to get a thyroid profile done. It could be a simple case of hypothyroidism. Hypothyroidism is associated with hypercholesterolemia. Let's have a look at the next question. C wave of JVP occurs in which of the following phases of the cardiac cycle? Now, JVP is seen on the right side. Why on the right side? Because the right internal jugular vein is in direct communication with the right atrium. So, all the pressure changes of the right atrium are reflected in the right internal jugular vein, seen as the JVP. JVP has got 3 positive or outwardly directed waves and 2 negative or inwardly directed waves. The 3 positive waves are A, C, V. A is due to atrial systole, which occurs in the second rapid filling phase. C is due to bulging of the closed tricuspid valve into the right atrium during the isovolumetric contraction phase. V wave is due to venous filling of the right atrium just before opening of the tricuspid valve. Tricuspid valve opens at the end of the isovolumetric relaxation phase. You also have 2 negative waves. The negative waves are X descent and Y descent. X descent is due to a downward pull of the closed tricuspid valve during the ejection phase. Y descent is due to rapid flow of blood from the atrium into the ventricles during the first rapid filling phase. So question says C wave. C wave is in isovolumetric contraction phase. Ejection phase, X descent. First rapid filling phase, Y descent. Second rapid filling phase, atrial systole or the A wave. Let's look at the next question. It says, the body fluid volume changes in a 22-year-old patient are shown below. Solid line is normal, dotted line is patient. Which of the following is the cause of this patient's condition? So whenever you get what is known as the DY diagram, have a look at the rectangle represented by dotted lines. Now, volume is represented horizontally, osmolality is represented vertically. So this rectangle represented by dotted line tells you that the total body water has reduced, so there is a dehydration. Osmolality has increased. So in other words, this is hyperosmotic dehydration. Hyperosmotic, there is an increase in osmolality. Dehydration, there is a decrease in total body water. Now, loss of which fluids causes a hyperosmotic dehydration? this is loss of hypotonic fluids. Hypotonic fluids like sweat. So my answer to this question will be excessive sweating. Let's look at the other options. Mannitol infusion will increase the total body water. So this is definitely not the answer. Hemorrhage is loss of isotonic fluids. So this is also not the answer. Adrenal insufficiency, that means lack of aldosterone, will cause loss of hypertonic fluids, which have got more solutes, more sodium. So adrenal insufficiency produces a hypoosmotic dehydration. So the answer to this question is excessive sweating. Let's look at the next question. An individual sleeps with his arm under his head. He wakes up with numbness, tingling, and inability to move his arm. Which of the following nerve fibers are likely to be affected? Basically, I'm trying to ask you here is which nerve fibers are most susceptible to pressure? And the most susceptible to pressure is the type A fiber. The most susceptible to pressure is type A, followed by type B, followed by type C. Remember, postganglionic sympathetic nerve fiber is type C. So these are definitely not your answers. Your answer is type A. Out of the type A fibers, it is A alpha, which is the most susceptible to pressure. Increase in which of the following ions in the ECF has the maximum effect on neuronal excitability? Increase in which of the following ions? Now remember, the ion which is most important as far as resting membrane potential is concerned is potassium. At rest, membrane is most permeable to potassium. Movement of potassium from inside to outside the cells causes the inside of the cell to become negative with respect to outside, which is your resting membrane potential. So changes in ECF potassium are the most important as far as its effect on neuronal excitability is concerned. The other ions have very little to do with the resting membrane potential, so they do not affect the neuronal excitability. But an increase in ECF potassium definitely will. So if there is an increase in ECF potassium or hyperkalemia will result in a decrease in the diffusion potential of potassium, which causes more positive ions inside the cell and causes a depolarization, or the RMP becomes less negative. And that in turn leads to increase in the excitability. One of the most common symptoms of hyperkalemia are arrhythmias. So answer to this question is D. Following a sympathectomy, a 66-year-old man experiences orthostatic hypotension. What is the explanation for this occurrence? Remember, when you from lying to standing position, the moment you go from lying to standing position, there is a peripheral pooling of blood, which will cause a decrease in cardiac output and decrease in blood pressure, but your baroreceptor mechanism immediately corrects it. So most of the times we do not even come to know about it. Baroreceptors cause an immediate correction by increasing the sympathetic discharge. But in this patient, we've done a sympathectomy. So sympathetic response is suppressed. So why is he experiencing orthostatic hypotension? Because of a suppressed response of the baroreceptor mechanism. Once again, see this, when you go from lying to standing position, There is a fall in blood pressure, but the baroreceptor reflex will immediately increase the sympathetic discharge and bring the blood pressure back to normal. If you do a sympathectomy, there is suppression of this response, and that is why he experiences orthostatic hypotension. Wish you all the best. Keep calm, keep cool, and I am sure that you will be able to tackle all the physiology questions in the exam. All the very best, and God bless. Thank you.
So welcome all, and let's start this discussion on the subject anatomy. I'm Dr. Ankit, your anatomy faculty in LNext, and let's discuss some of the questions. So as the first question, in a patient with a referred back pain, a surgeon suspects the origin of pain to be from a retroperitoneal organ. Which of the following is the likely cause of the pain? So here anatomically, we have to understand, we have to think that which of the organs are retroperitoneal, and if that is not the option, that should be the answer. You should always know the organs that are retroperitoneal. To start with the level of IVC and aorta, we have the organs like the kidneys, then the ureter, then the adrenals. They are at the similar level. Now just anterior to these organs, we have the organs like the duodenum, we have the organs like the pancreas, and the ascending and descending colon, both of them. So this one of them should be in the options: jejunum, liver, stomach, pancreas. Hence pancreas, option number D, is the answer over here. Other organs are intraperitoneal. So the patient is giving a referred back pain. It could be a possibility. It doesn't mean it is, but it could be a possibility that it is from a organ that is pancreas, could be pancreatitis. Let's see the next question over here. A 30-year-old female is presenting with wrist pain on the lateral side. On examination, the test shown in image was a positive tendon sheaths of which two muscles have been involved. So if you look at the image, there's some bending of the lateral side of the wrist to elicit the pain. This pain over here elicited, and that test is known as the Finkelstein test. It's a provocative test, and the disease over here is the tendon synovitis, the inflammation of the tendinous sheaths of the lateral border of the wrist tendons, basically forming the lateral border of the anatomical snuff box. The disease is known as de Quervain's tenosynovitis. De Quervain's tenosynovitis. And the tendons over here are forming the lateral border of the anatomical snuff box. And these are on the lateral side. We have abductor pollicis longus and extensor pollicis brevis, which should be the answer, and I guess it is option number A over here. But we should also know what lies medially is the extensor pollicis longus tendon. Here the answer is our option number A over here. De Quervain's tenosynovitis, very commonly conservative management has to be given at most of the times. Let's see next question. A resident was inserting a central venous line through the femoral vein. Okay, he accidentally injured the structure medial to the femoral vein within the femoral sheath. Which structure is likely to be injured? So here we should know a couple of things, like for example, if you go from lateral to medial, this is anterior superior iliac spine, this is pubic tubercle, we have a ligament over here known as inguinal ligament. Now from lateral to medial, the mnemonic, if you can remember, is navel, N-A-V-E-L. Navel is a mnemonic. While N refers to the femoral nerve coming over here, A refers to the beginning of the femoral artery, V refers to the femoral vein, E is an empty space which might have one or two lymph nodes which are known as lymph node of Cloquet or a Rosenmuller. And mind you that this whole structure over here is inside the femoral sheath. And you can understand that femoral nerve, it lies outside the femoral sheath. Artery, vein, and that empty space having that lymph node of Cloquet is inside the femoral sheath. Remember, the mnemonic or structures are from lateral to medial side, don't go the other way. And if the lymph node is over here, then we can automatically understand that lymphatics have to come and go from here. And the question they are saying what? That
he accidentally injured the structure medial to the femoral vein. Within the femoral sheath has to be this empty space, this actually known as the femoral canal, a very important anatomical site for development of femoral hernia. So there has to be either the lymph node should be the answer or the lymphatic vessels. A looks like an appropriate answer over here. Let us see other options. Femoral artery, nerve, genital femoral. No, answer is therefore option number A over here. Answer is option number A over here. Here we will be having the lymphatics. This lymph node is a deep inguinal lymph node, also known as cloacated lymph node. And this area anatomy is very important because femoral hernia develops from here. Now, the femoral hernia develops from the femoral canal. We can say that the mouth of the hernia is below and lateral to the bony structure. What? Below and lateral to the pubic tubercle, which is over here. PT is pubic tubercle. Pubic tubercle. So this is how the anatomy plays an important role in everything. Not just one or two exception things, but everything. Right? This is a thing over here, and femoral vein blood is also taken, and that is known as femoral tapping. Let's see the next one. A patient developed the following deformity after overhead exercises. Which muscle? If you look at the deformity over here, you see this medial body of the scapula that is prolonging out. What is that? That is the medial winging of scapula. That is the medial winging of scapula is a disease. So therefore, understand that the muscles which normally should be making this medial body of the scapula more close to the chest wall are not working. Now, if you look at the scapula over here, it's a right-sided scapula posterior aspect. The muscle, if we can imagine over here, that this is the muscle that is taking origin from the anterior part of the medial body of the rib, and that goes anteriorly into the upper 8 ribs. And this muscle would be which muscle? This muscle would be our serratus anterior. So serratus anterior muscle could be paralyzed, causing the medial winging of scapula, and this muscle is supplied by the nerve long thoracic nerve. Remember, the mnemonic is SALT, S-A-L-T. Serratus anterior, long thoracic. LT is long thoracic nerve, and this question answer is straightforward, serratus anterior muscle. Okay, the medial winging of scapula. Tomorrow they can ask us about the lateral winging as well. If they show you the lateral winging of scapula, that is probably due to the paralysis of the muscle trapezius. But medial winging answer is serratus anterior, long thoracic nerve. Let's see the next one. The given image is a dissected specimen of the posterior surface of the knee. That is, it's from the popliteal fossa. What is the nature of the gait associated with the damage to the structure marked in the image? So in the image, they are decent enough to tell us what is medial side versus lateral side. Popliteal fossa, they have put an arrow over here. The nerve that is going out laterally is the common peroneal nerve. So we all should be knowing that there is a sciatic nerve coming from the top posterior thigh, upper limit, lateral medial side, upper limit of the popliteal fossa. It divides into a tibial nerve which goes down, tibial, and a nerve going laterally, winding around the neck of fibula is a common peroneal nerve. So the common peroneal nerve is the one that they ask. Common peroneal nerve divides into two main nerves, the deep peroneal and a superficial peroneal. Function wise, this is more important, supplies the anterior leg compartment, and therefore its damage would lead to a high, because damage lead to foot drop. So damage leads to foot drop, and that gait is a high stepping gait. Because if they don't high step, then what will happen? Their toes start to drag. So this foot is getting dropped, they have to do high stepping gait. So foot drop leads to high stepping gait. And therefore, answer over here is option number A, high stepping gait. Okay. Therefore, answer over here is option number A. Very important. Common peroneal nerve damage is the most common nerve in the lower limb that is injured. Okay. Let's see the next one. Identify the arrow marked bone in the X-ray. They have shown an X-ray of the foot. They're asking the bone. Now remember, over first of all, understand that if you start from the foot, say medial side and lateral side is this. First of all, understand this image. The heel that is formed by this calcaneum. So this calcaneum over here forms the heel. This calcaneum. Over the calcaneum is seated your talus. So this talus is seated over the calcaneum. Calcaneum anteriorly articulates the bone, that is the cuboid. This is cuboid on the lateral side. This is Cal dot calcaneum, that is TL talus. The talus, on the other hand, articulates anteriorly with another bone over here, that is navicular. And remember the mnemonic if you can, TNM. TNM classifications, tumor, nodes and mats. T and M means talus, navicular are on the medial side. CCL are on the lateral side. Calcaneum, cuboid on the lateral side. In front of navicular, we have these three cuneiforms: the medial, the intermediate, and the lateral cuneiforms. These are 7 tarsals. Now, if you look at this, this automatically becomes the medial side because you can look at the great toe, that's the lateral side. Okay, so therefore, these are the cuneiforms over here, and this arrowed has to be the navicular. And if you look at the options, then option number B suffices the answer. Option number B, navicular, will be the answer over here. Let's see the next one. Which structure is palpated in the given image? Very important. We should know few arteries that can be palpated. If you look at the image, you are seeing over the foot. Which part of the foot? We are looking at a medial part of the medial aspect of the foot. And they are palpating over here behind the medial malleolus. This area is the medial malleolus. The structures in this compartment, that is posterior compartment of the leg, will be entering into where? Into the foot directly. This is how the things go. Let me show you in this way. This is how the things go from here to here, from the leg to the foot. Therefore, the artery in the posterior compartment of the leg, the artery over here is the posterior tibial artery, and this is what is being palpated behind the malleolus over here. This is the location for the posterior tibial artery. That should be one of the answers over here. If they show an image of someone palpating right over here at this area, the dorsum of the foot, that is probably the location of the dorsalis pedis artery, which is a continuation of the anterior tibial artery, if the location is over there on the dorsum of the foot. But here it is at the posterior tibial artery. Hence the answer is this. Let's see next one. An elderly man is diagnosed with a slow growing tumor in the deep perineal pouch. Okay. Which of the following structures would be most likely affected in the deep perineal pouch? So what are the structures lying in the deep perineal pouch is the question. Okay, if we look at the perineum, then perineum is below the pelvis. So what happens is, basics, above we have the pelvis, then we have what? Then we have a group of muscles over here that is known as the pelvic diaphragm. So this is known as pelvic diaphragm, and below we have the perineum. Now in this perineum, what happens is you have what? You have a membrane over here. This membrane is known as what? This membrane is known as the perineal membrane. And this divides the perineum into a deep perineal pouch and a part below it known as superficial perineal pouch. That is the whole game of the anatomy over here. Now they are asking you what lies in the deep perineal pouch, what lies above the perineal membrane. Now, therefore, the structures lying in the deep perineal pouch are, first of all, there is a membranous urethra over here, which is bounded by the urogenital diaphragm muscles. And in this urogenital diaphragm muscles, we have a sphincter urethrae muscle and a deep transverse perineae muscle. Apart from these structures, there is also presence of a bulbourethral gland. But mind you that only this gland is present while its opening, in brackets, its opening lies in the superficial perineal pouch. That is the point. These are major structures. Apart from all the nerve and vessels, these are the major structures. So if you look at the options, then we'll consider over here option number A, bulbourethral gland, that lies in the deep pouch. Hence, it should be the answer. The corpus is spongiosum, Bartholin, and these are all present in the superficial perineal pouch. So one thing you should know, that what separates deep from superficial, it is this perineal membrane location that separates deep from superficial. Right? And so our answer is option number A, though its opening is there in the superficial pouch. Let's see the next one. Now you are examining the liver. The gallbladder will be found in the fossa between which two anatomical lobes. Basic anatomy of liver should be clear. Now if you imagine this to be the liver, this is actually, imagine the fundus of gallbladder, and that is the IVC that is lying behind. And if we take, we can say a hypothetical plane from IVC to gallbladder, then that plane that plane will be known as the Cantley's line, right? So this is what is known as the Cantley's line, which separates the liver into right and left lobes, right? So here if you look at the lobes, then this will be the right lobe and that will be the left lobe. Now segments over here, try to understand. Segment number 1 is present posteriorly. So this segment number 1 present posteriorly. Then we have segment number 2 over here, segment number 3, segment number 4 actually spread throughout the anterior surface. And then segment number 5 over here, 6 over here, 7 and 8. So gallbladder is technically lying between the right and the left lobes, or we can say between the segment number 4 and segment number 5, or between the right lobe and the quadrate lobe, because segment number 4 is the quadrate lobe. So if you look over here, then options are the gallbladder lies where? Quadrate and left, quadrate and quadrate, right and quadrate. Yes, option number C, right and quadrate, will be the best possible answer over here. Caudate lobe is segment number 1, lies posteriorly. Right, so this basic anatomy of the liver, how to divide the segments, where do they lie, that is important. It's also important while doing segmentectomies or hepatectomy, hemihepatectomy, you have to remove half of the liver. Let's see the next one. The boundaries of the Calip's triangle are found by all except. Calip's triangle is used while doing a cholecystectomy or surgeries around the gallbladder or the liver. Now Calip's triangle is what? You have to understand this again being the liver. Now imagine the liver has been somewhat retracted to show you the gallbladder. Now, if you look at the gallbladder, then gallbladder, imagine, is here like this, having this, say, the cystic duct over here, and that is the gallbladder, right? Now from below or from above, we can say these are the right and the left hepatic duct. They form the common hepatic duct. They join with the cystic duct to form the common bile duct. If I may label it, I will write it as, this is the hepatic ducts, right? These are the hepatic ducts, and then we have what? This is the common hepatic duct, that is the cystic duct CD, that is the common bile duct. Now this is on the right side. What happens on the left side? If you have a proper hepatic artery coming out, this is the proper hepatic artery, divides into right and the left hepatic artery. This right hepatic artery gives off a cystic artery. So this, imagine, is the cystic artery over here. Now, if you take this area, this small area over here, what are the boundaries of this area? There is cystic artery, which the person has to ligate if you to operate on the gallbladder. Then there is going to be cystic duct, and there is going to be the common hepatic duct. Now, this area is known as the Calip's triangle. This is the anatomically that is known as Calip's triangle. But on the other hand, if you include this inferior border of liver also, instead of cystic artery, that will become the cystohepatic triangle or cystobiliary triangle. So what are the boundaries of cystohepatic triangle? They are same as that of Calip's, only differences. In place of this cystic artery, we have the inferior border of liver. So it's a slightly bigger triangle. Cystic duct, common hepatic duct. So if the question comes, what is like content of this cystohepatic triangle? The content is cystic artery. The content of this triangle is a cystic lymph node or cystic lymph node LUND. Right. So here, if we look at now the option which is not formed, common hepatic duct is a part, cystic duct is a part, cystic artery is a part of this Calip's triangles. GB is not a part of it. Hence, GB will be the answer. Let's see the next one. A fracture, the marked arrow leads to bleeding of which artery? Now, marked arrow is towards the, what we can call it as a H-shaped suture, where the bones meet. Which bones? We have a frontal, parietal, temporal, and sphenoid greater one. So these four bones meet, and you have this sort of H-shaped suture over here. The important part over here is that deep to it, you have a artery, and this is the middle meningeal. It has an anterior trunk and a posterior trunk. So therefore, deep to this H-shaped suture, which is also known as the T-region with the P silent, what we have an anterior trunk of the middle meningeal artery. And as this part of the skull is thin, in a lateral injury, this part of the skull of suture can break, leading to bleeding from this artery, which might give rise to the epidural hemorrhage. Therefore, in this option answer is this. And remember that this artery is itself a branch of the maxillary artery. epidural hemorrhage, which is an emergency situation, needs craniotomy to be done. Okay, so it needs craniotomy to be done. So this H-shaped suture, remember the name is stereon, the artery is this, the branches of the maxillary artery. Okay, let's see the next one. Cranial nerves with parasympathetic component. We all know that the parasympathetic itself is having a craniosacral outflow. This cranial nerve over here are nerves number 3, 7, 9 and 10, which should be the answer. While the sacral ones over here are S2, S3, S4, which are also known as the pelvic splanchnic nerves or nervi erigentis. So this cranial nerve 3, 7, 9, 10, they have the parasympathetic component. Hence, this should be the answer over here, while the nuclei or the nucleus inside of the third nerve is known as the Edinger-Westphal nucleus. For the seventh nerve, we have a superior salivatory and a like crematory nucleus. The ninth nerve, what we call it as a inferior salivatory. For the 10th nerve, we call it as a dorsal nucleus of vagus nerve. And if you talk of the cranial nerve nuclei component, these all come under general visceral efferent column. These are all the questions that they can ask from here. Let's see the next one. Which of the following arrow is wrongly matched? Now, this section over here is nothing but a coronal section of the brain. Right here, you can see clearly that few things, if I may point out over here, this is the corpus callosum. This is the corpus callosum over here. Okay, and then what happens? This is what? That is the lateral ventricle over here. And if I put an arrow over here, this was also asked, that is fornix over here. This is the area. A should be the caudate nucleus, a part of the basal nuclei. C is also part of it, known as the lentiform, which has the parts like putamen and globus pallidus. B is the diencephalon or the thalamus or the diencephalon over here, while D is outside the lentiform. It is a site for external capsule. In all of this, the location of internal capsule, is this INTCAP, that is going down. This is internal capsule. So if you look at the options, A is caudate nucleus. Yes, A is the caudate nucleus. B is thalamus. Yes, B is thalamus. C is lentiform. Yes, answer should be D without even seeing what is written in D. Was A, B, C, we are sure that it is correctly matched. D, they are saying internal. D is the external capsule. We also shown where is the internal capsule, right? Moving from here, let's see the next one. Which of the following belongs to spatial visceral efferent? Spatial visceral efferent column. The spatial visceral efferent columns over here are the columns for the pharyngeal arches, nerves of pharyngeal arches. And if you compare it, we have the arch number 1, arch number 2, number 3, number 4, and 6th arch. And the nerves for the first arch is the mandibular nerve. Second arch is the facial, third arch is the glossopharyngeal, fourth and sixth nerves are superior laryngeal and a recurrent laryngeal, both branches of vagus. What happens is this 9th and 10th combined with a bit of 11th, they all form a common nucleus, and that common nucleus is known as the nucleus ambiguous, right? That common nucleus is known as nucleus ambiguous. Hence, therefore, nucleus ambiguous should be the answer over here, option number B over here. And nucleus tractus solitarius is for the visceral afferent, taste. Dorsal nucleus vagus, just saw parasympathetic general visceral efferent. This answer is spatial visceral efferent. And last option, mesencephalic, is for the sensation, general sensation, so general somatic afferent. Okay. So this answer for us here is option number B over here. Let's see the next one. A newborn had hypoplasia of the mandibles and the zygomatic bone over here, malformed external ears, and slanted palpebral fissures. Abnormality in the development of which of the following pharyngeal arches will most likely lead to the given condition? They are saying it is problem in the mandible and all the associated bones, including the ear. The first arch itself is known as the mandibular arch. It also forms a part of the external ear. It also forms a part of middle ear, like the bones of malleus and incus. All of this relating to the first arch, therefore answer has to be the first arch. And first arch is also known as the mandibular arch. The second arch is known as the hyoid arch. Right? So remember the pharyngeal arches topic in embryology we have done in detail. Have a look at it. A very important topic of embryology of the head and neck. Let's see the next one. The type of structure shown in the following slide. This is a histology question. Look at it. You're seeing some larger cells. These are basically the chondrocytes over here. But in the matrix, if you see, it is, it has a glassy appearance. It is homogeneous. It is transparent. That is why it is a hyaline cartilage. The most abundant cartilage is a hyaline cartilage. Present in the costal cartilages, articular cartilage, and where not. Thyroid, cricoid, everyone is hyaline cartilage. So this is hyaline cartilage. Now there are options given like intervertebral disc. This is the example of fibrocartilage. Articular cartilage, yes, that is the example of hyaline. And this should we answer? Articular cartilage is at the end of the bones which are forming the joints. Articular disc is again fibrocartilage. Pinna is a elastic cartilage. So here remember, if a glassy hyaline itself means glass type. Glasses are transparent, right? So why is the reason of it being transparent? Is the refractive index of the fibers in the matrix is same. So there are fibers but they are not seen because of the similar refractive index. That is why articular cartilage will be the answer here. Okay. Okay, so here's the next question. The question says upper lateral cutaneous nerve of arm is a branch. Very typical question, but very easy to sort it out. How? Let us see how to sort it out with the help of simple mnemonic. One of the simplest mnemonics you will see in anatomy. So this is the neck region, that is the shoulder, that is the upper limb, going down, that's here the thumb region and the hand region. Going back to the forearm, then this is the arm region, and then this is the trunk part. Okay, so you can imagine that this area is the area for the, say, the elbow region or the cubital fossa region. Above it is arm, below it is forearm, that we already know. Let us just complete it. This is the arm region, and that region is the forearm. And distal to it we have the hand or the palmar region. Now see, the lateral cutaneous nerves of the upper limb. Sir, why not a medial cutaneous? See, the medial cutaneous nerve, the point over here is, in the medial area, you already have the direct branches coming from the brachial plexus, like what? Like medial cutaneous nerve of forearm, okay, and medial cutaneous nerve of arm. So here is the medial cutaneous nerve of forearm. This will be the medial cutaneous nerve of arm. They are directly coming from the medial cord of brachial plexus. So from where are they coming? Medial cord. Both of them are coming from the medial cord. Now come to the lateral part, which was the question that is asked. Here the mnemonic, remember, is arm. A, R and M. So A and R are in the arm region, lateral cutaneous in the arm, and M is in the forearm, lateral cutaneous in the forearm. If we trace their area, this is the area for the A, axillary nerve. This is the area for the R, radial nerve, and this is for the M, not the median but the musculocutaneous nerve. So here the names are a bit different. A is referring to the axillary nerve. What it is? Upper lateral cutaneous nerve of arm. That is what they asked. Therefore, axillary nerve is the answer. Upper lateral cutaneous nerve of arm. R is for the radial nerve, and what is that? Lower lateral cutaneous nerve, but lower for the arm, not in the forearm. And M over here is the musculocutaneous nerve, not the median. It is a musculocutaneous nerve, and it is complete in the forearm in the lateral part. So we call it as lateral cutaneous nerve of forearm. Simple as that. So laterally are these, mnemonic is arm, medially we have directly from the medial cord. What about posterior? In the posterior part of the upper limb, they are posterior cutaneous nerve of arm and forearm. Please do remember they are coming directly from the radial nerve. This is itself a branch from the posterior cord of brachial plexus. Okay, so these are important questions, and do remember that they do come, and simple questions. Just if you go through the mnemonic, it will help you. Also do remember, in a few years back they used to ask it in the form of a sign. The sign was known as a regimental badge sign. I hope many of you might be familiar with it. That was known as a regimental badge sign, because at this area there was sensory loss or paresthesia was there. Okay, so this was the answer for this question, axillary nerve. Let's see the next one over here. Which of the following glands is supplied by the glossopharyngeal or the ninth cranial nerve? So before looking at the options, if the concept is clear, you will be actually searching the answer. If the concepts are not clear, then you will be okay ruling out A, what is there in A, let us put a guesswork. But here concepts. Concepts are what? When they are asking the glands supply, it is parasympathetic. We all know parasympathetic, the 4 nerves, cranial, 3rd, 7th, 9th and 10th. Okay, the third nerve over here will go to which ganglion? They basically go to the ciliary ganglion. Okay, what do they supply? They supply two basically muscles, sphincter pupillae and ciliaris. That's it. The seventh nerve over here will go to two different ganglia. What are those? One is the pterygopalatine ganglia. Okay, pterygopalatine ganglia. Where will it go? It will go to the lacrimal gland. Very good. And some of the nasal palatal glands. Fine. The other ganglia will be the submandibular ganglia. Submandibular ganglia. Where will it go? Obviously to the submandibular oblique sublingual gland, salivary gland. The ninth nerve will go to which ganglia? It will go to the otic ganglia. Okay, so that was the question. And this ganglia will go to which gland? It goes to the parotid gland. Otic, parotid. So here obviously the answer is the parotid gland. That is our clear-cut answer. The 10th nerve has a various supply because it goes through the entire thoracic and the abdominal viscera till midgut. The name of the nucleus over here is the dorsal nucleus of vagus. And mind, all of these parasympathetic, they come under which cranial nerve nuclear column? It is also frequently asked. They are all parasympathetic or secretomotor. So they are efferent. They are going to visceral, and general visceral efferent will be. What is the next question? So if we look at the other options, so submandibular salivary gland, 7th nerve, lacrimal, 7th nerve, parotid, 9th, sublingual, again 7th nerve. This is how we can easily answer. So remember the 4 ganglias in head and neck, you need to know the details of it. Of which is the post-ganglionic nerves, they are frequently asked. So that's all. I hope you enjoyed. All the best and for the exams, and that's it. Thank you very much.
Hello all, welcome to the FMGE CBoT discussion held on 20th July, that is today, and I hope all the questions of pediatrics were very simple, straightforward. So we'll have a quick discussion, but what were the answers to the various questions? Okay, starting with the first question in pediatrics, a child who's having severe acute malnutrition has presented in the emergency in a state of shock. Which of the following fluids should be administered to this child initially? So, important thing over here is this is a child with SAM, severe acute malnutrition, very, very important. This is just not a normal child with shock. He's a case of SAM with shock. Now, one thing which you have to keep in mind always, in fact, there are 3 pointers which you have to keep in mind. First, children with SAM, they are always in a state of decreased potassium levels. They also have decreased magnesium levels and their total body sodium is grossly elevated, right? So, these 3 things have to be kept in mind. And the most important thing, the 4th thing that has to be kept in mind is that they are always at a risk of developing hypoglycemia. And how is hypoglycemia defined in these children? It is the blood sugar level less than 54 milligram per deciliter. Now, keeping these things in mind, let us see which would be the ideal fluid for resuscitation. Definitely the first option is out. 10% dextrose is not a fluid recommended for resuscitation. Coming to the rest of the 3 fluids, there would be no problem had it been a normal child. We could have, used any of these. But since this is a child of SAM, we need to use a fluid where the sodium is low comparatively and where we can also supply potassium. And an ideal fluid in this case, if you see this chart, is lactated ringer or ringer lactate, whatever you want to call it. So where you can see that in NS, the sodium and the chloride levels are quite high as compared to the lactated ringer or the ringer lactate, and very importantly, ringer lactate also contains 4 milliequivalent per liter of potassium, right? And if we also add 5% dextrose with it, this becomes the ideal fluid. So therefore, my friends, I'm sure many of you would have got this right. Yes, the answer is ringer lactate plus 5% dextrose would be the ideal fluid for resuscitation in this child, right? So moving on to the next question. And that was a 2-month-old female infant presents with an occlusive vascular lesion involving the right upper eyelid, resulting in severe restriction of opening of right upper eyelid. This lesion was first noted within 1 week of normal delivery, and the lesion has increased in size over the past 2 months. Identify the condition given in the figure below. So if I enlarge it for you, what is this condition? So let us look at the options given. A very easy way to answer this would be look at the other options. So erythema toxicum neonatrum, for children who have read with me, they know that in neonatology we have seen this very, very commonly. This is a very common topic from which the questions come. Erythema toxicum neonatum is seen on day 2, day 3 of life, and usually it is a pustular lesion with an erythematous base and usually resolves in coming 2 to 3 days, nothing to be done. And if you do the scrapings of these lesions, it will reveal eosinophils. They do not appear like this and they are seen all over the body, right? So this is not erythema toxicum neonatum. What about milia? Milia we know are discrete yellowish, maculopapular lesions seen in children right after birth, and again nothing to be done. They resolve spontaneously and they are seen mainly over the face. Then what about Mongolian spots? We know Mongolian spot is a purplish, bluish, greenish patch-like lesion, seen in the posterior part of the newborn, usually in the lower back, in the trunk, lower trunk region or the gluteal region. So that there you will find these patches, nothing to be done. It has no relationship with Down syndrome. It can be seen in normal children. And it resolves spontaneously in coming 6 months to 1 year of age, right? So if you go by exclusion, yes, the answer straight away becomes capillary hemangioma. So yes, this is a case of capillary hemangioma. These are also known as stork bites, also known as nevus simplex. Usually they are very smaller in size. They are seen in the glabular region and over the area of eyelids and on the nape of the neck. In this case, yes, this is unusually large, and in this case, usually in stork bites, we do not do anything. They resolve on their own. Day in, day out, I see in my clinical practice, people, they come with their newborns and they're very worried with these lesions. So they are very harmless lesions. But in this case, this capillary hemangioma might cause vision problems, right? It is increasing in size. It was not there at birth and is progressively increasing in size, may lead to refractive error or amblyopia, right? So in this case, what do? Yes, we have to resort to treatment. Otherwise, the general dictum for capillary hemangiomas, if we all know, is 40% resolved by 4 years of age and 80% resolved by 8 years of age. But in this case, it requires treatment. So the first drug of choice in this case, remember, is propranolol. Yes, propranolol is, the drug of choice in this case. And, even topical propranolol has been advised in this case, and usually it causes regression of the lesion. But of course, one has to take care about the side effects of propranolol in children, especially in infants, leading to hypoglycemia and bradycardia, right? So a preliminary workup of echo and ECG has to be done before starting propranolol. Another drug which can be used is intralesional steroids, and sometimes adjunct to intralesional steroid is oral steroid therapy. And of course, the third modality of treatment would be surgery, which is, can be done at any point of time where you think that lesion is not responding to the drugs, but then it comes with its innate risk of anesthesia and the risk of recurrence of the lesion. So that is it. This is capillary hemangioma for you. Okay, then coming on to the next, MCQ, and this was a 7-year-old male child presents to you with painful swelling below the ear, associated with fever, malaise and headache. There have been 2 other similar cases in the friends of this child in the same village. What is the next step of management? Definitely, this is an infectious disease, and not only infectious, this is a communicable disease also, because the friends of the child, friends of the index case, have also suffered from the similar illness. And looking at the pic, you can see the fullness of the angle of the jaw that indicates a parotid gland swelling. And of course, the first thing which comes to our mind with parotitis, fever, malaise is the diagnosis of mumps. Yes, very, very important. Mumps is caused by paramyxovirus, the family, the virus belonging to the genus paramyxovirus, and usually it has a incubation period of 2 to 4 weeks, and usually it starts with the prodrome of fever, malaise, headache and parotid gland swelling, which may be unilateral to begin with, but may involve both the glands, and the other 2 glands may also be involved, that is namely submandibular and sublingual. And within 1 to 2 weeks of this illness, after the parotid swelling, we get the something known as orchitis. Very, very important, seen in male children. Orchitis, remember, 85% of times it is unilateral. Only one of the testes is involved. But yes, it can be bilateral also. And very important thing, what you are asked in your exam is, does orchitis lead to sterility? No, it doesn't. Sterility is very rare with mumps orchitis. Coming to the complication of mumps, we should be knowing the most common complication of mumps is aseptic meningitis, that you should be knowing. And also you should be knowing certain important facts about mumps, that mumps is considered to be the most common cause, most common infectious cause of aqueductal stenosis. Very, very important. You should know this, aqueductal stenosis, which can lead to hydrocephalus. Other manifestations or other complications of mumps seen would be Guillain-Barré syndrome can occur, cerebellar ataxia can occur, right? And we can also have, facial neuritis can also occur in this case. So that is what is seen with mumps. Other than the CNS complications, we also get to see, very importantly, pancreatitis. Pancreatitis can also give rise to insulin dependent diabetes mellitus. Remember, so mumps can be one of the causative factors of childhood diabetes. So that is it. And of course, there can be involvement of the heart in form of myocarditis, and nephritis can be seen. And apart from that, oophouritis can also be seen in the later weeks of illness. So these are the complications which one needs to know. What do you do for the treatment? That was what was asked over here. So do we immediately hospitalize? Not needed. Incision and drainage not to be done. Mouthwash, yes, saline mouthwashes are recommended. But the ideal treatment over here would be give antipyretics and send the child home, because it's a very painful condition. You also have to give painkillers to the child and antipyretic for decreasing the fever, right? Saline mouthwashes can be done. So people who have marked C, in this case, there's a very close call between the C and D option, but you have to choose one. Then you will always go for give antipyretics and send home. Of course, saline mouthwashes is not a wrong option, but given the choice, we would go for D rather than C, right? Okay, then let us come to the next question. Which of the following condition is associated with hypocalcemia, TOF, thymic hypoplasia and microdeletion in chromosome 22 Q11.2? So this is a diagnosis which has been served on a platter to you. Yes, straight away the diagnosis becomes DiGeorge syndrome. You should know it is known by a mnemonic known as catch-22. Definitely 22 stands for the chromosome which is affected over here, which is the culprit, where the culprit gene resides. Deletion takes place. And catch, what does catch stands for? So let us see this. In fact, we have it over here. So catch C stands for cardiac abnormalities, and cardiac abnormalities are usually in form of conotruncal abnormalities. You can have either TOF or you may have something like truncus arteriosus. So these are the common cardiac lesions seen in this disease. A stands for abnormal facies, where you have very smooth philtrum, very thin lips, narrow palpebral fissure would be there, and there's more or less a flat mid face, and there's a box like or bulbous kind of nose. So these are abnormal facies. A stands for that. T stands for hypoplasia of thymus and T cell abnormality. C again stands for cleft lip or palate, and H stands for hypocalcemia. So you should be knowing these are the features of DiGeorge syndrome, right? And because of the hypocalcemia, the child may land up with neonatal seizure or tetany, right? So this is a very good synopsis of DiGeorge syndrome, and this is a child where you can see narrow palpebral fissure, smooth philtrum, very thin lips, and almost a flat facial profile. So this is a narrow forehead also, right? So this is DiGeorge syndrome for you. Coming to the other options, we know what is Down syndrome. You have clinodactyly, you will have sandal clap, you will have single palmar crease. Commonest congenital heart defect we all know is endocardial cushion defect, and this child is also at risk for developing annular pancreas and Hirschsprung's disease. Congenital hypothyroidism is extremely prevalent in Down syndrome. And what else do we see in Down syndrome is lots of GI abnormalities, as I already told you, Hirschsprung disease and atlantoaxial abnormality or instability also, right? Turner syndrome, we all know this is a XO phenotype would be there. Here we have trisomy of 21 chromosome, right? Trisomy of 21 chromosome is seen in Downs and Turner is XO genotype would be there, and this child would be having female child, short stature, would present to you with primary amenorrhea, and when you investigate, you get to see streak ovaries. On visual examination, what you see: wide carrying angle, shield chest, widely spaced nipples, low posterior hairline would be seen, right? So these are all features of Turner syndrome, and the most common congenital heart defect over here is the bicuspid aortic valve followed by coarctation of aorta, right? Okay, now what about the Prader-Willi syndrome? Yes, Prader-Willi syndrome occurs because of the thing from the paternal side is missing. And what is one chromosome 15, which you know, in a pair of chromosomes, one member of the pair comes from the maternal side and the other member comes from the paternal side. Here the paternal side of chromosome 15 is missing, and therefore that affects the functioning of many organs, and the primarily organ affected is hypothalamus. So because of this, these children will have problems with the sexual development, and they would also have, you know, because of hypothalamus affection, they will have more and more hunger pangs, and so they eat more and more, and they develop extreme forms of obesity. And then you can imagine the complications of obesity that is prevalent in Prader-Willi syndrome. Other than that, they have temper tantrums, and they have stubbornness, compulsive behavior, they have problems in sexual maturation. We have already visited that. They have problems with the sleep also. They have feeding difficulties. They are hypotonic, very, very important, and they have poor growth, again because the secretion of hormones from the hypothalamus is affected, so the growth is also affected in these children. And they have a typical facial profile, which you can see: epicanthal folds, flat nasal bridge, small palpebral fissure, again in this case also smooth philtrum and thin upper lip. So this is Prader-Willi syndrome for you. Very commonly you will find Prader-Willi syndrome associated with obesity, remember that, right? Okay, then the following signs would warrant further evaluation of developmental status in a healthy 6-month-old infant. Let us see all the options. Does not probe with 4 fingers. Remember, this comes around 8 to 9 months, when you know they would be starting, especially around 9 months, when they would be starting off pincer grasp. Then the 4-finger probing comes. So again, this is not a cause of concern because the child is just 6 months of age. Does not speak bisyllables. We know bisyllable speaking comes at again 9 months, and at 6 months the child is supposed to speak monosyllables. So again, not a cause of concern at all. Has stranger anxiety. We know this. Stranger anxiety is quite rampant in 6 to 7 months of age, right? So since if the child is having, a 6-month-old child is having stranger anxiety, that is very much expected of his age. That's a developmental milestone for him. Has no social smile. Definitely, I would like to strike this out. Yes, this is the answer. Has no social smile, because you know social smile starts at around 8 weeks of age, and if the social smile has not come till 6 months of age, it's a cause of concern. The upper limit for social smile appearance is taken as 6 months. So if it has not come, yes, it's a cause of concern and requires investigation into this matter, right? Okay, so A is the answer over here. A baby was born limp and apneic with a heart rate of 40 per minute. What will you do next? See, whenever they give you a very typical, value of heart rate, always remember, you will never perform initial steps. Remember that. So if initial steps was one of the answer, you would not perform, because heart rate evaluation takes place with the performance of the initial steps. And you know what is initial steps? It is providing warmth, receiving baby in a warmed towel, and then putting the child under the radiant warmer, drying the child, positioning the mouth, suctioning the secretions if there are any. So during this time, there is evaluation of the heart rate and the respiratory effort, and then you come up with some or the other conclusion. The heart rate is this much and the child is limp and apneic, right? Then what do we do? So the next step obviously is giving bag and mask ventilation. So this was purposely put. Why 40 was put was to trap you into marking for starting chest compressions, because everybody has been taught that less than 60 per minute start chest compressions. That's a wrong answer. Please remember, chest compressions have to be started only after 30 seconds of effective bag and mask ventilation. And what is meant by effective bag and mask? Bag and mask ventilation, that is producing a chest rise. If it is not producing a chest rise, then you do the ventilation corrective steps, which is known as MR SOPA, which goes by the name of, the steps have been given a mnemonic, that is MR SOPA. So MR SOPA has to be done. After that, you ensure there is chest rise, do 30 seconds of bag and mask. Even after chest rise of accompanying bag and mask ventilation, if the heart rate is still less than 60 per minute, then you perform chest compressions. Here we have not done anything. So the first step would be, please remember, this is the wrong answer. This is the correct answer, bag and mask ventilation. Giving oxygen to an apneic baby would not be helpful at all. And umbilical artery catheterization, umbilical vein catheterization is not at all recommended at this point, because this child needs to be resuscitated right now through bag and mask ventilation, right? So no medications, the turn of medications would come only after bag and mask ventilation. We proceed to chest compression, and even after chest compressions, if the heart rate is less than 60, then we have to give medications, and for that umbilical vein catheterization would surely come into play, right? So the correct answer over here is bag and mask ventilation. This is the complete neonatal resuscitation protocol, which we have discussed umpteen number of times, right? Okay, so mother is worried that her newborn has not passed meconium since 6 hours after birth. How much time can we wait for the passage of meconium after birth? Remember, 99% of term infants. So this is a line I'm quoting from Nelson. 99% of term infants pass meconium within 48 hours of birth. Remember this, and therefore we have to wait till 48 hours. If the same question would have been asked for urine, remember the waiting time for urine in this case would be 24 hours. So for urine we wait for 24 hours, and for stool or for meconium we wait for 48 hours. You have to remember, either of this could be asked in your exam, right? Okay, then so the correct answer over here is the C option. Then let us come to the next question. Has been asked multiple number of times. In a newborn with following presentation, the mode of inheritance and suspected embryological abnormality respectively is, right? So they are asking you first the inheritance. Remember, let us look at the pic. This is a typical pic of anencephaly. You should know this. This is anencephaly, or for that matter, any other neural tube defect has a multifactorial causation. It does not follow Mendelian pattern of inheritance, very importantly. And multifactorial, it can be because of intake of drugs by the mother like valproate. It can be because of hyperthermia in the mother during early gestational period. It can be because of many other reasons, and the most prominent being the deficiency of folic acid, and hence the folic responsive enzyme pathways are not activated to sufficient degree, and hence the child lands up with neural tube defect. Now neural tube defect, they occur because of the failure of spontaneous closure of neural tube during the 3rd or 4th week of intrauterine development. You should know this, right? So the neural tube is supposed to close down during 3rd or 4th week. Now neural tube defects are actually classified into 2 categories. We have cranial neural tube defect, and we have caudal neural tube defects, right? So cranial neural tube defect is there, and caudal neural tube defect is there. Caudal neural tube defect is because of the failure of closure of posterior neuropore. Remember this. This can be asked next time in the coming exam. And cranial neural tube defect is because of failure of closure of anterior neuropore. And if both anterior and posterior neuropore do not close, then the complete neural tube is left as such. Then we get to see something known as craniorachisis, right? This is another where you have complete absence. So this is anencephaly with exposure of the spinal cord in the upper region of the trunk. So this is what is a neural tube defect all about. So therefore the correct answer in this case will be multifactorial and That is the pattern of, seen causation and failure of closure of anterior neuropore, because we are dealing with the cranial neural tube defects, that is something like anencephaly. If the same is asked with respect to, let us say, spina bifida, then you will say it is because of the posterior failure of closure of posterior neuropore, right? Okay. Then let us move on to the next question, and that is, in a neonate, there was discharge of meconium from the umbilical stump. Which of the following conditions should be considered? So, first of all, let us strike out the options which are very obviously not the answer. First of all, it is uretrocele. Why uretrocele? Uretrocele is not visible macroscopically. It is seen as dilatation of the terminal part of urethra, and it is not seen outside the body. We have to do something like ultrasound abdomen or maybe voiding cystourethrogram to catch this condition and to make a diagnosis. Usually it presents either antenatally, it is caught antenatally, or if it is not caught antenatally, then postnatally it presents with frequent febrile UTIs. In that case, we have to go for ultrasound abdomen or VCUG to make a diagnosis. So this is definitely not the case. Then coming on to Omphalocele. Omphalocele is extrusion of intestinal contents out from the umbilicus to the exterior, and this is covered by a sac, and that sac is the peritoneal sac. Sometimes you may have even liver coming out in that sac, and so there would not be any secretion of meconium or urine coming out from that place, right? So again, omphalocele is not the answer over here. Now we are left with the two options. Very, very importantly, remember urachus, remember like this, and remember urine. Yes. So if there is patent urachus, there will be outflow of urine from the umbilicus, from the site of umbilicus. There will be the urine, foul smelling fluid or foul smelling watery kind of fluid coming out. We know that is the urine coming out, and that is because of the patency of the urachus, or urachus, which communicates with the bladder. In this case, the other name for urachus is, we also know, is allantois, so that it communicates with the bladder, and this is supposed to involute by 5th or 6th week of gestation. But if it remains patent, then there is a continuity between the bladder and the umbilicus, and therefore we have the urine coming out. So this looks somewhat like this. See, so this is the bladder, if you can see. So this is the bladder, and this is the urachus, and this is communicating with the umbilicus, and therefore what we see over here, the urine coming out over here, right? So this is patent urachus. But what is asked in a question is the outflow of meconium. So outflow of meconium is because of the patent vitellointestinal duct. You should know vitellointestinal duct is a duct which connects the midgut with that of the yolk sac, right, with that of the yolk sac during the intrauterine period. So this duct is called the vitellointestinal duct. It is supposed to close down by 3 or 4 weeks of intrauterine life, but if it remains patent, then you have the connection of the intestine with the umbilicus being there, and therefore the intestinal contents would flow out of the umbilicus. So that is what we are seeing. We know in the intestine we have meconium, so there's meconium which is coming out of the umbilical stump, right? So there are various types of vitellointestinal remnants which we can see and which can trouble the child. So if the entire vitellointestinal duct is patent, and because of which the meconium is coming out from here, so let us say this is the umbilicus, so then it is known as vitelline fistula. If only the middle part of the duct is patent, and rest is flanked by cord-like transformation of the vitellointestinal duct, then this is known as vitelline cyst. And if the entire has been reduced to just cord, then it is known as vitelline cord. And then we have a very interesting thing over here, and that is Meckel's diverticulum. So that is only the part which is arising from the intestine is there and ends into a blind pouch. This is Meckel's diverticulum. And if the Meckel's diverticulum is attached with a cord with that of the umbilicus, then we call it Meckel's diverticulum with vitelline cord. So you should know this very well. Next time they might give you some variation in this question. And you should also know that urachus means urine, right? So urachus, when there's patent urachus, there'll be urine coming out. When there's patent vitellointestinal duct, then there'll be meconium coming out, right? And vitreointestinal duct is also known as omphalomesenteric duct. Very, very important. You have to remember this. Next time they may change the options for you, right? Okay. Then let us come to the next question, and that is a 6-year-old child presents with purpuric rash on the extensor surfaces of lower limbs as shown in the figure. And then we have, which is associated with arthralgia and abdominal pain, right? So this is a purpuric rash, and lab investigation done in this child would reveal all of the following except. So first of all, the diagnosis, yes, we know the diagnosis is a straightforward diagnosis of HSP, where you get to see abdominal pain, you get to see arthralgia, and you get to see the the non-palpable purpura, right? Very importantly, the platelet count is normal in this case. So we will see a normal platelets, and in this case kidneys are also affected. So the kidneys usually they have the presentation of nephritis, so that means they may have hematuria, they may have some amount of proteinuria also, but primarily it is hematuria, and there is deposition of IgA in the mesangium if you do a kidney biopsy. So we see the options. So indirect immunofluorescence on kidney biopsy specimens show deposits of IgA. We know this. Urine examination reveals mild proteinuria and reveals hematuria, right, and thrombocytopenia. So definitely this is the wrong option. This is the wrong finding. This is not seen in HSP. In HSP, the platelet number is absolutely intact, right? So this is a case of Henoch-Schönlein purpura, right? Okay. Then let us come to the next question. A 4-year-old child presents to you with difficulty in getting up from sitting position. On examination, his calves in both the legs are unduly prominent, and there is similar history in his maternal uncle. Very importantly, all of the following statements about this condition is correct except. So again, this is straightforward question for you. They are saying difficulty in getting up from sitting position. This is most likely they are describing the Goward sign. We know this, GOWER. Goward sign has been described. Remember, this is not specific to any disease. This is just a sign of proximal myopathy. Remember that, just a sign of proximal myopathy, and illness which would present to you with such a kind of presentation at 4 years of age is DMD, Duchenne muscular dystrophy. So diagnosis is DMD straight away over here. Is it an X-linked dominant disorder? No. Please remember, DMD is X-linked recessive. You are not supposed to forget the inheritance pattern of DMD. Very, very important, right? So X-linked recessive disorder, and that is why we know usually the maternal uncles are affected. The gene to the boys are affected, and the gene to the boy comes through the X chromosome, which is because of the mother. So mothers are usually carriers, and the mother's brother would be affected in this case, right? So these children are more prone to develop epilepsy as compared to general population. Yes, this is the correct statement, because you should know the dystrophin gene, which is the involved gene over here, is expressed in the CNS also, central nervous system also. So it is expressed in CNS, it is expressed in retina, and it is expressed in heart. So we know that in CNS, this is responsible for intellectual retardation and also risk of development of epilepsy, which is slightly larger than the general population. About heart, we know it leads to dilated cardiomyopathy. Very, very important. You should be knowing this. And what happens with the retina? It is still not clear. It is more in the experimental phase. More studies are being done to detect what happens when it is expressed in the retina. So serum CPK level is grossly elevated. Again, this is the correct statement. Why? Because you know CPK comes from the muscle. In fact, it is a dictum. A normal CPK goes against the diagnosis of DMD unless and until you are seeing this child in the later stage of the disease. So tomorrow, if let us say a 17-year-old child comes to you all wasted, a case of DMD, and you get to see that CPK levels, do not expect a very high CPK level, maybe normal, maybe below normal, because the muscles which are the storehouse of CPK have all been wasted, right? So therefore, serum CPK levels grossly elevated. That is a right statement over here. The involved gene dystrophin codes for sarcolemmal protein. This has been asked from you millions of times. So please remember this. This time I had changed the question a bit for you. Remember, the dystrophin gene affects the sarcolemmal protein in the muscle and hampers with the functioning of the muscle, right? So the correct answer, it was asked all of the following statements about this condition is correct except, so definitely the answer is A, because you know it's a X-linked recessive disorder. Okay, next, which of the following statement is true regarding pertussis? Whoop is a classical manifestation in infants less than 3 months of age. Is this true? Vaccine efficacy with regards to pertussis vaccine is more than 95%. Is this true? Azithromycin is useful for post-exposure prophylaxis, and the degree of polymorphonuclear leukocytosis correlates with the severity of cough. So what is true? Let us see. Whoop is the classical manifestation in infants less than 3 months of age. Remember, this is a false statement. Why? Because you know, in less than 3 months of age, they would usually present with apneic spells, either apneic spells or they would present with cyanotic spells, right? Or they do not have the characteristic whoop, or they may gag, or they may choke. So children who are less than 3 months of age do not present with characteristic whoop. Always remember this, right? What about vaccine efficacy with regards to pertussis vaccine? You should know the vaccine efficacy of pertussis vaccine per se is around 80 to 85%, and this is the reason, the pertussis component is the reason why we go for 3 doses of DPT. The efficacy, vaccine efficacy against diphtheria and tetanus is extremely nice. It is almost more than 95% or 90%, so as to say. But with pertussis, the vaccine efficacy is not much. It hovers around 80 to 85%. That's why we have to go for 3 doses. And remember, protective efficacy lasts only for 3 to 4 years and definitely wanes off by 12 years. So that is why it is said that adolescents and the adults are actually the carriers of this disease, and that is why the infants get it so easily if there is an adolescent or adult coughing and having pertussis in the family. So that is the reason, because the immunity, the vaccine immunity endorsed or imposed by the vaccine administration actually wanes off in the coming years of life. So that should be very clear. So again, this is a false statement. It is not more than 95%. Azithromycin is used for post-exposure prophylaxis. Very, very true. So all contacts who have come in contact with the case of pertussis should be given azithromycin for 5 days, and their movement also should be restricted so as to prevent the spread of the disease. So azithromycin is used. Even erythromycin can be used, but azithromycin is preferred. The degree of polymorphonuclear leukocytosis correlates with severity of cough. Nothing happens like this. In fact, you should know there is polymorphonuclear lymphocytosis. So lymphocytosis is seen and not leukocytosis in pertussis. You should know this. So anyways, again, this is a false statement. So the correct answer over here is azithromycin being used as post-exposure prophylaxis. It is used for treatment also. Remember, less than 1 month of age, you have to give azithromycin. You cannot give erythromycin. You know this. This question has come in the last NEET examination. You should know, because erythromycin increases the risk of idiopathic hypertrophic pyloric stenosis. Remember this, if given in children who are less than 1 month of age. So this is particularly notorious in children who are less than 1 month of age. You can give erythromycin to the older children, no problems, but in less than 1 month, you prefer giving azithromycin. Remember that, right? Okay, then a 2-year-old boy presented with cough, fever and difficulty in breathing. His respiratory rate is 50 per minute. There is no chest in drawing. Auscultation of chest reveals bilateral crepitations. The most probable diagnosis is. Now, please remember, if this is a 2-year-old boy, very importantly, remember the age, because age is important for remembering the cutoffs for tachypnea. You know, between 1 to 5 years of age, the respiratory rate of more than 40 per minute is taken as tachypnea. We know this, right? In the less than 2 months of age, the cutoff is 60 per minute, right? Anything more than 60 per minute, and 2 to 12 months of age, the cutoff is more than 50 per minute. We know this, right? So he's a 2-year-old boy and definitely his heart rate is more than 40 because it is 50. So definitely he is having tachypnea, but he is not having chest indrawing. So remember, tachypnea plus minus chest indrawing or the reverse chest indrawing plus minus tachypnea classifies this child as having pneumonia. Very importantly, there is no term as very severe pneumonia. This is a wrong option. Either it is very severe disease or it is oblique severe pneumonia. So this is not severe pneumonia. Why it is not severe pneumonia? Because along with chest indrawing or tachypnea, the child must have general danger signs, right? So general danger signs mainly in the form of unable to drink, convulsions, abnormally sleepy or lethargic, stridor in unusually calm child, or severe malnutrition. If these risk factors or these factors are coexisting along with tachypnea plus minus chest indrawing, then we know this is severe pneumonia, and then obviously the management is different. That means you will give the first shot of parenteral antibiotics and refer the child urgently to the hospital. In this case, what we have classified, because the child is having so the child is having fast breathing in our case, though this classifies as pneumonia. In this case, what we have to do, we have to start the child on oral antibiotics for 5 days, but we have to tell the mother to revisit in the coming 2 or 3 days just as to see whether the pneumonia is progressing or not, right? So therefore, here the classification is pneumonia. Is it no pneumonia? Definitely this is not no pneumonia or cough and cold because the child is having fast breathing, right? So the correct answer over here will be the child is having pneumonia, right? This is the C is the correct option. Now coming to the next question, and that is a 2-year-old child weighing 6.5 kg, presents in casualty with history of vomiting and diarrhea for the last 2 days. On examination, skin pinch over the anterior abdominal wall goes back very slowly to its original position. Interpretation of skin pinch test in this child will be, is it no dehydration, some dehydration, severe dehydration? Skin pinch cannot be evaluated in this child. Remember, look at the age of the child and the weight of the child. You should know at 2 years of age. Remember, the expected weight of this child is around 12 kg and the observed weight of this child, as you can see, is 6.5 kg. So this is almost 50% weight for age, which falls in the category of severe malnourishment, of severe malnutrition, right? So in severe malnutrition, had this been a normal child, then the skin pinch going very slowly would have classified this child as severe dehydration. But this is a child with severe malnutrition, and in that case, the skin pinch is of no value. It does not give you a true estimate of hydration. Please remember this. It does not give you a true estimate of hydration at all. Why? Because the skin elasticity is anyway decreased in this child. Why? Because of the loss of subcutaneous fat. And anyways, this child will have a decreased recoil or a prolonged recoil, the skin pinch will go down slowly even if the child's hydration is intact. So this will in fact confuse you or make you overdiagnose hydration. Therefore, it is recommended that in children with severe acute malnutrition, please do not take skin pinch as a marker of hydration. Put your finger inside the mouth, roll it in the inside of the cheeks, and the moistness of the cheek from the inside. That means the oral mucosa will give you a fair idea about hydration. However, there are other features also which will help you estimate hydration or dehydration in this child, and that can be in form of the temperature of the skin or the pulses, right? Pulses volume or the pulse rate. All these are, and of course the presence of anuria or oliguria. These are all markers of whether the fluid status of this child is intact or not. So these are the important signs that should be relied upon while assessing hydration. Very importantly, oral mucosa and not the skin pinch. So in this case, your correct answer should be skin pinch cannot be evaluated in this child, right? Okay. Then let us come to the last question. During initial assessment of an unconscious pediatric patient, ABCD includes all of the following except. So remember, according to PALS, that is Pediatric Advanced Life Support, we have A, B, C, D, and A stands for, we know, airway, B stands for breathing, C stands for circulation. What does D stand for? So D stands for something known as disability. And what do you mean by disability is that you have to assess the neurological disability in any child who has presented to you in such a condition, right, who requires your services as a PALS provider or pediatric advanced life support provider, right? So neurological disability has to be ascertained. And how do you do that? So we have many, scores for this. We have the AVPU score, we have the Glasgow Coma score, and very importantly, the pupillary light response. So first of all, even the pupillary light response will tell you whether the neurological system is intact or not. And then you can go for AVPU scale. We know what does it stand for. A stands for awake, or that means the child might be sleepy but is responding when you are calling out, right? So awake, either the child is awake, then V is responding to voice. Voice can be normal voice or yelling. Both of them can be there in V. Then P is responding only to pain, not to voice but only to pain. And U stands for total unresponsiveness, right? So AVPU scale is one of the way of assessing the neurological ability, and the other is the Glasgow Coma scale, which should know that this has been modified. There's a separate kind of GCS scale for infants and separate type for children. So these are the three ways in which you assess the neurological disability. Of course, there's a fourth scenario also over here. APCDE is the correct this thing. What does E stands for? They may ask you in the next exam. So E stands over here for exposure. What do you mean by exposure is that you have to expose, that means open the clothes of the child and thoroughly examine the body of the child. And this is usually done when you are called to attend to victims of trauma. So you have to look for any trauma, features of trauma, or maybe burns, or maybe fracture, right? Or sometimes you may also have to look for, some markers of the illness because of which the child is in present state. So maybe they may be bruises, they may be petechiae, which will give you an just a fair idea of what is going on in the child, with the child apart from the such condition of the child. So because of this, you should know that exposure, E stands for exposure, where you have to look for all this. But please remember, this should also come to your attention that in exposure, you should be aware of the fact that the children, they lose the core temperature twice as much quickly as the adults do. So they should be adequately then covered as soon as you examine the child and given warmth. Otherwise, the child will further deteriorate, right? So A, B, C, D, E, remember this mnemonic. This is for how to assess the child. A stands for airway, B stands for breathing, C stands for circulation, D stands for neurological disability, assessing neurological disability, and E stands for exposure. That means exposing the body of the child, opening the clothes and looking for symptoms of trauma, fracture, burns, and other disorders which you can see on skin examination, right? So this is it for now. Keep MCQing. As I always say, you can win the game. It is very near to your thing. The date has almost come near. So keep MCQing and I'm sure you will ace it. Thank you. Okay.
Hi friends, now we start psychiatry discussion. Question number 1. A 40-year-old male patient come to psychiatry OPD with complaint of having repetitive thoughts. Point it out. Repetitive thoughts of hands are dirty, my hands are dirty, my hands are dirty. These thoughts are coming in his mind. And patient says that these thoughts are my own thought. Patient want to stop these thoughts but unable to stop these thoughts. That's why anxiety develop. Go to washroom, wash his hand. Thoughts are coming, obsession. Washing hand, compulsion. Obsessive compulsive disorder. Obsession are disorder of possession of thought. What I said? Obsession. So this is example of OCD, obsessive compulsive disorder. Obsessions are disorder of possession of thought. Mnemonic. Possession, obsession. So you can easily remember possession, obsession. Okay. Other than that, you will remember flow of thought. Increased flow is seen in flight of idea, seen in mania. Form of thought. Disorder of form of thought means formal thought disorder seen in schizophrenia, and most characteristic formal thought disorder is neologism. Question is asked. Neologism, coining of new word whose derivation cannot be explained. Question is asked, a patient says this is omni-micro. So this is neologism commonly seen in schizophrenia. Disorder of content of thought, delusion. Question. There is a controversy that obsession or disorder of position of thought or content of thought. Few textbooks says D, position, few says C. So better to go with position. Position as mnemonic obsession. Second question. A 50-year-old man presented in emergency with severe alcohol withdrawal symptoms. Yes. Tremors in the body, nausea, transient tactile auditory hallucination. Although in delirium tremens, I am discussing delirium tremens. In delirium tremens, there are usually visual hallucination, but tactile and auditory hallucination may be present. Patient is not oriented to time, place, person. This is catching point. I will highlight. Wherever you find acute disorientation, or clouding of consciousness, or altered sensorium, these are acute. Diagnosis is delirium. But in question, if these symptoms or these points are given after alcohol withdrawal, then it would become delirium tremens. And delirium tremens best treatment is IV lorazepam plus IV thiamine. Okay. In this question, they have pointed out that there is no time to carry out investigation liver function test. What does it mean? What is the significance? If alcohol withdrawal patient liver function is deranged or there is no time to carry out liver function, better to give lorazepam or oxazepam. Okay. So question has been asked, they will give alcohol withdrawal, they will ask that patient is in periphery, in PSC you are sitting, there is no lab facility, which benzodiazepine you will prefer, either lorazepam or oxazepam. So in this, answer is B. Now, which of the following best describe paradoxical suicide? Most common cause of suicide is depression. Most common cause, depression. Most common method, hanging. Attempt suicides are more common in female. Complete suicide is more common in males. Suppose a patient is having severe depression, having suicidal thought, low energy. You started treatment. Patient improves. Energy increases. But suicidal thought is still present. Means previously energy was not there. He wanted to commit suicide. He thought, who will go to market? Who will buy the rope? Who will hang? But now you started treatment, energy came, now thoughts are there, now he will go to market, will buy rope, will hang himself. Means suicide rate is high in recovery phase. This is called paradoxical suicide. Paradoxical suicide rate is high in recovery phase. Next question, which antidepressant used for nicotine dependence? Yes, bupropion. This is NDRI, norepinephrine dopamine reuptake inhibitor, antidepressant used for nicotine dependence. One more question, varenicline, also used in nicotine dependence. Which one is better? If I write E is better than D. Okay. More effective, varenicline. But it is associated with suicidal thought. Question has been asked. Yes. Although few literature says that no suicidal thoughts with varenicline, but question has been asked, it has side effect. Next, so in this question answer is D. A 27-year-old female with chronic schizophrenia is admitted to psychiatry ward. She mimics the examiner's speech during the interview. Examiner asks, what is your name? Patient says, what is your name? Where do you live? Where do you live? means same. Echolalia, echo of language. Echolalia means echo of language. Okay. Echopraxia. Yes, suppose examiner do like this and this, patient do like this and this. Examiner became angry and said, put this patient on ECT. Okay, he is not angry. He diagnosed that echolalia, echopraxia, posturing, I will discuss posturing, are present in catatonia. And treatment of choice of catatonia is ECT, electroconvulsive therapy. Initial treatment of catatonia is lorazepam injection. Both are question. What is posturing? Patient maintain abnormal posture for a long time. Suppose he is standing like this. That is posturing seen in catatonia. What is perseveration? Yes, this is important point. Question has been asked. Suppose you ask the patient, what is your name? Patient says, my name is Mahesh. Where do you live? My name is Mahesh. What is your father's name? My name is Mahesh. Means same thought is continued. Point it out. If patient repeat his own words, own sentences, that is perseveration. If patient repeat the examiner's language, then it is echolalia. So in this question, patient mimics examiner. So this is echolalia. Thank you and best wishes.
Hi friends, I am Dr. Harmeet Goel, your Obs Gynae faculty, and I will be taking the Obs Gynae question discussion for this mock test. Hope you must have tried well for this mock test of FMGE exam. Now, my first question is, according to recent updates of MTP Act in 2021, a registered medical practitioner can terminate pregnancy up to how many weeks? So, the options given are 18 weeks, 20 weeks, 24 weeks or 26 weeks. So, the latest MTP Act 2021, it says that MTP can be terminated up to 24 weeks. Okay, so the answer is 24 weeks. If I go by MTP Act 1971, the MTP was allowed or it was legal when terminated in less than 20 weeks. So that is a change. Plus, this amendment was made because unfortunately, if there is a rape victim, or unfortunately, if it is an unmarried girl, or unfortunately, if there is a certain congenital anomalies which can be detected after 20 weeks, then in that case, there was no provision for termination of pregnancy if the pregnancy has gone beyond 20 weeks. Okay. So nowadays, even if to, give relaxation, so the MTP Act, the upper limit has been increased to 24 weeks. For example, if there is a rape victim and by chance the pregnancy was not being detected, or she is such a younger age group that she is not aware of amenorrhea and the pregnancy has crossed 24 weeks, then what? In that case, there is a special board which includes a gynecologist, a pediatrician, a radiologist and a gazetted officer by the state or by the union territory. This case goes to the medical board, and if the medical board takes a decision, yes, the termination should be taken, then doctor has to do the termination. So this is important. Now, next question, which of the following is an absolute contraindication to the IUCD insertion? So this mock test revision or discussion is very, very crisp and concise to boost up your confidence. So which of the following is an absolute contraindication to IUCD insertion? Let us check history of previous PID, unexplained vaginal bleeding, previous ectopic pregnancy or HIV positive status. If I look at these options, the best answer I can select is unexplained vaginal bleeding, because in this case, unexplained vaginal bleeding, you have to rule out underlying cause for bleeding. Okay, and you're supposed to investigate. It might be a case of underlying genital tract cancer. Whereas if you look at the history of previous PID is not an absolute contraindication. They say if there is present history of PID or STD, or it is acute PID within 3 months, then that is an absolute contraindication for IUCD insertion. Okay. So I am going to mark the answer as unexplained vaginal bleeding because it can be a presentation of underlying genital tract cancer. For example, it may be a presentation of endometrial hyperplasia, endometrial cancer, or cancer cervix, which is most common cancer of female genital tract in developing countries like India. All of the following regarding non-scalpel vasectomy are correct except. So nowadays, there is NSVT technique is used, non-scalpel vasectomy. Okay. So there's a special instrument under a local anesthesia to make a hole in the scrotum, take out the vas deferens, cut it, ligate it and cut it, and then on the other side, and no stitches are being applied, let it heal by secondary intention. So this is the best method. And who all are doing the non-scalpel vasectomy? This is the person motivated, comes to the surgery department and get the vasectomy done and goes home. So let us see the options. Sexual function following healing is rarely affected. This is true. Hematoma in up to 5% of the subjects may occur. This is true because newer technique is better than the conventional vasectomy. Then recanalization is possible. Yes. So although it is a permanent method of sterilization, but any case the person wants to get it recanalization done. For example, there is a divorce case, or the wife has died, or both the children had died. So he wants recanalization, so that can be very well done. Now, sterility immediately after vasectomy, this is false statement. Okay, because after vasectomy, the couple has to take up the backup method for at least 3 months because sperms can stay in the tract and failure of sterilization can take place. So, for 90 days, the couple has to use additional method of contraception. Next, which of the following is an indication for surgery in ectopic pregnancy for a woman who is desirous of another pregnancy? Now, what is the indication for surgery and which is the surgery that can be preferred in case of unruptured ectopic pregnancy? Because if it is a ruptured ectopic pregnancy, we are going to go for immediately laparotomy. Now, patient wants to continue the pregnancy. Ectopic, this is not possible because if it is an ectopic pregnancy, we have to terminate. Ectopic pregnancy mass is more than 4 centimeter. This is against, I am not, very happy about this statement. Serum beta HCG levels are less than 1000 milli-international units per ml or unruptured ectopic pregnancy. Okay. Now, for unruptured ectopic pregnancy, if suppose in this question I add cardiac activity, then if cardiac activity is present, even then surgery can be done. So, in this case, if ectopic pregnancy mass is more than 4 centimeter, okay, in that case, it is a contraindication to the medical treatment and we have to go for surgical treatment. Now, what surgical treatment I am going to do in this case? In this case, I am going to do a laparoscopy and laparoscopically, I am going to do salpingostomy. Laparoscopically, I am going to do salpingostomy. So, this is a fallopian tube and there is ectopic pregnancy even if the ectopic mass has more than 4 centimeters. Okay. In that case, medical management cannot be done. Other options like serum beta HCG less than 1000, very well the medical management can be done. So, in this case, I am going to give a cut onto the fallopian tube, take out the ectopic pregnancy and let it heal by secondary intention. The more you stitch, there is more chances of adhesion and more chance for, infertility later on because of adhesions. So, the answer here is ectopic mass more than 4 centimeters. A lady presented with complaints of foul smelling greenish white discharge. Whiff test is done and discharge was positive. So positive whiff test, foul smelling vaginal discharge and clue cells present. Okay, what is this criteria? This is Emsel's criteria, and Emsel's criteria is for bacterial vaginosis. Okay, and pH is more than 4.5. Okay, so which is the drug for bacterial vaginosis? The drug for bacterial vaginosis is metronidazole. So I am going to mark the answer as Gardnerella vaginalis and the treatment is metronidazole. One thing is, it is not STD. It is not STD, so there is no need to treat the partner. Clear? Next. A lady with infertility undergoes laparoscopy for the purpose of assessment of her pelvic anatomy. Okay, so she is a case of infertility. She has undergone laparoscopy. For the tubal patency, a chromotubation involves pushing the dye from the cannula into the cervix. Okay, so which cannula is used? Which cannula is used? It is Leash-Wilkinson cannula. Leash-Wilkinson cannula is used for HSG. Okay, and what is a dye for laparoscopic chromotubation? So dye used for laparoscopic chromotubation is a methylene blue dye. So if the tubes are patent, the dye will enter into the fallopian tube and free spill of dye is checked by a doctor doing a laparoscopy. So it is a test or gold standard investigation for tubal patency is laparoscopic chromotubation and the dye used is methylene blue. Next, in colposcopy, which color filter is used? So always remember it is a green color filter. What do you apply in colposcopy? It is 3 to 5% acetic acid. 3 to 5% acetic acid, and the abnormal area is aceto white. So you use green filter to, like during laparoscopy. Next, to look for the lesion. Now, lady passes urine while coughing or laughing. So while coughing or laughing, she is passing urine. What is this called as? This is called as stress urinary incontinence. So this is a feature when bladder neck is prolapsing in the vagina. So this is a symptom of stress urinary incontinence. How do you differentiate, or what is the best surgery, best treatment of choice for stress urinary incontinence is TOT, transobturator tape. Transobturator tape. And the differential diagnosis of stress urinary incontinence is true incontinence of urine. That is a feature of vesicovaginal fistula. Next, drugs for medical abortion. Mifepristone 200 milligram and methotrexate. No, this is not done. Methotrexate is no longer used. Misoprostol and methotrexate, no. Misoprostol 200 milligram, mifepristone 400 microgram, wrong. So the correct answer is misoprostol 800 micrograms after 48 hours and mifepristone 200 milligrams. Okay, so medical abortion by this way can be done up to 9 weeks of pregnancy. Okay, so best is you give mifepristone 200 milligram oral, after 48 hours misoprostol 800 micrograms vaginal. This is followed by abortion. So what is misoprostol? Prostaglandin E1. What is mifepristone? Anti-progesterone. Anti-progesterone. Next, A young girl complains of non-attaining menarche, presents with periodic abdominal pain to the hospital. On examination, the following lesion is seen. Now, what is this? This is hematocolpos, and the condition is called as congenital cryptomenoria. So, this question has been asked plenty of times in the PG as well as in FMG exam. So, this condition is imperforate hymen, and the treatment is cruciate incision and drainage. Mind it, here secondary sexual characters are normal, breast is normal, axillary hair, pubic hair are normal, per rectal examination, uterus is present. So, it is imperforate hymen hematocolpos, and the condition is called as congenital cryptomenoria. And the incidence is 1 in 2000 girls. Next, which of the following is the treatment for decubitus ulcer for genital prolapse? This is again a recently asked question. When the uterus or the cervix is lying outside the vagina, okay, the venous return gets obstructed. So, there is venous congestion. And because of venous congestion, there is formation of decubitus ulcer. Okay. Now, what is the management of decubitus ulcer is packing. That means take a tampon and deposit the cervix back into the vagina and do glycerin acreflavin packing. Glycerin acreflavin packing. Next, an intern conducts a delivery. Immediately after delivery, the mother experiences breathlessness, hypotension, tachycardia, collapses, and per vaginum examination is normal and there is no excessive bleeding. If there is no excessive bleeding and lady has collapsed after delivery, it is not PPH. It is not postpartum hemorrhage. And since there is no history suggestive of abruptio placentae, or it is a dead fetus, or it is a preeclampsia, so this is not the presentation of DIC. Okay. And in this case, uterine inversion, I will say, if there is mismanaged third stage of labor and the shock is out of proportion of blood loss. So, that history is not going in favor of uterine inversion. So, if a lady has delivered the child and she has become breathlessness, hypotension, tachycardia, collapses, this is none other than amniotic fluid embolus. And differential diagnosis you have to keep is pulmonary embolus. Here the mortality is very high. Next, a female has previous history of cesarean section and prolonged labor. She is hypotensive, fetal heart rate cannot be heard. Okay, she is a case of previous LSCS. Okay, previous lower segment cesarean section. She is in prolonged labor. She is hypotensive. That means BP is falling. Fetal heart rate not localized, and fetal presenting part felt very, very superficially. So, this is clear-cut history suggestive of rupture uterus, because previous LSCs, somebody has given trial of labor. Now, mother has gone into shock. Fetal heart rate is not localized or cannot be heard, and fetal parts felt very, very superficially. That means uterine rupture has occurred. So, in previous LSCS cases, you have to be very, very clear and give a short trial of labor, and earliest indication you should take up the patient for cesarean section. Now, 25-year-old female, para 1 L1, delivered 12 weeks back, gives a history of continuous vaginal bleeding, and she has history of DNC done after that in private hospital, but bleeding is continuing. So, if it has crossed 3 months, so it is not secondary PPH. Since the DNC has been done, it is not a succinturita lobe. DIC patient does not present like this, that for 3 months she will be bleeding. No. It is not normal lochia. Okay. Normal lochia is for 21 days. That means it is only, normal lochia is only for 3 weeks and this is 12 weeks. So I am suggesting this is a presentation of gestational trophoblastic neoplasia and might be this is choriocarcinoma, okay, where the lady has delivered a child and after that there is bleeding. They thought that it is maybe some retained products of placenta, so they have done DNC, but bleeding is continuing. So in that case, they have to get the titers of beta HCG levels done, and if there is increasing titers, then it goes in favor of the choriocarcinoma. Next, 25-year-old primary gravida is on lithium for treatment of psychiatric illness for last 2 years. Okay, the most common anomaly seen in the fetus whose mother is on lithium is always abstain anomaly. Fine. So what is an answer to this question? It is abstain anomaly. Next, 26-year-old female with mechanical valve on warfarin therapy and her pregnancy test is positive. The best advice to her: continue warfarin throughout pregnancy, replace heparin with warfarin in pregnancy, discontinue all anticoagulants. Warfarin is contraindicated in pregnancy and lactation. So answer is replace heparin. Okay. The latest edition of Williams says heparin is safest if you can manage and give. It can be given throughout the pregnancy. Low molecular weight heparin can be given throughout the pregnancy because it do not cross placenta. But what we follow is less than 12 weeks is heparin, 12 to 36 weeks is warfarin, 36 weeks to delivery is heparin, after delivery warfarin. So this is the way, the regime of anticoagulation in cases of the mechanical valve patient we follow. First trimester heparin, then warfarin, then heparin, and then finally after delivery the warfarin. Next, the complication associated with intravenous bolus injection of oxytocin. Oxytocin is always to be given in IV infusion or intramuscular bolus in cases of active management of third stage of labor according to WHO guidelines to prevent PPH. So if you give IV bolus, it will cause hypotension. Okay, if you give IV bolus, it will cause hypotension. So route of administration of oxytocin is intramuscular bolus or in the IV infusion. Next, G for gravida for para 0A3. So this is a case of bad obstetric history. Okay, 4th time she is pregnant and she has 3 abortions and no live issue. So 24-year-old female at 22 weeks of pregnancy with previous 3 mid-trimester abortions. Mid-trimester abortion, if there is a history, that raises the suspicion of cervical incompetence. Okay. First thing, you think of cervical incompetence, Mullerian duct anomalies, and you can always think of the APLA, antiphospholipid antibody syndrome. Now, ultrasound was done, which is the safest investigation in pregnancy, and cervical length is 20 millimeter. So what is normal cervical length? Normal cervical length on ultrasound is 25 millimeter. So this is no other than, the answer is cervical incompetence, and you treat this by cervical encerclage operation. Now 24-year-old female at 32 weeks of pregnancy has blood pressure 160 by 110 millimeters of mercury. Her lab findings are significant for increased liver enzymes and increased LDH, low platelet. What is this? This is no other than HELP syndrome. Hemolysis, elevated liver enzymes and low platelets, and it occurs in severe preeclampsia in 10 to 15% cases. When such a finding is occurring where there is increased liver enzymes, increased LDH, low platelets, high blood pressure, then management of this case is termination of pregnancy. Okay, so this is HELP syndrome. So this revision session is just very, very crisp. So, you have already read everything. It is just to boost up your confidence. This session has been conducted. Fine. So, which of the following peak is responsible for ovulation? Peak A, peak B, peak C, or peak D? Peak A is for LH peak, which occurs 10 to 12 hours before ovulation. Peak B is progesterone peak. Peak C is estrogen peak, and peak D is FSH peak. So, the answer for this question is peak A, which is LH peak that occurs 10 to 12 hours before ovulation. And hormone responsible for LH surge is estradiol. Which of the following has a false positive BAAR body? Now, all the girls, the karyotyping is 46XX. All the boys, the karyotype is 46XY. So, if there is a second X present, that means BAAR body is present. So, all the males, no BAAR body. Okay. So, if there is a second X, there is a BAAR body. And how do you take BAAR body? That is from the buccal smear. So, let us write down the karyotype quickly. Turner syndrome, 45XO, no BAAR body. Trisomy 21. Again, Klinefelter syndrome, the karyotype is 47XXY. So, there is a false positive BAAR body. And androgen insensitivity is 46XY. Trisomy 21 is there are 3 chromosomes at number 21. Now, so answer to this question is C, Klinefelter syndrome. Next, a mother brought her daughter to gynae OPD with complaints of not attaining menarche. Hormonal status is normal FSH and LH, and examination shows normal breast development and pubic hair, and there is a small blind vagina and absent uterus. Karyotype is 46XX. So, what do you say? FSH, LH is normal, axillary pubic hair are normal, breast development is normal, so that means ovary is present, karyotype is 46XX, but she is not menstruating, uterus is absent. So, this is Mullerian agenesis. How do I rule out from androgen insensitivity? The karyotype given in the question is 46XX, which is a karyotype of Mullerian agenesis, and here uterus is absent, but ovary is present. So, secondary sexual characters are normal. Sphere syndrome, the karyotype is 46XY. This is undescended testis with uterus. Turner syndrome is 45XO, where there is no breast development. In severe syndrome also there is breast development absent, and in androgen insensitivity syndrome, axillary pubic hair are very sparse or they are absent. Breast is normal. So, this is Mullerian agenesis from the history, examination and investigation given to me. Next, 25-year-old female attends gynae OPD with complaints of secondary amenorrhea. Previous DNC was done and FSH level is 6. So, after a DNC and normal FSH finding, the patient has got secondary amenorrhea. This means a very, very vigorous curettage has been done, which has destroyed the endometrium. So, there is adhesion formation. What is this? Asherman syndrome. And what is the gold standard investigation? In this case will be hysteroscopy. So, the first investigation is HSG and the final gold standard investigation is hysteroscopy, because it will confirm your diagnosis and you are going to treat by hysteroscopic guided adhesiolysis. 37-year-old woman, unmarried, is on oral contraceptive pills. She is sexually active. Okay. She visits the gynecologist for a routine screening. Her mother had breast cancer at 55. Okay. And sister had ovarian cancer. So, there is a history of BRCA. Breast cancer and ovarian cancer. Breast cancer in the mother, so she is also at risk. Would you advise her stop OCPs, prophylactic surgery, mammograph every year, or genetic testing and BRCA1 gene testing? I am going to send her for genetic testing and BRCA gene testing, because if the gene testing is negative, then she is not at risk of breast cancer and ovarian cancer because of BRCA1 or BRCA2 gene mutations. Okay. Next. 30-year-old female presented with secondary amenorrhea. Urine pregnancy test was done, showed negative. Progesterone challenge test was done, no bleeding. Okay. So it is not PCOD. Estrogen followed by progesterone given, withdrawal bleeding seen. All of the following can be the causes for secondary amenorrhea. So if bleeding occurs after estrogen progesterone, the cause can be at ovary, or that is premature ovarian insufficiency, or the cause can be the ovary, that is Sheehan syndrome, or the cause can be at the level of pituitary, or the cause can be at the level of hypothalamus. Okay. In this case, premature ovarian failure fits into the diagnosis, pituitary adenoma fits into the diagnosis, and hypothalamic disorders, these all should be ruled out. Okay. But PCOS, withdrawal bleeding occurs after giving progesterone because there is a progesterone deficiency. Now, according to WHO, the maternal deaths is within 6 weeks after delivery. Okay. Now, identify the maneuver. This is first grip, fundal grip, second grip, lateral grip, third grip, pollic grip, and fourth grip is pelvic grip. So, we do per abdomen examination in a pregnant lady at term pregnancy, and we apply this grip to describe the lie and presentation. This maneuver is called as Leopold's maneuver. Okay, this is very important question. Next, identify the case. What you see is normal placenta and there is a blood. So placental separation is shown and there is a retroplacental clot. So this is no other than abruptio placentae. Sometimes they ask placenta previa in the image-based question. Sometimes they ask abruptio placentae. So most of these are very, very important questions. You should go through this final mock session before your exam. So that's all from my side, Obs Gynae. Hope you will do best in your upcoming exam. All the best.
So hi everyone, I hope you enjoyed the surgery CBoT part. So let us start with the discussion. The paper was a bit conceptual. Some questions were straightforward, very easy, but some question, yes, you would have used your brain or it would have twisted you. So let us start with a very simple question. A patient with long-standing multinodular goiter, developing hoarseness of voice. Now, why will you develop hoarseness of voice? Maybe because of the recurrent laryngeal nerve invasion. So, long-standing multinodular goiter can convert into malignancy. Now, here there are two malignancies. One is follicular and one is anaplastic. Now, what is the difference? So, then the next thing that you will see is features of local infiltration. Now, this is what is very, 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 very important. And along with that, pain may or may not be present. So, if it is present, pain is there or features of local infiltration are present, then that is suggestive of anaplastic. So, if you see here, hoarseness of voice is due to invasion of recurrent laryngeal nerve, which will be seen in anaplastic, not in follicular. This is what is very, very, very important. Now, medullary cancer will never arise. Medullary cancer can also have hoarseness of voice, but will not arise from a long-standing goiter. This is what is very, very, very simple. Next is a 40-year-old presents to you in the OPD with the lesions involving the left breast. What is the most probable diagnosis? So, if you see this breast, there is encrustation plus erosion of the nipple. So, encrustation and erosion involving the nipple areola complex. This is Paget's disease until and unless proven otherwise. This may be due to underlying. So, it may be due to underlying lobular cancer, ductal cancer. That is different thing. But yes, it's a Paget's disease. So, answer here is a straightforward. It's D. A 45-year-old lady presents with a hard mobile lump in the breast. So, whenever you have the lump in the breast, the next line investigation has to be radiology. Once you access a radiology, you will come to know, okay, there in this breast there is a lump. Now you can take out the tissue. So when you talk about the radiology, age is very important. Less than 35 years, you will prefer to go for USG. More than 35 years, you will prefer to go for mammography. So here, 45-year-old female presenting to you with a hard but mobile lump. So you'll go for mammography. The best investigation in this would be a true cut, but true cut can only be done once you localize. So first is localization, then is confirmation with histology. Next is 5-year-old presents to ER with burn. Now, according to the size of the palm, this burn surface area corresponds to what? Answer is 1%. So palmar surface with extended fingers corresponds to 1%. It's a straightforward go throwaway question. 46-year-old patient presents with breast cancer, history of breast cancer, diffuse microcalcification on mammography, intraductal cancer in situ. So this is a carcinoma in situ. What is carcinoma in situ? It is a tumor enclosed within what membrane, students? Basement membrane. And when such is the tumor, what should be done? You should do wide local excision with 1 to 2 centimeter margin, or this is also known as lumpectomy, or this is also known as quadrantectomy. So let us see. With the history of breast cancer shows a diffuse microcalcification, intraductal carcinoma in situ. What is the most appropriate management? Here, students, simple mastectomy is also right and quadrantectomy is also right. So if you talk about if this is a diffuse microcalcification, yes, I would prefer C over A in this case. Next is an adolescent boy with bilateral prominence of breast wants to get the breast removed. Which of the following incision should be the ideal? So this is a case of gynecomastia, and whenever we talk about gynecomastia, this is development of male breast. So breast tissue more than 2 centimeter is significant, and whenever you want to do this, what surgery you have to do? You have to do a subcutaneous mastectomy. So for subcutaneous mastectomy, you need to make an incision which should be hidden around the, you can say, natural contour. So you make a circumareolar incision. And what is the circumareolar incision? This is also known as a Webster's incision. So what is the answer? Incision along the areolar margin, circumareolar or Webster's incision. Now 28-year-old female with the following anomaly in the breast. What are you talking about? Right side breast is developed and this is hypoplastic. So I would say that this is nothing but amasia. Polymasia means accessory breast. Athelia means no nipple. Polythelia means supernumerary nipple. So here it's a straightforward case of amasia. Ideal graft for a leg injury with 10 by 10 centimeter exposed area. Students, 10 by 10 centimeters is a huge exposed area over the bone. And over the bone, the skin will not take. So you need a what, students? You need a flap. The word pedicle graft, the word graft here is a misnomer and basically it's a flap. So pedicled flap is what we go for. We will not go for any graft because it's the bone, and over the bone what will survive. So we have to take a flap. So basically it's an island graft or a pedicle flap. So option B is absolutely right in this case. Next is 40-year-old presents with fever, fatigue, diffuse painful swelling in the midline of the neck. FNA reveals epithelioid cells and giant cells. So this is a plasma reaction, fever, fatigue and diffuse painful swelling. So what are we talking about? We are talking about painful thyroiditis, and this is not a bacterial, this is subacute thyroiditis. It's painful, but if you see the plasma scenario, if you see the FNAC, basically it's having epithelioid and giant cell, which is seen in de Quervain's thyroiditis or subacute thyroiditis. This is what is very important. In Hashimoto's, the pain will not be there. Then it will be diffuse, yes, but lymphocytes would have been seen up along with the giant cells. So option D is not that correct. It is option B. 55-year-old male underwent cholecystectomy for gallstone. During the surgery, the patient developed arrhythmia. So pulse was irregularly regular, 160 per minute. BP was 80 by 50, and then temperature started to went. Hyperthermia, arrhythmia. In the operation, the most common cause is a thyroid dysfunction, and this is nothing but toxicity. So I would say that this is thyrotoxicosis due to poor patient preparation, and thyroid storm is what is. You can take all the options. How you'll explain hyperthermia? This is what is very important along with arrhythmia. So option A is right. Patient came with small solitary nodule in the right lobe of the thyroid. FNAC shows follicular adenoma. So students, you will go for hemithyroidectomy. It's a very straightforward question. Today we do only hemi or total, nothing like enucleation, nothing like subtotal. On physical examination, the patient has mild abdominal tenderness to palpation, particularly in the epigastric region. So there is pain in this region, as well as in the left upper quadrant. So in this, something belonging to pancreatic etiology it may be, as well as costovertebral angle. Lab shows hypercalcemia and ultrasound shows presence of kidney stone. So we are looking something belonging to pancreas, something belonging to parathyroid. What are we looking in this patient? So MEN 1, parathyroid, pancreas, pituitary. This is what is very, very, very important. So option A is the right answer. Option A is far better answer than option B in this case. Next is hypocalcemia immediately post-operative phase of, you can say, in which the parathyroidectomy has been done or parathyroid adenoma is done. So do you know that parathyroids produce parathormone which keep on excavating, you can say, the calcium from the bones via osteoclastic activity. So the moment the adenoma is removed, there is a rebound surge by the bone, where the bone starts to absorb all the, you can say, calcium available in the blood as a revenge, and this is what is known as hungry bone disease. So what is hungry bone disease? The concept of hungry bone disease is based on one very simple thing. What is that? Hypersensitivity of the bone calcium receptors, and this is increased uptake by the bone. So this is option B is right. Question is the most common site for rupture of abdominal aortic aneurysm. Now it's a very straightforward question, students. It is, aorta is a retroperitoneal organ. So first of all, this will not be there. Yeah. Posteriorly into the posterior retroperitoneum, it's not possible because there is no space there. It is left retroperitoneal area where it is frequently seen to rupture. So it is retroperitoneum and laterally into the left side of the retroperitoneum where it is frequently seen to rupture. So option A here is the answer. Now, what is the name of this bariatric procedure? So you have done a restrictive component where you have reduced the size of the stomach. Then you have attached a jejunum here and again the remnant part of the jejunum here. So what is this? Laparoscopic Roux-en-Y gastric bypass. How to identify this gastric bypass? This is what is very, very, very important. This is Roux-en-Y setting, and you have bypassed the stomach in such a way that it is restrictive also and malabsorptive also. This is what is. So this is LRYGB. What is LAGB? It is adjustable gastric banding. There is no such banding here. Roux-en-Y gastric bypass. It is LRYGB. Biliopancreatic division. When we talk about biliopancreatic division, it is nothing but we have a partial gastrectomy with a gastroileal anastomosis, and along with that ileoileostomy done 40 to or 70 centimeter proximal to IC junction. So here this is a Roux-en-Y arrangement. So it's a Roux-en-Y gastric bypass. Next is initial therapy for documented deep vein thrombosis. Students, in the initial phase of deep vein thrombosis, the first line of treatment is IV anticoagulants, then to be substituted with IV plus oral, and then stop IV, continue oral. This is what is. So intravenous heparin therapy. Thrombolytic therapy is not for all. It's reserved. Thrombolysis is reserved for proximal DVTs only. A patient undergoes prolonged and complicated pancreatic surgery for chronic pancreatitis. The most preferred route for supplementary nutrition, students, in pancreatectomy, or you can say when we talk about chronic pancreatitis, either the patient will undergo Whipple's or a Frey's procedure where you do LPJ. You know that delayed gastric emptying is a complication. So you need to do some alternative. And feeding gastrostomy is not possible here. Why? Because of the delayed gastric emptying. So we prefer to go for feeding jejunostomy. So FJ is the enteral nutrition route of choice. Next is during lap inguinal surgery, inguinal hernia surgery, the tacker was accidentally placed below and lateral to iliopubic tract. The moment you go here, below the iliopubic tract, you have all the nerves here. And therefore, there is entrapment of lateral cutaneous nerve. Along with that, there may be risk of injury to femoral nerve or femoral branch of genitofemoral nerve. So, it is lateral cutaneous nerve of thigh, which is the most commonly nerve injury during laparoscopic hernia repairs. This is what is very important. Next is, what type of knot is this? I always say this is a two-throw knot. This is one, this is two. These are two-throw knots. Look at the symmetry. So, if there are three ends, A, B, C. Let us select any one end. So, blue is below this red. Blue is below this red. Students, red is above the blue. Always look for the symmetry. So, this is a two-throw symmetrical knot. And since it's a two-throw symmetrical knot, this is a reef knot. This is what is very, 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 very important. A 45-year-old patient presents to you with ongoing massive hematomesis. The patient is hemodynamically stable. What should be the first line? Secure the airway. So, put the patient in recovery position and secure airway. This is one very important thing. Insert cannula and start the IV fluid. B is better than C. This is what is very, very, very important. However, both are done. So, secure airway, then plan the extra things. Following blunt trauma, a patient had renal laceration with urinoma. So, urinoma is a grade 4 renal injury. Now, grade 4 should either repaired. Now, however, the patient was not, you can say the kidney was not repaired, or the patient didn't undergo surgery. Even after 12 days, urinoma persisted, but patient is hemodynamically stable. That means there is no complication associated with this. So, what should be the next thing? Put a stent. This is what is the best thing. So, percutaneous exploration, no. Wait and watch. C is better answer than B in this case. This is what is very, very, very important. Had the patient been not stable, you would have gone for percutaneous nephrostomy and then you could have planned a surgery and a repair. So, C is better option than D. Next is, let us see this. Adult patient presented with hematomesis. Endoscopy revealed a growth at the pyloric antrum. CT scan shows pyloric antrum without infiltration or invasion into the surrounding structure and no evidence of distant metastasis. At laparotomy, growth was found to be neoplastic, involving the posterior wall of stomach and pancreas. So, if the pancreas involved, that means, and that too, the distal part, what needs to be done? Gastrectomy, and along with that, the splenectomy and pancreatectomy. So, D is far better than C. D, option D is far better than C here in this case. Next is, ulcero-proliferative lesion in the antrum of the stomach, invading the serosa with 10 enlarged lymph nodes. So, it is invasion of the serosa. So, you know, T1A is mucosal, T1B is submucosal, T2 into the muscularis, T3 into the serosa, and T4 outside serosa. So, one thing is clear, that it is T3. Now, the option, the paper that you would have gone is the options were corrected. So, option B is anyways the answer. But 2 to or 1 to 2 lymph nodes is N1, 3 to 6 lymph node is N2, and 7 or beyond that is N3. So, the option is T3, N3, M0. A gallstone gets impacted in which part of the CBD? Students, it is the ampulla, which is the narrowest, and ampullary stenosis due to the stone impaction has been seen. So, ampulla vater is the answer here. Now, a 40-year-old patient underwent open cholecystectomy. This is again very important. Procedure was reported to be uneventful. 100 ml bile was seen to come out of the drain. And the first post-operative day, the patient is afebrile and in anicteric. The abdomen is soft, bowel sound is okay. What to do? Wait and watch. Wait and watch because less than 100 is low output fistula. So, clinical observation, this is what is very, 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 very important. And you can add some bile acid sequestering agents also. Best treatment for a 4 cm moderate grade rectal cancer at the junction of lower and middle 1/3. So, here is the cancer with less than 1/3 circumference of the rectum being involved. What should be the best? What should be the best answer? Now, here there are two possibilities. You can go for, you can say transanal resection also. Transanal resection. Students, the next option, the first thing, radiotherapy as a primary therapy will not be there. Now anterior resection is not there. Had it been LAR, I would have said this is an answer. So it's not LAR. AR is only for the proximal growth. Middle 1/3 either LAR or APR. Students, trans anal excisions are not considered to be the first line management. It should be either LAR or APR in this case. Since the option doesn't match and if there is a healthy margin, I would go for APR. Else I would go for LAR. So LAR is not given here. So option D is far better answer than option C in this case. Next is Lalit, a female patient presents with pigmentation of the lips and oral mucosa with intestinal polyps. So GI polyps, buccal and perioral melanosis. What are you looking at? And this is a familial condition. That is what is known as Peutz-Jeghers syndrome. So option D is the right answer. 68-year-old man undergoes surgery for aortic aneurysm. 20 days later, he is brought to the hospital with upper GI bleed. What are you looking for? So aneurysm has been repaired. This is the graft, Dacron graft, and then there is, mostly they are infrarenal. So at the third part of the duodenum, they tend to rupture, and this is what is known as aortoenteric fistula. So aortoenteric fistula is the cause of massive upper GI bleed post successful aortic aneurysm repair. So option C is the answer here. 29 question is, a patient with obstructive jaundice due to pancreatic cancer will have all except thrombocytopenia, maybe, lung metastasis, yes. Palpable gallbladder, it's a curvaceous lobe. Pain, no. Early presentation is painless jaundice, painless progressive jaundice. So option B is absolutely wrong. Now what are you seeing? You are seeing necrolytic erythema migrans. And which pancreatic tumor does it associate with? Answer is glucagonoma. Glucagonoma. There are 4 Ds: dementia, dermatitis, and we have diabetes, and we have deep venous thrombosis also with this. So glucagonoma is the classical answer. 50-year-old lady with 2 years recent history of abdominal pain radiating to her back. The pain is severe in intensity, refractory to analgesics. CT was showing a dilated pancreatic duct. Which of the following? So this is a patient with refractory chronic pancreatitis. Longitudinal pancreatico-jejunostomy, LPJ, is far better answer than the classical Whipple's that we have. What about the succinate dehydrogenase resistant, you can say deficit gastrointestinal tumor? So I'm talking about wild gist. Now when you talk about wild gist, what are they? They are more frequent. Normally gist occurs in 40 to 60 bracket, but the young patients are involved in wild gist. So this is absolutely right. It is negative for Dodge1. No, diagnosed only is gastric gist. This is present. Most common location is stomach. This is also true. They are associated with Carney-Strategic syndrome. This is also true. So option B is wrong in this case. So I hope you enjoyed the discussion of surgery mock test questions. Thank you.
Hello, how are you, my dear students? So let's take the questions of biochemistry from your CBoT exam. I hope the paper was balanced, right, in all the subjects. So let's talk about the question number 1. Cancer cells, next question. Cancer cells derive the most of nutrition. Guys, cancer cell, they follow the Warburg's effect basically, and most of their energy is derived from the glucose. First thing to remember, cancer cells use glucose as the major source of energy, or I can say glycolysis, right? So obviously now I'm left with option A and option D. Now which glycolysis? Oxygen, even if it is available, they will produce lactate. So guys, that is what we called as aerobic glycolysis. Okay, so answer is D, right? Cancer cells uses glycolysis and produce lactate even in the presence of oxygen. So oxygen is present, that's why we called it aerobic glycolysis, right? Okay, so don't confuse that cancer cells, they are deprived of oxygen and they do the anaerobic. No, right? Okay, they're not using it, they're using aerobic glycolysis. Fine. Okay, moving to the next question. Identify the nutrient deficiency presenting with the following condition. Okay, so guys, this is the skin with the bleeding around the hair follicle, and this is what we called as perifollicular hemorrhage. Okay, this is called as perifollicular
hemorrhage. Clear? And the hair are called as corkscrew hairs, right? Corkscrew hairs as a shape, right? As you can see here, the shape. Okay, so guys, what is the answer for this condition? This is scurvy, sign of scurvy, and the answer is vitamin C, right? Vitamin C. Clear? Fine. Guys, vitamin A deficiency also present with the skin feature, that is phrinoderma, right? And biotin deficiency present with multiple carboxylase deficiency. Okay, fine. Our next question is thyroid hormones are derivatives of which amino acid? So guys, as a just remember like this, that thyroid, okay, they are derived from thyroid, right? Just to write, thyroid means thyroid, that is tyrosine. They are derived from tyrosine, thyroid, right guys? So answer will be B. What are the other derivatives of tyrosine? The very important is melanin and the catecholamines like dopamine, okay, or norepinephrine. So these all are derivatives of tyrosine. Clear? Fine. What is the derivative of tryptophan? Serotonin and melatonin, right? Okay, there was a question like which amino acid maintains a sleep-wake cycle? So answer is tryptophan. Lysine. Carnitine is a derivative of lysine which transports the fats to the mitochondria. Histamine is made from histidine, right guys? So our answer of question 8, answer is B. Fine. ATP7A defects, right? They present with the Menkes disease, and ATP7B present as Wilson's disease, that is copper accumulation. Remember, B for bile excretion, A for absorption of copper, right? ATP7A, A for absorption of copper. Okay guys, so that is Marfan's fibrillin defect, right guys? So moving to question number 10. Following structure of the protein. So the structure of the protein was given like this. There are 4 chains as you can see, and even the mention is there, alpha chain, beta chain. So obviously it is hemoglobin, as a heme is also mentioned here, right, in the picture. So but we need to know that hemoglobin represents which order of protein structure, because it has multiple polypeptides, right? When we have 2 or more than 2 polypeptides, then it is called as quaternary structure. Okay. Guys, remember one thing, that tertiary structure represents the functional protein. Though it is also functional, but the minimum level should be tertiary. A and B are non-functional proteins, right? Primary and secondary structure. Okay. Also remember, primary structure determines the higher order of proteins because it is a sequence of amino acid. Secondary structure has alpha helix and beta pleated sheets, right? And one more question, that alpha helix has no proline amino acid. Okay. Moving to the next question. This is like an athlete consuming the slimming pill. So weight loss pill, presented to the emergency and was agitated, tachycardic, sweating profusely, fever with a temperature of 104. That's very high fever. Venous blood sample shows metabolic acidosis, that is 7.23. And his temperature reached 105 in the next few minutes, right? So means the temperature is rising, and guys, this is like kind of hyperthermia which is happening due to the consumption of a slimming pill. So it's a very typical presentation of poisoning with dinitrophenol, right? Okay, and dinitrophenol or DNP is is a banned substance which was used previously in the slimming pill, and it's a uncoupler. What we have to remember, right, as a student of biochemistry, uncoupler of oxidative phosphorylation. Clear? Uncoupler of oxidative phosphorylation, right? Okay. And like we have physiological uncouplers like thyroid hormones, right, and the other ones are thermogenin, right? Okay. Newborn developed the seizures 2 days after the birth and was diagnosed with high ammonium ions or ammonia levels, glutamine, hypoglycemia, and ketoacidosis was absent, right? So the baby has high ammonia. So obviously it's a case of urea cycle defect. See guys, even if they don't mention high ammonia, if they mention high glutamine, glutamine is a marker of ammonia, right, levels in the blood. So answer will always be urea cycle disorder. Now they have also mentioned there is no ketoacidosis, right?
So like in the maple syrup urine disease, because the keto acids of branch and amino acid accumulate, right? And they may also have hyperammonemia, right? So ketoacidosis was absent, for example. Okay. Hypoglycemia may be present in, like, let's say, hereditary fructose intolerance and classical galactosemia, right? So that's why these 2 points are also mentioned together here. But our point is, right, answer is urea cycle disorder. The following child presents with the sun sensitivity and skin cancer. So guys, sensitivity to the UV rays, okay? So that is always, you know, a serious case, like, because already there is a skin cancer. 100% risk of skin cancer is present in a disorder known as xeroderma pigmentosum, okay? Xeroderma pigmentosum. So answer is nucleotide excision repair. The other 2 disorders that we should remember in nucleotide excision repair is cocaine syndrome and trichothiodystrophy, right? Trichothiodystrophy, where there is a tiger tail appearance of the hair shaft under the microscope, okay, under the polarized microscopy, right? So nucleotide excision repair, okay. Base excision repair, the disorders are rare, and double strand break repair disorders are based on, like, you know, they are repaired by non-homologous and homologous repairs. So the disorders of NHEJ and homologous repairs, like SCID, we can remember for NHEJ, right? And mismatch repair is very important. Hereditary non-polyposis colon cancer, hereditary non-polyposis colon cancer. Double strand break repair, you can remember SCID, severe combined immunodeficiency. And for homologous and joining repair, we can remember familial breast cancer and ovarian cancer, right? Okay. Moving to the question number 14. Telomerase, right? The enzyme which can make or keep us young all the time, right? But that is unfortunately absent in all our cells except few cells like stem cells and the cells which are present in, you know, the reproductive system, that is sperm, right? And the ovum. Sperm has a very high activity, but ovum has very low activity of telomerase enzyme, right? But stem cells, they have a sufficient activity of telomerase throughout the life, okay? So what is that other name of telomerase is? It's a reverse transcriptase, guys. So RNA plus protein. So RNA dependent DNA polymerase. I can also call it reverse transcriptase, okay? Reverse transcriptase. That's the name you should always remember also, right, guys? Cancer cells also becomes immortal, right? Okay, right. So that is also through the activation of telomerase genes in all the, you know, their the part of the cells which turn into cancer cells, right? Like if it's a lung cancer or lung tumor, there will be activation of this particular enzyme, suppose. So a young man trying to build muscles, right, presented with the alopecia and muscle aches, right? So he gave the history of the diet rich in raw egg whites which contains avidin, right? And avidin prevents the absorption of biotin, okay? So biotin dependent enzymes are carboxylase, okay? So that's what we have to remember: avidin, biotin and carboxylase, fine. So biotin deficiency is also known as multiple, C for carboxylase and deficiency, right? Okay, and this patient also has a typical order in the urine that is called as a tomcat urine order, okay? Cat urine or tomcat urine order, right, guys? So guys, thank you so much and all the best for your exams, right? Myself, Dr. Amit Jain, and I wish you all the best and you score way beyond the 150 or 200, right? So that's my wish. All the best. Be calm in your exams. Thank you so much. Bye-bye.
Hello students, I hope you had a very good exam. Now I am here to discuss with you the questions which were asked in anesthesia. All 5 questions which I selected for you, they are very much expected questions. They can again be asked in your exam. And they are the simple question. I hope you have done all the questions correct. So let us discuss the first question. A first question was asked on regional anesthesia. A 48-year-old patient developed trigger finger, and for the tendon release, IVRA was planned, that is intravenous regional anesthesia was planned. Which of the following agent is agent of choice. So the question was on IVRA, intravenous regional anesthesia, which is also called Bayer's block. Now this is a special type of regional anesthesia in which only one region is blocked, but the local anesthetic which is used for regional anesthesia is given intravenously. So either upper or the lower limb we can give IVRA. So for IVRA we tie tourniquet and then we put an IV cannula and give local anesthetic through that IV cannula. So the drug remains in this limb only and only this limb is anesthetized. So it's a regional anesthesia, but drug is given IV and there's always a risk little drug can go in systemic circulation. So local anesthetic, which is the safest and which if little bit goes in the systemic circulation, no major problem will happen, would be used. And that local anesthetic is lignocaine. Lignocaine is the safest local anesthetic and local anesthetic of choice for IVRA. So answer has to be lignocaine. So lignocaine, guys, it is safest LA, safest local anesthetic and local anesthetic of choice for IVRA. This is the only local anesthetic which can be given intravenously as analgesic, as your antiarrhythmic, right? It is used in ventricular arrhythmia also, antiarrhythmic, and we also give it as anti-epileptic, right? So lignocaine is the only LA which can be given IV. Now the LA, local anesthetic, which cannot be given IV is the LA which is most toxic if it goes little bit also in IV, and that is our bupivacaine. Bupivacaine is most cardiotoxic local anesthetic, right? So it is contraindicated for IVRA. Remember, we cannot use bupivacaine for IVRA. This is the second potential question on IVRA. Okay, prilocaine is safe. Again, a safe local anesthetic, right? But prilocaine can cause methemoglobinemia, so that is why it is not commonly used for IVRA. Lignocaine is the most commonly used for IVRA. So with prilocaine, remember, there is a risk of methemoglobinemia. So prilocaine is not a very commonly used local anesthetic. And again, mepivacaine is not a very commonly used local anesthetic. Got it? So answer is lignocaine. Now one more potential question on IVRA is that contraindication of IVRA. Guys, in IVRA, we tie tourniquet. So conditions in which tourniquet cannot be tied for that long, in those conditions, we are not using IVRA. And three conditions in which tourniquet cannot be tied for a long time period. And that is sickle cell disease, sickle cell anemia, scleroderma, and your peripheral vascular disease, peripheral vascular disease. So these are three contraindications of IVRA. So these are the potential questions on IVRA. Got it? So this was my first question. The second question which I asked, again, let's say a very potential question for exam. A patient was on ventilator from last 14 days. Tracheostomy was planned. So when someone is on ventilator for a long time, what we do, that initially we put the patient on ventilator with endotracheal tube. But for a better pulmonary toileting, we go for tracheostomy later on if the mechanical ventilation is prolonged. Right? So patient had endotracheal tube and now we want to replace it with a tracheostomy tube. Tracheostomy tube, that is the tube which is inserted in trachea. Endotracheal tube which is inserted from the nasal or the oral cavity into the trachea. Got it? So tracheostomy had to be planned. Which would be the best tracheostomy tube to be used in this patient? So tracheostomy tube is to be put on a patient on ventilator, that is for mechanical ventilation. So remember guys, when someone is for mechanical ventilation, we need to have a good seal in trachea, then only the positive pressure ventilation is possible. Otherwise, the air will escape from side. So we can only have to put the cuffed tube. The cuffed tube can only create a seal in the trachea and can allow a proper mechanical positive pressure ventilation to happen. So answer has to be cuffed tracheostomy tube. Okay, so whether I am putting an endotracheal tube or tracheostomy tube for a patient on mechanical ventilation, it has to be cuffed. Okay, uncuffed tube is mostly used in pediatrics and that also for short procedures, not on mechanical ventilation. Metallic tracheostomy tube is used when we are putting the tracheostomy for just for maintenance of airway, not when the patient is on mechanical ventilator, right? So this is just used for maintenance of airway, maintenance of airway. not on mechanical ventilation. Patient can breathe but cannot maintain his airway. Then tracheostomy is done and metallic tube is put. Metallic tube can be removed, washed and again reinserted in the patient. So they are used for long-term tracheostomy. Fenestrated tracheostomy tube is used when we are, let's say, encouraging vocalization in a patient, right? This is tube to use to encourage vocalization, right? So guys, these two tubes are basically used in rehabilitation. On mechanical ventilation, we always use cuffed tracheostomy tube. Uncuffed is used for short procedures only. So remember this, okay? The third question which I asked, that it is question on cardiac arrest, a very, very, let's say, commonly asked topic. The question was, an unresponsive patient was taken in the ambulance and on attachment. It must be a ACLS ambulance and attached with the monitor. Following rhythm was seen. When ECG electrodes and monitors were attached, following rhythm was seen. What should be done immediately? So patient is unresponsive. Patient is in cardiac arrest. No pulse, no BP. Let's assume. And because this is the rhythm. This is ventricular fibrillation, right? What is ventricular fibrillation? No formed waveform. Just like, let's say, lines on the monitor, right? So this has no morphology, nothing, just irregular lines on the monitor. So this is when the heart is fibrillating, and this fibrillation of heart is not getting converted into mechanical output. So there is no pulse. In this case, what we do immediately, we start CPR and we defibrillate the heart and stop the heart so that heart resume its normal rhythm. It may become a sinus rhythm. So what should be done immediately? Chest compression and defibrillation, right? Defibrillation is the treatment of choice in ventricular fibrillation. Got my point? Remember, when someone is in cardiac arrest, right? When someone is in cardiac arrest, there is 4 rhythm possible of cardiac arrest, which is divided into 2, shockable and non-shockable. Non-shockable. So shockable rhythm. Shockable rhythm is ventricular fibrillation, which is asked in this question, and pulseless ventricular tachycardia, right? Which has like something like this waveform. Both this rhythm, what would be the management? Compression and defibrillation. And non-shockable rhythm is asystole. Asystole is straight line, and pulseless electrical activity, which is any electrical activity without pulse, but that electrical activity should not be VF or VT or a straight line. Then we call it pulseless electrical activity. These two are non-shockable rhythm. So what would have been the answer if a straight line would have been given, or any, let's say, electrical activity would have been given without pulse? Right, the answer would have been only chest compression. Got it? These are non-shockable. So we will not defibrillate the heart. We will not give shock to the heart. We will just do the CPR. So remember this, okay? The fourth question which was asked, a patient had an injury leading to massive blood loss resulting in hypotension. So patient is in hypotensive shock and patient requires rapid fluid infusion. We have to give fluid very quickly, which is the most preferred IV cannula. So we put IV cannula to give fluids through the peripheral vein. And when a patient is in hypotensive shock, we will try to use the largest diameter cannula so that the saline or whatever we give to the patient, it should be given as quickly as possible. So let's say pink cannula. What is the, let's say, diameter of the pink cannula? It is 20 gauge. Orange cannula, it's 14 gauge. Grey cannula, it is 16 gauge. And green cannula, it is 18 gauge. Okay. So which of the following has widest diameter? The orange one. So answer has to be orange. The orange cannula is most commonly used in trauma patient for resuscitation and for cardiac surgery, where we have to give fluid very quickly. And by this cannula, we can give in 1.5 minutes a 500 ml of saline bottle to the patient within, let's say, 1.5 minutes. Okay. Then comes the grey cannula. Grey cannula is also can be used in trauma patient and cardiac surgery. And guys, this cannula we can give in 2 minutes a 500 ml bottle of saline to the patient. Pink and the green cannula are the most commonest one which is used during perioperative care and in wards, etc. in an adult. So pink cannula and the grey cannula are most commonly used in adult patient in ward or during perioperative period. right? So remember these. The sizes of cannula are very important for the exam. They can even give you an image of the cannula and they can ask what is the gauge of this cannula. So color coding of the cannula and their corresponding gauge is one of the most important expected question, right? Now the fifth question which was asked was an image-based question. A procedure was given and they asked you to identify the procedure. Well, you can see if you identify, these are the tracheal rings. Tracheal rings, okay? And a hole is being made in the trachea and this tube is being inserted. This is a tracheostomy being done. So answer has to be tracheostomy, okay? This is a very clear image. Now let's say this is your thyroid cartilage, this is your cricoid cartilage, and then this is trachea with the tracheal ring. If a procedure is being done between the tracheal ring, okay, then this is tracheostomy, which has been asked in this image. If the procedure is being done, let's say high up in the neck, between thyroid and the cricoid, then it is cricothyroidotomy. So if an image is given of the neck and if the needle is high up in the neck, then it is cricothyroidotomy. And if the needle is low in the neck, just above the suprasternal notch, then it is tracheostomy. For central line insertion, one of the big vein like IJV or subclavian, the needle would be directed towards it. So it would be clear-cut central line insertion. And thoracotomy, a procedure would be done on the left or right thorax. The thorax would be open, ribs would be seen. Right, ribs would be seen. So it would be very clear that it is thoracotomy. These are tracheal ring and the tracheostomy tube is being inserted. So answer is tracheostomy. So these were the 5 questions. Very quickly I will revise. So what is the procedure being done in this image? It's tracheostomy. The 4th question was a trauma patient, which cannula should be used? The thickest one, that is the orange, which is 14 gauge. So B is the answer. Then a patient in cardiac arrest, this was the rhythm, which is ventricular fibrillation. What should be done? The chest compression and defibrillation. That is the answer is A. And the second question, that a patient was on ventilator, a tracheostomy was being done, and which is the tracheostomy tube of choice in this patient to be used in this patient? Cuffed tracheostomy tube. That is the answer is A. And first question, a question on IVRA, agent of local anesthetic of choice for IVRA. Answer is lignocaine. Okay, so these were the 5 questions. I hope you have done all the 5 questions correct. My best wishes. Thank you.
Hello dear friends. So you must have given up this particular exam, and important questions are there which are like from the microbiology part, and these are those which are being constantly being repeated in the exam. So I suppose you must have found them easy. So now start up in a short discussion. We'll try to give you important points regarding the various aspects. So let's start up first. Okay, let's see the first question. The first question says a 70-year-old male presented with fever, vomiting and neck rigidity. So obviously they are talking about what? Meningitis. The patient blood picture shows monocytosis. Okay, the organism cultivated from the CSF after the lumbar puncture gives a positive Anton test. Okay, this gives a test which is termed as positive Anton test. So from these all particular lines, what you are getting up, that we are talking about a particular organism termed as Listeria monocytogenes. Okay, Listeria monocytogenes, and as the name suggests, Listeria monocytogenes, this is what is termed as monocytosis, and this Listeria is a gram-positive Coccobacillus. And if you see the first option, it's a coccoid and gram-negative. So this is what is the incorrect statement. So this particular thing is the answer because this is incorrect. All other things are correct. Like most of the human infections are caused by serovar2A and 2B. It shows slow tumbling motility, and it is catalase positive. It is catalase positive. Now, if I want to change up this particular question, other than the Anton test and all, I can put a CAM test positive and all that. And I can put off like this that we are dealing with a CAM positive cocci. Okay. So guys, then we are talking meningitis features for the neonatal meningitis. And you know the most common cause in neonatal meningitis is what, guys? So that is group B strepto. That is Streptococcus epilepticus. So like that you need to know. Another important aspect here is that Listeria, whenever comes, it shows differential motility also. So as you can see in the C option, it shows slow tumbling. Yes, it does show tumbling motility. Tumbling means a drunkard which is fallen off and again standing like that. So slow tumbling motility. It also shows differential motility. That is what is important, and it is
catalase positive. And most of the infections are done by what? 2A and 2B. Listeria does have a role in pregnancy also. It leads to preterm births and even abortions. Okay. All the true about the Bacillus anthracis except. So except they want the first we see plasmid responsible for the toxin production. Yes. For the toxin production, plasmid is responsible. And what is plasmid? Any extra chromosomal genetic material that is termed as plasmid. The cutaneous anthrax generally resolves spontaneously. The capsular polypeptide aids in virulence by inhibiting the phagocytosis. Okay. Remember one thing, that this is an exception where the polysaccharide is not there, polypeptide is there. So capsular polypeptide aids in virulence by inhibiting what? Phagocytosis. And the toxin is a complex of 2 fractions, and there the answer lies, which is wrong one. The answer is this itself. Important is it is made up of 3 fractions. Okay, it is made up of what? 3 fractions, and 3 fractions are made up of what? They are made up of EPL. And what is EPL? England Premier League. And England Premier League is what? This is edema factor. This is P is protective factor. And then you have the lethal factor. And all these particular ones, they increase of the cyclic AMP, that is adenosine monophosphate. Is it fine, guys? So remember these particular point regarding the Bacillus anthracis. Important, polypeptide capsule is there. Okay, and for that we do have a reaction, Mac-Padden's reaction. Cutaneous anthrax dissolves spontaneously. Yes, that malignant pustule 1 can resolve spontaneously, and plasmid is responsible for the toxin production. And it is a category A bioterrorist weapon. This particular one is a category A bioterrorist weapon. As far as the pulmonary anthrax is concerned, it leads to the mediastinal hemorrhagic necrosis, that is hemorrhagic pneumonia. Coming to this, a 3-year-old child develops a bloody diarrhea and hemorrhagic colitis happens. The E. coli O157H7. O157 means the O is a somatic antigen, H is a flagellar antigen. That is suspected. What medium should be inoculated to help the lab staff to make the diagnosis of this infection? So guys, retrograde question it is being asked. They already have given up that E. coli O157H7 they are suspecting of, and to isolate this particular one, we need rainbow agar. Okay, we need rainbow agar, which is like one of the medias other than the SMAC, and SMAC is a famous one for this. And SMAC stands for what? SMAC stands for sorbitol McConkey agar. This particular one stands for what? Sorbitol McConkey agar. And why we use this? We use this because it does not ferment sorbitol, and all others they does. This does not. So that's why the answer comes towards the SMAC or a rainbow stuff. TCBS, you know, Vibrio cholerae, modified Thea-Martin for gonococci and meningococci. Chocolate agar, again, for the Haemophilus species. They love chocolate, and that is what their answer is. And this particular fellow, O157H7, secretes up VT1 and VT2. And what is VT? VT is virotoxins or virocytotoxins 1 and 2. Fine. They are also termed as Shiga-like toxin. A 3-year-old girl presents with a history of hydrocephalus, presents with severe headache and fever. The girl underwent a revision of the ventricular peritoneal shunt 1 month ago, means that is being corrected off. Neurologist suspects that an infection has occurred, which is the following organism most likely isolated from this shunt tubing. Is it Bacteria physalis? No. Concomitant diphtheria? No. E. coli? Might be. Staph epidermidis? Yes. This is what is the answer, guys. Staph epidermidis. And as the name suggests, this is present over the skin epidermis. And whenever in the question they are talking about intervention, whenever in the question they are talking about intervention, we need to think for this particular one. Okay. So basically, any sort of intervention, if it is there, that is to be correlated with what? Staph epidermidis. Another important thing regarding this fellow is that it contributes to the antibiotic resistance by forming of what? Biofilm. So biofilm is produced. Okay. And another important thing regarding the antibiotic stuff is this is novobiosin sensitive. This particular one is what? It is novobiosin sensitive. Okay. And this particular epidermidis is termed as cons. And what is cons? Coagulase negative staph. Now, which of the following species of Candida produce the characteristic thick-walled terminal chlamydospores? And as you know, chlamydospores are what, guys? They are asexual spores. And on this media, corn meal agar, which is a nutrient deficient media, they'll produce these asexual spores, and the organism which does it is Candida albicans. Okay, this is the main fungus, Candida albicans, and it does produce chlamydospores, asexual spores on which media? On corn meal agar. Okay, and why does it produce so? Because they are nutrient deficient one. Another one which is shown by this, which is frequently asked, is germ tube formation. Germ tube formation, and this germ tube formation is also termed as Reynolds-Broad phenomena. It is also termed as what? Reynolds-Broad phenomena. Fine. And Reynolds-Broad phenomena, basically projections are there. This is what is termed as germ tube formation or Reynolds-Broad phenomena. Candida krusei. This Candida krusei, which is there, this one is intrinsically resistant to the azoles. Okay, this one is intrinsically resistant to the azoles, and this can be asked. As such, we know na, the drug of choice for the Candida is azoles. Okay, fluconazole and all that. Fine. But this particular Candida species, krusei, it is intrinsically resistant to what? Azoles, and this you need to remember. Is it fine, guys? So these all are there, and one important aspect which I like to tell you is beta-1,3-glucan assay. This particular beta-1,3-glucan assay, this testing beta-1,3-glucan assay is being done for CAP. And what does this CAP stands for? Invasive candidiasis. Okay, A is invasive aspergillosis, and P is pneumocystis carni or pneumocystis zerovasi pneumonia. Okay, for these particular organisms, you go for this beta-1,3-glucan testing, and this is a highly potent question which can come in your exam. And another one which can be coming is invasive aspergillosis. What is the drug of choice? And the drug of choice for invasive one is voriconazole. Okay, voriconazole is the drug of choice for the invasive aspergillosis. And in aspergillosis infection, on the LPCB mount or on the like H&E staining, what do you observe? Septate hyphae or aseptate hyphae? Septate hyphae are there, and those are what do you say? Acute angled. Okay, those are what? Acute angled. Now talking about this, the major cause of FAVIS. Another important question, a favorite of examiner is this, and the FAVIS, as you can see in the picture, this is what is FAVIS is, and FAVIS is done by what? Trichophyton Sean-Lenny. Okay, Trichophyton Sean-Lenny. And how to remember that? The favorite shoes lane hai. Favorite shoes lane hai. This is the most important one which it does it. Other than that, even the Microsporium gypsum, that does it, and Violatium, that does the FAVIS. But the most important one is what? Trichophyton Sean-Lenny. Another one which is important here, which you should know, is Chirion. And Chirion is being done by Mentigrophytes. Okay, this is being done by Mentigrophytes and Trichophyton verrucosum. This is being done by Mentigrophytes and verrucosum. Okay, so Chirion is being done by Mentigrophytes and verrucosum, and this Chirion associates with those who have PET. Okay, so that's why we say this particular fungal disease is a zoophilic one. Okay, done by these particular ones. And Mentigrophytes is said to be hair perforation test positive. Okay, this particular test which is seen here is hair perforation test positive in the case of Mentigrophytes. Okay, rubrum. This particular rubrum also can be asked. That is, it produces a pigment that is termed as red pigment. So red pigment is produced by this rubrum, and how to remember? Rub, it becomes red. Flocosum. This particular flocosum and Epidermophyton flocosum is associated with Tinea pedis and Tinea cruris. And the Tinea cruris and pedis, this is athlete's foot and this is Dhobeach. Then coming to this one, a person presented with orbital swelling and a blackish crust formation had a history of prolonged steroid use with COVID-19 disease. Okay, steroid use, COVID-19, they need to be related up. And there is orbital swelling, blackish crust, so means it's an invasive infection of mucormycosis. So it is being done by what? So obviously mucus species is involved. Remember guys, Rhizopus is also involved in this. So both options, Rhizos and Oryzae, they are also okay. And the mucus species are also okay. The answer to this question is all the above. Important aspect which I like to tell you here is, last time they have asked the questions by this name. Okay, so it is having three names: phycomycosis, one is zygomycosis, okay, and one is mucormycosis. So all these are same, and you need to know that they associate strongly with the DM, and they associate strongly with the prolonged steroid use. So basically all those conditions in which immunodeficiency is being produced of, means immune system is suppressed by any of the things. Okay, and what you get in that, obtuse or right angled aseptate hyphae, that is the feature of this zygo stuff. Okay, now coming to this, which of the following causative agents are there, and what should be the answer? A, B, C and D. So guys, you know the Q fever is termed as query fever, and it is being done by Coxiella burnetii. Cat scratch disease, the cat have scratched you haste haste. So Bartonella Hansley, that leads to cat scratch disease. Stellate granuloma is observed in that. Rat bite fever, that is being done by Spirillum minus. And Brill-Ginser disease is the recrudescent form of epidemic typhus, done by whom? Rickettsia prowazaki. Okay, and regarding this Coxiella burnetii, it is the organism which is not killed by Holder's method of pasteurization. So remember, for that we need to use what? Flash method of pasteurization kills the Coxiella burnetii. It associates with the atypical pneumonia, and you know guys, it does culture negative endocarditis. Okay, and bad cat scratch disease, Bartonella Hansley, it is having stellate granulomas, and that can associate with the like in the liver you can have something, in the spleen you can have something. So that particular thing is being done by this Bartonella Hansley, which comes as rickettsial ones. Rat bite fever, Spirillum minus, and Brill-Ginser disease is a recrudescent form of epidemic typhus, done by whom? Prowazaki. Okay, it is done by whom? Prowazaki. So answer to our question is A. Now coming to this, appropriate culture media they are asking of, and Salmonella typhi, enrichment media is being asked. Enrichment is what? Mostly or always? What? So it is always liquid, and the answer to our question is selenite F broth. So selenite F broth by this Salmonella typhi. Then you have this bordered laporteosis leading to what? Bordered ganju. For that, which media we use? Bordered ganju media. And which type of colonies they come? Bisected pearl appearance. Okay, chlamydia is growing on which particular cells? That is the HeLa cells. Okay, and the Mycobacterium TB, that is for the LJ media. Okay, for that we use what? LJ media. So answer to our question again is what? A. Answer to our question is again what? A. First is A, second is B, third is C, and fourth is D. And on the LJ, which type of colonies they come? Rough, tough, and buff. Okay, HeLa cell lines, and they are continuous cell lines, cancer cell lines, and chlamydia is a bacteria which loves to grow on the cell lines, and that's why you can't culture it. That's why the investigation of choice for this is NART. Bordered laporteosis, bordered ganju media, bisected pearl appearance, that is observed up, and you already know that it is incubation period 7 to 14 days, and catarrhal, paroxysmal, and convulsant, they are the stages of it. And the paroxysmal is one in which whoops comes, the high pitched stridor sounds, and post-tussive vomiting is observed. Most infectious is catarrhal. And the question, last time which have come is drug of choice. Drug of choice for the pertussis in children is EZI, that is azithromycin. Okay. A child from Bihar presented with fever. The blood examination shows sheathed microfilaria. The first thing is sheathed it is. And remember, the sheath microfilaria are these. Leg before the wicket, LPW. Okay, L is lova lova, B is Brugia malai, and even Brugia temori, and W is Wuchereria bancrofti. Wuchereria bancrofti. Now the next point which is observed is with nuclei up to the tail tip. With nuclei up to the tail tip is a feature of lova lova. Okay. So answer to our question is lova lova, which leads to loesis and Kala Baar swellings, which leads to loesis and Kala Baar swellings, and the fly which is involved in this is Chrysops fly. The fly which is involved up in this is Chrysops fly. This is the fly which is involved up in spreading of this particular thing. That is the Chrysops fly. Loesis and Kala Baar swellings, that has been done by that. Then Bruggia malai. How to identify this one? To identify this particular one, you have to see the tail tip, and in the tail tip, you have terminal 2 nuclei. In the tail tip, what you have, guys? Terminal 2 nuclei, they are seen. And in the Wucherera bankrofti, there is a ban. So there is no nuclei. There is no nuclei in the bankrofti. Okay, there is no nuclei in the tail tip of the microfilaria in the case of Wuchereria bankrofti. So like this, the question can come. Up to the tail tip, like in a continuous manner, that is the lower lobe. Terminal 2 nuclei, they are observed in Bruggia malai, mala, having 2 A's. And Wucherera bankrofti is not having any sort of nuclei. There is ban on the nuclei, so there is no nuclei. Now coming to this, a following disease associated with Epstein-Barr infection except. First of all, you should know Epstein-Barr is which number? It is HHV4, human herpes virus 4, and obviously it associates with infectious mononucleosis, which is also termed as kissing disease, and Paul Bennell test, which is a heterophile agglutination test, is positive here, along with that monospot test, that is also termed as positive. And the patient presents with the pseudomembrane and sore throat is the main complaint of the patient. And when that fellow takes ampicillin for that, there might be a fixed drug eruptions over the body. Epidermodysplasia vericiformis, which is also termed as Treeman syndrome, guys. This is not done by Epstein-Barr virus. This is done by HPV 5 and 8. It is done by what? HPV 5 and 8, and human papillomavirus does this. And this particular one is a double-stranded DNA virus. Nasopharyngeal carcinoma, yes, common in Chinese and done by Epstein-Barr virus. Nasopharyngeal carcinoma, oral hairy leukoplakia, yes, lateral side of the tongue, you will having it, and it is common in the HIV positive ones. Important question which have recently come is, these particular fellows, they associate with CD markers, CD21, CR2. This particular combination, CD21, CR2, is present over the B cells. CD21, CR2. It is present over the B cells, and that's why they get attracted towards it and leads to the clonal proliferation of these particular ones. That's why it goes for these particular cancers. Okay. And other than that, if somebody asks you, Burkitt's lymphoma is being done by that, starry sky appearance, Hodgkin's lymphoma, non-Hodgkin's lymphoma, all these are there regarding it. So guys, with this, we end up, and all the very best from my side. Do revise these particular ones. They are important CBOT questions, and they are previous year's questions. And I will recommend you to go through the PYQs, because the topics will definitely be repeated. Even though the question is not repeated up, the topics will definitely be repeated. And I hope if you go through properly, in a way, this particular one, as such, it is like 13-14 questions only. But if you see up, if you study the microbiology properly, you can very well appreciate that it correlates with around 30 to 40 questions. Okay, and I'm not joking up. You can yourself find out in your exam this particular thing. Okay, so thank you very much. Best of luck.
Hi students, welcome to the discussion of forensic questions of recently held computer based offline test. तो फटाफट शुरू करते हैं हम forensic medicine के questions का discussion by taking our question number 1. Question number 1 is, a pregnant female of 26 weeks of pregnancy has substantial risk of fetal anomalies. Okay, according to MTP Act 2021, who can allow MTP in this case? So this question is very crystal clear. This question is directly asking कि MTP Act के provision क्या हैं? So what are the provisions of MTP Act? That MTP can be done for a maximum period of 24 weeks of gestation. Okay. Now, up to 20 weeks, one doctor can decide the procedure of what needs to be done, and that can or he can do it. Then 20 to 24 weeks, two doctors are required to decide that what procedure would be best for the female, and then one of them can go ahead and do it. But in this MTP provision, there is a special provision given for females whose gestation age is more than 24 weeks, that MTP can still be done, but only if there is a substantial risk of fetal anomalies in the fetus who is sustaining development in her uterus. And in that case, the allowance of termination of that pregnancy can only be done by a board of doctors. Okay. So what do we see? That in the normal provision of the Act, MTP can be done till 24 weeks. Up to 20 weeks, one doctor can decide the procedure and can do it. Between 20 to 24 weeks, consensus of 2 doctors are required, and that's all. But in a special provision, MTP can be done beyond 24 weeks also, but only in a scenario where there is a substantial risk of fetal anomalies, and here the permission has to be given by board of doctors. That board of doctors will be constituted by every state, so the case have to be referred to them. They had to go through the case and they have to decide. So correct answer here is option number C. Coming to question number 2. A male of 30 years of age daily stands naked in the balcony of his home. So important word here is he stands naked. Where? In the balcony of his own home. People on ground can easily witness the act. One day public reports it to the police. He is arrested for doing this act. And the question is very simple. If he is arrested, he might have committed some offense. What is the offense? Okay. Now what is he doing? He is standing naked in his own home. Now that's not any crime. That's not an offense. But if you are doing it in certain area of your home where you know that you can easily be viewed by public, that would amount to deliberate vision or deliberate disclosure of your nudity to unsuspecting public, and this act is called as exhibitionism. So the crime is called as exhibitionism. Exhibitionism is public display of self nudity, and it is punishable under section 294 IPC. It is punishable under section 294 IPC. So that person would be arrested for that crime. Coming to question number 3. A physician doctor referred a patient to a radiologist. Okay. Some person known to the radiologist later visited the physician doctor with a thank you letter and a money packet. Which is true regarding the above situation? So the situation which is giving in the question is pretty simple. A physician doctor refers a patient to a radiologist, another fellow doctor, and later on radiologist sends him money for that referral, right? This concept of gaining money for referrals or splitting money over the treatment of a patient, either you gain that money from another doctor to whom you have referred the patient, or you take that money from any laboratory or investigation services where you have referred the patient. This concept is called as dichotomy. This concept is called as dichotomy. So correct answer here is that it is medical dichotomy. Medical dichotomy is fee splitting over a patient. Now sometimes certain students get confused. Let's say a patient is to be operated, right? the operating surgeon will take his fees and the anesthetist will also take his fees as he is delivering anesthesia in that case. Now, even here you will see that two doctors are taking money from the patient when he is getting operated. Will it amount to be dichotomy? No, that's not dichotomy, because here both of these doctors are gaining or receiving money for the job they are doing. They are not distributing that money amongst themselves because one has referred the patient to other or vice versa, right? So, dichotomy, plain and simple, is the scenario which is given in the question. When two doctors treat a same patient and both of them recover their fees from him for the treatment they have given to the patient, that's not fee splitting. Okay. Next question. Question number 4. A farmer is sleeping under the shade of a tree after intense work. Okay. He suddenly feels a sting on his leg. So, important thing here is sting on his leg. On observation, there are two puncture marks. So, there are two puncture marks. So, it could be something like these kind of two dots present on his leg. He shouts for help and is taken to hospital. In hospital, he has no other symptom but pain and swelling at the area. The next appropriate management is, the first step of management in this situation is, or in this question is, the identification of that sting. A farmer is resting in the field after intense work and he suddenly feels a sting in his leg, and on observation there are two puncture marks. Now, these two puncture marks, they probably are fangs of a snake. So, this situation is a classical situation of a snake bite. Now, what happens when he is taken to hospital? In hospital, he has no other symptom but pain and swelling in the area, which makes us believe that this is a non-poisonous snake bite, because we know poisonous snake bites generally refer either as a neurotoxic or a hemotoxic kind of symptoms. In the question it is clearly given that he is not exhibiting any neurotoxicity nor he is exhibiting any kind of hemotoxicity. Okay, so it looks to be a non-poisonous snake bite. Now the management has to be what is or should be done with patients who come with non-poisonous snake bite. The answer here is observation for 24 hours. Now, observing that patient is very critical. Why these patient needs to be observed? Number 1, to allay their fear. Most of them are fearful. If you are going to send them home, many of them may collapse because of the neurogenic fear. So, neurogenic shock, and they may return back to hospital, and this time their situation may be more critical as compared to snake bite itself. So, to allay their fear, to take their fear away, observe them for 24 hours, right? The second benefit of observation is that if there is any kind of delayed development of symptoms, even that can be treated because patient is under observation. So, remember, in cases of non-poisonous snake bite, the treatment is observation. In cases of poisonous snake bite, the treatment is very simple. If he is exhibiting symptoms either of neurotoxicity or hemotoxicity, you give polyvalent anti-snake venom, right? Question number 5. A person died of cyanide poisoning. True statement. So, it's a very direct question. The person has died of cyanide poisoning. Which of the 4 statement is true? Right? First statement is ammonical odor during autopsy. Now, that's not true, because in cyanide poisoning, we tend to have a bitter almond odor, right? Then pink post-mortem staining, that's true because in cyanide poisoning there is superoxygenated hemoglobin, right? So the more a hemoglobin keeps on getting oxygenated, the more brighter it keeps on becoming. Third is Poltov's hemorrhages in lung, that's false because Poltov's hemorrhages in lungs are seen in cases of antemortem wet drowning. And fourth is opisthotonus. Opisthotonus also is a wrong statement because opisthotonus develops in cases of strychnine poisoning, right? So answer is very, very simple. Answer is always in front of our eyes. We just have to eliminate the wrong possibilities. So this is a very straightforward question where the answer is pink post-mortem staining because of superoxygenated blood in cases of cyanide poisoning. Next question, the condition is associated with, now it's a picture based question. If you look at this picture, a photograph of fingers are shown and arrows are pointing towards development of certain condition in the hand. And what do we see in the hands, or I should say finger, is that there are development of white transverse lines in nails. These lines are called as Eldridge-Mees lines. These lines are called as Eldridge-Mees lines, and they are very, very important symptomology or presentation developing in cases of chronic arsenic poisoning. So correct answer here is option number D, chronic arsenic poisoning. Remember few things that are associated with chronic arsenic poisoning because question like these are often asked in examination. Chronic arsenic poisoning tend to develop certain important skin symptoms. Eldridge-Mees lines on nails, alopecia, falling of hair. Third is development of raindrop pigmentation. Okay, hypopigmented, round to oval or circular, you can remember like that. Hypopigmented areas developing in different areas of body, those are called as raindrop pigmentation, sometimes also referred to as salt and pepper kind of pigmentation developing on body, chronic arsenic poisoning. Okay, so we need to remember few things which are very, very important in relation to chronic arsenic poisoning. Right, question number 7, again a picture based question. What do we see in this picture? First of all, the question, for the gunshot wound shown in the picture, true statement is, and there are 4 statements given in the question. First of all, let's analyze what is the gunshot wound given in the question. In the picture, you can see that there is a very, very clearly demarcated circular opening in the center. So, I am just drawing over it. So, there is a very clear circular hole in the center, and then we can see lot of dot markings around that hole. Now, what are these dots around that hole? Let me rub this picture for you. Okay, the central opening is nothing but the entry wound, and that dot black markings around that central opening is tattooing, right? So, this is a photograph showing a central hole and a tattooing around it. Now, a very neatly developed circular central hole with tattooing around it. What kind of weapon are we talking about? We are talking about rifled weapons here because this is a work of a rifled bullet. Okay, so if you see the options, the first option is distant range shotgun entry wound. Now, because it is not a wound created by a shotgun, because in shotgun when we shoot, pellets come out, right? So, this option already goes out of the wind because it is a wound caused by a rifled weapon or you can say a rifled bullet. Second is near range rifled weapon entry wound. That we can still keep in the option because it is a rifled wound. Third is rifled wound weapon exit wound, and fourth is close range shotgun exit wound. So let's cross this option also. It cannot be possible, right? Now we are left with B and C, and out of B and C, which is the correct answer? The answer is very simple. It is option number B, because we know it's an entry wound. Why? Because entry wound only has features of tattooing, blackening, burning, singeing along with the entry hole. Exit wound do not have tattooing, burning, blackening, singeing, right? So if either burning, singeing, blackening or tattooing is shown along the picture or is given to you as a question, in the question, written in the question, it means we are talking about entry wound. So this is one question which is a very good question, because you need to see the photograph to identify that it is entry wound. Once you have identified it is entry wound, the second thing you need to identify is this kind of entry wound is possible with by which kind of weapon. Once you identify that this is possible with a rifled weapon, then looking at the answer becomes really easy. Then you can exclude out all the wrong possibility very, very easily. Okay, let's move to next question, question number 8. A crime of rape is allegedly committed in a room. Okay, so it is given that rape has been committed in a room. On inspection of crime site, nothing unusual is noted in the area. For detection of presence of any seminal droppings in the room, what should be done? So question is very simple. Rape has been committed. On naked eye examination, the investigator cannot find anything unusual in the room. But if the investigator is very positive that there should be certain seminal droppings that should be there in the room, what kind of procedure or what should be done to find those seminal stains? So question is typically asking, how do you look for presence of seminal stains in a room? The answer is ultraviolet light illumination. What you need to do is, you need to make the room dark. You need to switch on ultraviolet lamps or UV lamps. In ultraviolet light, in UV light, semen has self glow. Semen starts to glow itself. So whatever you see as glowing spots in UV light, you can pick up those as they could possibly be semen. So that's what you need to do. Now, in the same question, if you look at option number C, which is luminol spray test. Remember, luminol spray test is used for detection of blood stains at crime site. So if you want to detect blood stains at crime site, you need to spray luminol material. If you want to detect presence of seminal stain at crime site, you need to do an ultraviolet illumination test. Seminal stain glow themselves. With that, we come to end of this session. I'll see you maybe in discussion of any other test in future, but right now, for all those people who are giving FMGE examination in July, a very, very best of luck, right? Bye.
Alright, hi guys, I hope all of you guys are doing good. And after your computer based offline test, I got many feedback from the students that sir pharma ke question ज़्यादा थे, yeah, there were a lot of integrated topic. So I would say हाँ थोड़ा ज़्यादा तो थे, but it was not like all pure pharma, है ना? So usually 28 से 30 क्वेश्चन आते हैं, but इसमें थोड़ा ज़्यादा आपको इसलिए दिखे because there were many questions that got integrated with other subjects as well. So let me quickly take you through the entire discussion of this computer based offline test, and maybe some of these questions can be repeated in medicine, but I will try to see that that is being discussed only once, right? So that we can save your time here. So you can inform our other teachers as well that it has been discussed in this subject. Okay, so the very first question that I would like to discuss with all of you guys is a very simple question of a patient treated with ampicillin developing some problem like rash, breathlessness, right? So what is this? This is an example of type 1 hypersensitivity reaction, है ना? So anaphylactic reaction हो रहा है ना, and type 1 anaphylactic type 1 hypersensitivity reaction, which is anaphylactic shock or anaphylactic reaction. The treatment for this one is what? Adrenaline, intramuscular route 1:1000. This is what we are going to give. Now multiple options are there, IV and IV. 2 IV immediately ruled out. Now you have to choose between B and C. Immediately we always choose IM, not IV. Okay, so IM 0.5 ml 1:1000 or IM 0.5 ml 1:10,000. See, if it is non-responsive to IM, we can repeat. If it is still non-responsive, then we can give via IV route by further diluting 10 times, है ना? So that become 1:10,000 in scenario if it is non-responsive to IM dose. So first and foremost, the correct answer for this one is IM adrenaline 0.5 ml 1:1000. We got the first question right. Okay, next one. A patient was given digoxin. Now this is looking like a digoxin question, but it's actually general pharma question. So two kind of integration you will see. One integration is between two subject, and other kind of integration is within the subject only. Like this is the one. General pharma got integrated with your systemic pharmacology. Okay, this drug is having very high volume distribution and also having narrow safety margin. Which of the following is true about this drug? Now what all thing we know about the volume of distribution, guys? That whenever volume of distribution is high, this is mostly seen in the lipid soluble drugs, mostly in the lipid soluble drug. And when the volume of distribution is high, where is the drug mainly located? Drug is mainly located in the tissues. They are not in the plasma, they are mainly in the tissues. Always remember that when plasma protein binding is high, there will be lesser volume distribution. You see, the plasma protein binding is high, the drug will be less available for the tissues. Next, that you should know, if the volume distribution is high, what will be the clinical implication? One of the clinical implication is that with such a drug, the T half-life will be longer. Other implication is that when the volume distribution is high, as soon as you are going to give the drug is directly going to the tissues, right? Most of the drug is going to the tissues. Therefore, in order to achieve the therapeutic plasma concentration, we need a higher dose, and in this scenario, loading dose is required. That is a second clinical implication. Third clinical implication, if the volume distribution is high, that if there is an overdose or if there is a toxicity with the drug having high volume distribution, in that case scenario, antidotes will be utilized. Remember, hemodialysis will not be effective. Antidote will be utilized. Hemodialysis is ineffective. See how easy is it, right? Now, most of the information I have summarized here for all of you guys. Now, let us quickly go ahead and check it out, the question. Drug is very less distributed tissue. As I told you, drug is mostly in the tissues, no? Drug is mostly bound to plasma protein. If the plasma protein binding is high, distribution will be very, very less. It is having high volume distribution, that we know already. Always give high loading dose in such drug. Any drug that is having high volume distribution, if you want to achieve therapeutic plasma concentration, emergency mein hamesha we give higher dose and we call it as a loading dose. Okay? A drug is mostly polar. See, polar drug will have less. It's always the non-polar, non-ionized and lipid-soluble drug. So lipid-soluble drug, non-polar, non-ionized, that is going to have high volume distribution. Alright, so I hope all of you guys have got this one correct as well. But if not, learn from the mistake. Next, entry of the drug into the market. This was a very, very easy question. Phase number 3. After which phase of clinical trial? So after phase 3. Phase 1, it is mainly for what? Safety. Phase 2, it is mainly for what? Efficacy. And this is going to determine. Phase 3, it is the replica of phase 2 only, but with more number of patients. So phase 3 is known as confirmatory trial. So we are going to do confirmation of the efficacy. Confirmation of the efficacy. Right? And also comparative analysis. And a comparative study. That means comparative study with the existing drug. It will be done in which phase? So again, this could be one of the very potential MCQ. Comparative study with the existing drug. It will be also done in the phase 3. And phase 4 को तो हम बोलते हैं post marketing surveillance. After the drug is launched, we'll be doing post marketing surveillance. So we read a topic pharmacovigilance. That is again a part of phase 4 again. Okay. So we can talk about the next question. A patient was on valproate for his epilepsy, acquired tuberculosis, and he started on first line anti-tubercular. Okay, so he is a patient on epilepsy, well controlled maybe, and was started on ATT. ATT is anti-tubercular therapy, which is having isoniazid, rifampicin, pyrazinamide, and ethambutol. After a few days, there were complaints of recurrence of epileptic episode. True about this. Now always remember, epilepsy पहले control था. After you started this anti-tubercular therapy, there is a recurrence. So try to understand. Rifampicin is the culprit here. Rifampicin is a very potent enzyme inducer. See, I hope all of you guys have got this one. This was a little tricky for all of you guys. The potent enzyme inducer. So whenever there is an enzyme inducer, they are going to increase the metabolism of the existing drug, and this will be leading to treatment failure. This will lead into a treatment failure. So जब treatment failure होगा, तो usually what will be the outcome? The outcome is going to be, there will be a recurrence of the epilepsy. Now let's read the option. Toxin released by killed tubercle bacilli caused the epilepsy. No, not the toxin. Decreased effectivity of the valproate due to ATT. Yes, ATT में एक है ना rifampicin. It's the correct answer. And option C and D, which they are telling which of the following statement is true about the cause of the epilepsy और द ट्रीटमेंट ऑफ दिस वन, है ना. सो दोनों ही पूछ लिया इसमें. ऑप्शन सी, स्टॉप वैल्प्रोवेट एंड ट्रीट ट्यूबरकुलोसिस. यू कैन नॉट डायरेक्टली स्टॉप वैल्प्रोवेट, है ना, एंड नाइदर यू स्टॉप एटीटी, है ना. सो यू विल हैव टू मैनेज इट वेरी केयरफुली, है ना. सो करेक्ट आंसर फॉर दिस वन विल बी बी. बी इज द करेक्ट आंसर बिकॉज वैल्प्रोवेट का जो आउटकम था रिड्यूस हो गया बिकॉज ऑफ द rifampicin, which is a potent enzyme inducer. Inducer always causes treatment failure. Okay, next. A patient presented a casualty with tachycardia. So ये तो organophosphate carbamate तो बार बार पूछता है और मैं बोल चुका हूँ आपको, कभी भी ये क्वेश्चन है, please don't make mistake. There is organophosphate or carbamate, and other one will be your atropine. So they are always going to present with three important symptoms. There are many symptoms that can be mentioned, but look for three important symptoms: eyes, mouth, heart. Eyes, mouth, heart. What do I mean? Organophosphate में eyes never lies. Atropine में भी eyes never lies, है ना. तो eye आंखों को देखो, माउथ को देखो, दिल को देखो, है ना. हियर व्हाट विल हैपन? देयर विल बी पिन पॉइंट प्यूपिल, मायोसिस, पिन पॉइंट प्यूपिल. सिक्रीशन क्या होगा? देयर विल बी एक्सेसिव सिक्रीशन, इंक्रीज इन द सिक्रीशन, body secretion, salivary secretion, every secretion will be increased because it's a irreversible acetylcholine esterase inhibitor. There will be more increase in the amount of acetylcholine. Okay, what will happen to the heart? Heart rate, it is going to be decrease. अब इसी का उल्टा कर दो atropine में. Atropine, everything will be on top. What do I mean by everything will be on top? Pupil size on top, mydriasis. Secretion कैसा होगा? कम होगा. Secretion will decrease because it's an anticholinergic drug. Because there is a decrease in the secretion, please remember, body temperature is going to increase. So as I said, everything will be on top. Body temperature will also be on top. What about the heart rate? Heart rate is also going to be on top. Heart rate भी बढ़ जाएगा. Atropine में everything will be on top. How will you manage this case? How will you manage? Organophosphate carbamate में we will be using atropine as an antidote. And atropine में antidote क्या होगा? That is going to be your physostigmine. Physostigmine, it's one of the reversible acetylcholine esterase inhibitor, tertiary amine है ये, ठीक है. And here just remember one additional point here, that if there is a case of organophosphate, we can even use oximes. So oximes like pralidoxime, obidoxime, it will be mainly utilizing the organophosphate. Remember, because organophosphate one site, an ionic site is vacant, therefore this particular oximes can be effective, but others will not be effective. I hope it is making sense to all of you guys. Okay, I hope it is making sense to all of you. Okay, so correct answer for this question, if you see, tachycardia, hyperthermia, mydriasis, so your diagnosis will be atropine poisoning, and so atropine is the correct answer, C. Organophosphate carbamate, they will present in the similar way. If there is a pinpoint pupil, drug addict brought from the street, this will be the history of opioid, always remember. Okay, 55-year-old patient with a history of diabetes, BP is 140/90, which of the following antihypertensive drug would you avoid? So what we know, that whenever there is any diabetic patient, the drug that should always be avoided in diabetic patient will be, I mean, in antihypertensive drug will be non-selective beta blocker. Because see, he is a diabetic patient. Whenever any diabetic patient have hypoglycemia, because of the hypoglycemia, there will always be activation of the sympathetic symptom. Sympathetic outflow जब बढ़ेगा, तो because of sympathetic outflow, the patient will have multiple symptom. So what could be symptom? Because of the beta 1 activation, there can be increase in the heart rate. There will be palpitation. तो ये एक symptom होगा. Patient will feel, okay, I am having hypoglycemic scenario. Beta 2 activation can lead to tremor. Sweat gland activation, because sweat gland is sympathetic and cholinergic in nature, there will also be sweating. ठीक है. So one thing is for sure that you are not going to see these all symptoms. So if there is a diabetic patient who is going to be on a non-selective beta blocker, what will happen? This non-selective beta blocker, especially non-selective beta blocker, if it is given, one problem that it is going to do, it is going to cause masking of the hypoglycemia. What did I say? I said it will be causing masking of hypoglycemic symptom or warning symptom of hypoglycemia. Masking of hypoglycemic symptom or warning symptom of the hypoglycemia. So all these symptom will not be coming, है ना? And second thing, what will happen? See, after some time, when the beta 2 of the liver will be activated, this beta 2 of the liver will be causing what? Gluconeogenesis, glycogenolysis. Because of gluconeogenesis and glycogenolysis, what will happen? There will be increase in the glucose. So this increase in the glucose is actually going to cause a reversal of the hypoglycemia. And if you are going to give beta blocker, you see, if you give your patient a beta blocker, what is going to happen? If you are going to give beta blocker, this beta is blocked. So symptoms, usually the symptom will not be seen. Symptom is not going to be seen. Second thing, second problem that we are going to see, there will be no reversal of hypoglycemia as well. So there will be no reversal of hypoglycemia. So because of these two problems, non-selective beta blocker should be avoided. ACE inhibitor, ARB, amlodipine can be given. There is no such contraindication for them. Okay, next. Which of the following drug doesn't cause SLE-like syndrome? Right, so any drug that is metabolized by acetylation can cause lupus-like symptom, है ना? So all of them, sulfonamide, penicillin, isoniazid, है ना, hydralazine has been given. But if you see penicillin is an antibiotic. It's one of the beta-lactam. It is not metabolized by acetylation, है ना? So penicillin is the correct answer. Other drugs that are metabolized by acetylation, there are so many drugs actually, but we know clonazepam, hydralazine, isoniazid, sulfonamide, है ना? Procainamide is an anti-arrhythmic drug that is metabolized by acetylation. Any drug metabolized by acetylation can cause SLE. So penicillin is the correct answer here. It will not cause SLE-like symptom. 65-year-old Parkinson disease patient on maintenance therapy of MAO inhibitor consumed sweets made of milk. So whenever you hear this in pharma, whenever they say milk product, sweets or food product made of milk, or after that some symptom is coming, most of the time it is going to be your cheese reaction. So this is actually a scenario of cheese reaction, and he consumed actually a sweets made of milk, and because of this, always remember, this patient actually is consuming more and more of tyramine. He is consuming more and more of tyramine. Tyramine is a sympathomimetic agent. Tyramine, it is going to cause displacement reaction. What did I say? I said tyramine is going to cause displacement reaction. But you and me, we are not going to get this problem cause cheese reaction, because there is abundance of MAO, monoamine oxidase, in our intestine, which is causing rapid metabolism of this tyramine. Hai? So tyramine is actually metabolized with the help of enzyme known as your monoamine oxidase. But if the patient is already consuming MAO inhibitor, then what will happen? Just think and tell me, if MAO inhibitor is given, MAO inhibitor is already existing, and now ऊपर से ले लिया milk product, banana, beef, है ना, they all have excess of tyramine. So tyramine level will be causing sympathomimetic symptoms. So there will be malignant hypertension, BP बढ़ जाएगा, heart rate palpitations बढ़ जाएगा. Drug of choice for cheese reaction is going to be phentolamine. Very simple, है ना? Phenoxybenzamine is the drug of choice in a patient with the pheochromocytoma. Now what is more important here in the entire discussion, आपको लेना क्या है, वो ये कि this question may not be repeated, but the topic or everything around this that I'm discussing could be a very important MCQ. Now many of you have also sent the MCQ, मैसेज कि सर डिजॉक्सिन के क्वेश्चन आए हुए हैं. देखिए डिजॉक्सिन के क्वेश्चन एक दो आए हुए हैं, वो बात मैं समझ रहा हूँ, बट ऑप्शंस में डिजॉक्सिन है, दैट डजंट मीन वो डिजॉक्सिन है ना, दैट डजंट मीन वो डिजॉक्सिन उसका आंसर है. There are some questions उसमें डिजॉक्सिन है, तो it could be overlapping with the medicine, could be overlapping with my subject, है ना, but always remember it's not always digoxin that is going to be the correct answer. मैं अभी बता देता हूँ आपको बाकी सारे questions में. Now there is a 60-year-old male presented with the inability to evacuate the whole bladder. Inability to evacuate. So जब भी कोई patient आता है with the difficulty in evacuating the bladder, it is going to be benign prostatic hypertrophy, most likely BPH. This patient has a hypertension history as well. BPH is benign prostatic hypertrophy, hypertension. He also has diabetes and he also has a dyslipidemia. Guys, what did I tell you? That hypertension with BPH, the drug of choice, it is going to be alpha-1 blocker like prazosin, terazosin, alfuzosin. But if there is only BPH, the drug of choice is going to be tamsulosin. Right, we have discussed this, but here The correct answer will be prazosin, right? Do remember the prazosin important side effect. Now, when I'm discussing prazosin, everything around prazosin becomes important. What is the important side effect of prazosin, like postural hypotension and all, you know? Okay, Mira background, it's a beta 3 agonist. It will be causing relaxation of the bladder. Derifenacin, it is a M3 receptor antagonist. They will also be causing relaxation. ये दोनों के दोनों क्या करेंगे? They both are going to cause relaxation of the bladder. Relaxation of the bladder. Okay, correct answer is prazosin. A patient developed marked bradycardia after metoprolol. Metoprolol is a cardioselective beta blocker. Which of the following beta blocker is preferred? If any beta blocker is causing marked bradycardia, like थोड़ा बहुत ब्रेडिकार्डिया करेगा ही, बट मान लो आपने एक डोज दिया और हार्ट रेट इमीडिएटली 35 पे चला गया, दैट मींस सच पेशेंट आर नोन एज योर बीटा ब्लॉकर सेंसिटिव पेशेंट. सच पेशेंट आर नोन एज व्हाट? बीटा ब्लॉकर sensitive patient. And in that patient, what will you give? You'll be giving some beta blocker with partial agonistic property. Some beta blocker with a partial agonistic property. Now there are so many beta blocker that is having partial agonistic property. हमें सब नहीं पढ़ना है, हमें इतना ध्यान रखना है कि अगर हमने इन तीनों को याद कर लिया तो हमारा काम हो जाएगा. LAP, that is labetalol, esteemed, pindolol. So these are the beta blocker with the partial agonistic property and also they are having local anesthetic property. ये दोनों ही property इनके साथ होते हैं. Partial agonistic property and local anesthetic property. These both property are seen with this LAP. So अगर इन LAP में सर्च करते हैं तो which one is there? That is going to be only esteemed. So इसमें आप दोगे partial agonistic. It's a beta blocker but it is also having partial agonistic property. Because of that heart rate बहुत ही नीचे नहीं जाएगा, है ना? A drug with first order kinetic after 4 half life will be accelerated by very easy. 100% से start करो. 1 half life में it will become 50. Next half life it will become 25. That will become 12.5. That will become 6.25. That will become 3.12. It will keep on happening. And there is no end to this one. But you examiner is asking after 4 half life. So first half life में 50% बचा. Second half life, third half life, fourth half life. Now after fourth half life 6% remains. How much is accelerated? Around 95%. So close to 94, 95 we are having this one. 95% is the correct answer for this question. This was a very straightforward question and very easy question. Pancuronium. So pancuronium is what? It's a non-depolarizing muscle relaxant, and after muscle relaxation we always use what? Neostigmine. We are not going to use physostigmine because it's a tertiary amine. We want our action inside, outside usually, because there is an NM blocker, है non-depolarizing muscle relaxant. Tertiary amine, it is going to cross the blood-brain barrier. So mainly we are going to prefer what? Neostigmine, not acetylcholine or adrenaline. There is no point of using adrenaline or acetylcholine. Okay, B is the answer here. Vasomotor reversal of Dale. कितनी बार बता चुका हूँ कि it's always and always see in presence of alpha blocker. If you are going to give high dose of adrenaline, there will be only fall in the blood pressure. There will be only fall in the blood pressure. ठीक है? तो fall of BP on adrenaline injection only? No, adrenaline will be causing first increase then decrease. Fall of BP on adrenaline injection in presence of alpha blocker? Yes, B is the correct answer here. Fall of BP in presence of on adrenaline injection with beta blocker. See, in presence of beta blocker, if you are going to use this one, high dose of adrenaline, then there will be only upward, है ना? So there will be increase in the blood pressure, है ना? So vasomotor, that is reversal of Dale. But B is the correct answer here, है ना? A patient of Parkinson disease was complaining of resting tremors. So that's a very typical of Parkinson disease, which is not indicated. Pramipexole, rivastigmine. Come on. Pramipexole can be used as a dopamine receptor agonist. Deep brain stimulation, levodopa, carbidopa can be utilized. Levodopa, carbidopa preferred drug. What is rivastigmine? Rivastigmine is one of the acetylcholine esterase inhibitor. They will be increasing the level of acetylcholine. This acetylcholine esterase inhibitor increasing the level of acetylcholine. We are going to use this drug in the treatment of Alzheimer's disease. AD is Alzheimer's disease. तो rivastigmine तो come on, rivastigmine Parkinson disease में यूज ही नहीं होता है और ये एक PYQ है. It has been asked in NEET PG as well और आपके एग्जाम में पहले पूछा गया था. ठीक है? A patient with pancreatic cancer on morphine for pain management. After some time the pain is not relieved. So morphine के साथ एक प्रॉब्लम ये है कि morphine के साथ टॉलरेंस का रिस्क ज्यादा होता है. Now why does tolerance will happen? Tolerance is going to happen because of the receptor desensitization or down regulation, है ना? So either there will be receptor desensitization, or there will be down regulation of the receptor. डाउन रेगुलेशन. तो ये मैंने कॉन्सेप्ट आपको ANS में आई हैव टॉट दिस ऑलरेडी, है ना. डिक्रीज एब्जॉर्प्शन, ओपियोइड रिसेप्टर डिसेंसिटाइजेशन, पेन इंटेंसिटी इंक्रीज. नो, कैंसर तो वही है. तो करेक्ट आंसर व्हाई मॉर्फिन इज नॉट वर्किंग इज रिसेप्टर बिकम डिसेंसिटाइज, not the अगर upregulated हो जाएगा, if the receptor become upregulated then morphine will be more effective. If the morphine receptor become upregulated then morphine will become more effective. Okay, next. A patient presented in OPD with loss of consciousness. Upon examination there is mydriasis, heart rate is 144. Again, see, the diagnosis is going to be none other than atropine poisoning. Relative state that he is taking some plant product. Which of the following agent is most likely associated? तो कौन सा है? Atropine तो ऑप्शन में नहीं है, but atropine is derived from Atropa belladonna. So correct answer will be belladonna poisoning. Very very simple. वो मैंने कहानी पहले बता दिया है ना, eyes never lies, है ना. तो कहाँ का देखना, eyes, mouth और heart. There is a farmer, 50 years farmer, most likely case organophosphate. So look at the heart rate again, it's lesser, pupils are constricted. What is the true statement regarding the management? So true statement regarding the management, what is the correct answer? What is the diagnosis? Diagnosis is organophosphate poisoning. This could be carbamate poisoning as well. This could be the either of them, they will be the diagnosis. Now neohistamine is preferred due to its cholinergic property. Neohistamine will increase acetylcholine and it will worsen the scenario. If you give neohistamine, a single dose can kill this patient because this patient is already coming to in cholinergic crisis. And organophosphate will increase the acetylcholine level drastically. Epinephrine is used. No, there is no use of epinephrine here. Atropine is considered as a drug of choice. Very simple question. Yes. Methacholine, again, it's a cholinergic drug, we will not be using. A patient presented in OPD with complaint of muscle weakness. Upon adrophonium injection, the weakness disappears. So what is adrophonium? It's the same drug. It's also one of the acetylcholine esterase inhibitor. And acetylcholine esterase inhibitor that is going to increase the level of acetylcholine. This will be mainly seen in a patient with the myasthenia gravis. ये बात कर रहा है एक टेस्ट की जिसको हम बोलते हैं टेंसिलॉन टेस्ट. They are talking mainly about a test known as a टेंसिलॉन test. So how did this drug act? How did the weakness disappear? है ना? So this inhibited the enzyme acetylcholine esterase. है ना? That is how in the myasthenia gravis there is autoantibody against the acetylcholine receptor, post-synaptic acetylcholine receptor. है ना? So they are going to increase the acetylcholine level, that will be causing improvement in the symptom. Next, 50-year-old male patient ophthalmologist के पास गया for his vision related issue. The consultant instructed the resident on duty to do full retinal examination. After instilling a pediatric agent, which of the following agent can do this purpose? So phenylephrine is alpha-1 agonist. It will be causing active mydriasis. So definitely can be utilized. But अगर ये hypertensive patient होगा तो we would not use it, है ना? So this should be avoided in hypertensive patient. Avoided in patients with the hypertension. So आपके वो एग्जाम में ये देख लीजिएगा, अगर दे रहा है कि 50-year-old patient with the known case of hypertension, which drug should you prefer, which drug should you use? Phenylephrine तो नहीं यूज करेंगे because it will be causing hypertension. But यहाँ पे ऐसी कोई बात नहीं है. Simply they are telling a patient want mydriasis. Which of the following you use? Pilocarpine क्या है? It's a M3 receptor agonist. It will be causing active kind of miosis. It will be causing active kind of miosis. तो ये तो कभी यूज करेंगे ही नहीं ना, ये तो active kind of miosis कर रहा है. Cyclopentolate is a M3 antagonist. So this can cause passive mydriasis. It will be also causing mydriasis, so this can also be utilized. Correct answer for this question is going to be A and C. Okay? A and C is the correct answer for this question. Let's see the next one. 40-year patient with a chronic fatigue symptom, joint pain, dry skin. He also complains of difficulty in speech during difficulty in speech during eating and during the speaking. Okay. And dryness of mouth most of the time. Upon examination, there is a swelling of the salivary gland. Okay, swelling of the salivary gland, difficulty in eating, swallowing, बात करने में भी दिक्कत है. So most likely this will be a case of Sjogren syndrome. Sjogren syndrome के साथ there are autoantibody against salivary gland. So the patient will often present with a xerostomia. So if you want to increase the salivation, you will have to give M3 agonist, like cevimeline being the drug of choice. But there is one more M3 agonist that can be used, like bethanicol can also be used. So A and C is the correct answer here as well. It is also an M3 agonist. M3 agonist will be utilized for the management. Next, 36-year-old woman presented with a symptom of major depression that are unrelated to general medical condition. So you see, a question like this could be a question of pharmacology, it could be a question of psychiatry. तो थोड़े बहुत integration हो गए हैं from paper 2. Some questions are here, but it is absolutely fine. This is a very common question of medicine, है ना? Medicine में भी Sjogren syndrome पढ़ाते हैं ना अच्छे से, है ना? ये ऑफ्थेल का, तो आप देख रहे हैं देयर हैज बीन इंटीग्रेशन नॉट ओनली विद फार्मा। अब हो गया कि ज्यादातर सब्जेक्ट के इंटीग्रेशन फार्मा के साथ हो गए हैं ना, तो इसलिए फार्मा के क्वेश्चन आपको ज्यादा लग रहा है, बट इट्स एक्चुअली इंटीग्रेशन है, क्लिनिकल क्वेश्चन इसलिए आपको लग रहा है। ठीक है, लेट्स सी द नेक्स्ट क्वेश्चन। द नेक्स्ट क्वेश्चन इज अबाउट a 36-year-old female with a major depression unrelated to any general medical condition, bereavement or substance abuse. She is not currently taking any prescription or over-the-counter medication. Drug treatment is to be initiated with sertraline. So sertraline क्या होता है? Sertraline is one of the SSRI. In your information to the patient, you would tell her that. What would you tell her? That always remember that drug immediately will not start working. Any CNS drug, guys, it will be taking around 2 to 3 week time for onset of the action. Okay, it is preferable. Sertraline may take 2 week or more to become effective. Yes, it is preferable she take the drug in the morning. Okay, so SSRI है, antidepressant है, so she can take the drug in the morning. She should notify you if she anticipate any. Okay, if she is taking any other drug, definitely she should notify you drug, है ना? So again, if you see this question, it was a very easy question, easy peasy question. All of them is the correct answer here. 63-year-old man is undergoing radiation treatment as an outpatient for metastatic bone cancer. His pain has been treated with fixed combination of oxycodone plus acetaminophen taken daily. One of the opioid, one is NSAID. Despite increasing doses of the analgesic combination, the pain is getting worse. The most appropriate medication for his increasing pain, है ना? So most appropriate, look at the word oral drug पूछ रहा है. The only oral drug that is having efficacy quite similar to morphine will be hydromorphone. So you'll be advising this patient this drug is having high oral efficacy, and orally it's available, unlike pentazocine that is injectable, and he can take this for analgesic purpose. Its efficacy is compared to morphine. तो morphine के जितना efficacy इसका compare किया गया है, तो C is the correct answer. A known patient of glaucoma went to mountaineering. So glaucoma patient at an altitude started developing breathlessness, nausea and vomiting. Which of the following drug useful in glaucoma and high altitude sickness? Guys, this is the easiest question. Carbonic anhydrase inhibitor is the drug of choice for mountain sickness, and it's also the drug that can be used in the glaucoma. In glaucoma, how it is going to work? In glaucoma, it will be decreasing the aqueous production. And in mountain sickness, they are going to act by producing metabolic acidosis, and likewise they can also lead to CSF acidosis. This CSF acidosis will be causing or inducing hyperventilation. Because of hyperventilation, again the excess CO2 will be washed out. Okay, 45-year-old patient with the given glycopyrrolate. So glycopyrrolate is one of the M3 antagonists. Please remember it's a M3 antagonist as a pre-anesthetic drug, and they are one of the quaternary amine. What do you know about quaternary amine, boys? What do you know about quaternary amine? That quaternary amine do not cross the blood-brain barrier. So there will be no CNS effect. That they will not cross the blood-brain barrier. Okay, the pre-anesthetic that is used for this scenario is because of its sedating property? No. As I said, no CNS action. Anxiolytic property? No. Anti-emetic property? No, it does not have anti-emetic property. It reduces the secretion? Yes. So that the most of the anesthetic agent could reach to the lower air space like alveoli. 58-year-old patient, compensated heart failure, started on a beta blocker which has antioxidant. So which beta blocker has antioxidant property? The answer to this question none other than carvedilol. There is no and if but here. Carvedilol has shown to have antioxidant property, and it is also having vasodilating property. This vasodilating property, it is possibly seen due to the alpha-1 blocking property. Okay, now you see this question. This could be a very good question of your compensated decompensated. You should teach in medicine as well. Medicine के बारे में बात कर सकते हैं. Pre-anesthetic drug. Who will be taking this one? Anesthesia. So now these two questions, or previously also 6 questions that I told you, they are mostly a case of what? They're mostly a case of a different subject. Like this one, a patient of glaucoma. So they are usually integrated ophthalmology with pharmacology. तो ज़्यादा integrated हो गया है, इसलिए ज़्यादातर फार्मा में आ गया. ऐसा नहीं कि फार्मा के हैं सारे. हाँ, ऐसा भी हो सकता है कि ये फार्मा में मैं पढ़ाया हूँगा, because again ever since your subject has become clinical pharmacology और integrated system जब से आ गया है, जब से we are teaching most of the clinical, तो ये सारे के सारे क्वेश्चन प्योरली आपके फार्मा के नहीं है. जैसे ये वाला क्वेश्चन है ना, रेडिएशन थेरेपी, ओपीडी, मेटास्टेटिक बोन कैंसर. तो ऑर्थोपेडिक्स गाइस आर आल्सो टीचिंग दिस वन. मेटास्टेटिक बोन कैंसर हो गया, कैसे ट्रीट करेंगे ना. So these things are not purely. This will be a very good question of your psychiatry, क्योंकि psychiatry में इसके बारे में बात होगा. फार्मा वाले तो बात करेंगे mechanism of action की बात करेंगे, है ना. फार्मा वाले will not talk about कि 2 टाइम लेना है 3 टाइम लेना है. They will be teaching mostly about the mechanism of action, side effect, interaction. We will be talking more about that. But again, there are a lot of integration. Because of that, more question look like a pharma question, है. तो ये देखिए सारे के सारे ना प्री-एनेस्थेटिक एनेस्थीसिया का इंटीग्रेशन है इसमें, ठीक है. Medicine integration. Next one, middle-aged patient with the who has started on clonidine for his hypertension. The physician instructed him possible side effect on the sexual dysfunction. See, any sympatholytic drug, be it clonidine like alpha-2 agonist, because alpha-2 agonist they will decrease the noradrenaline level, right, at the synaptic level, or any of the beta blocker, any sympatholytic drug, they will be associated with the sexual side effect like impotency. Impotency will be seen because they are going to decrease the testosterone formation, right? So sympathetic system blockade can decrease the testosterone synthesis, therefore impotency will be a very, very important side effect. Now examiner asks, where will you see delayed ejaculation? Delayed ejaculation SSRI के साथ हो सकता है. It can be associated with the SSRI, SNRI, also some TCA, tricyclic antidepressant, have also shown to have delayed ejaculation. That is why one very specific SSRI that we know, dapagliflozin, psychiatry वाले बड़े प्यार से पढ़ाते हैं dapagliflozin, है ना. It's a FDA approved drug for premature ejaculation. ठीक है. Hypersexuality can be seen with some of the drugs like levodopa, carbidopa, levodopa. It can also be seen with some other dopamine receptor agonists like pramipexole, ropinirole. They can also cause hypersexuality. तो ये दो तीन क्वेश्चन अलग यहाँ पे हमने डिस्कस कर लिया, ठीक है. नेक्स्ट क्वेश्चन. 55-year-old male complaints of urinary incontinence. All of the following agent can be used in incontinence except. Now urinary incontinence है. So what will you use? You are trying to, you should use the drug that should hold the bladder, right? So you can use a drug like beta 3 agonist like mirabegron. Mirabegron will be causing what? Relaxation of the bladder. Mirabegron, vpegron. So if this is the normal bladder tone, you will be giving a drug that should actually relax the tone of the bladder. And you should give a drug that should actually cause relaxation of the bladder tone. So either beta 3 agonist or you will be using M3 antagonist. So oxybutynine, solifenacin, tolterodine, these are all M3 antagonists. Bethanicol, guys, it's a cholinergic drug. It's a M3 agonist. They will be increasing the tone of the bladder. They will increase the urine outflow. So you will not be using this one. Hai na? A very typical question of pediatrics. Integrated with pharma. So they have given, they have classified into pharma. 9-year-old child, learning difficulty at school. He has brief lapses of awareness every 5 to 10 minutes. EEG is telling you 3 Hz per second spike and wave pattern. So which of the following the drug of choice? Again, it's a case of absence seizure. So more the examiner talks, more information will be coming to you. And when it's a case of absence seizure, what will be given? The drug of choice will be ethosuximide. Ethosuximide. Question is telling which drug will be effective in this child without disadvantage of excessive sedation or tolerance. Now remember, can we use clonazepam in a patient with absence seizure? Yes. But does it have a sedation property? Yes. So without a sedating property, ethosuximide. Gabapentin और barbiturate तो हम यूज ही नहीं करते हैं, है ना, absence seizure में. Drug of choice will be ethosuximide. A patient was started on anti-seizure drug with chronic use of using seizure state with the adverse effect. Which of the following adverse include coarsening of facial feature, hirsutism, gingival hyperplasia? Typical to the point, facial feature, gingival hyperplasia, or the gum hypertrophy. Gum hypertrophy, in fact, is the most common side effect of this drug by the name of phenytoin. है ना? So that is a clear-cut case of phenytoin. Young patient, typical integrated medicine question. Patient को 15 to 30 second के लिए tremor progressing to massive jerking of the body. Clonic phase lasts for 1 to 2 minutes, leaving the patient stupor. So there is a post-ictal deficit as well. So in the medicine, they will be discussing you something called post-ictal deficit. As I told you, there is a lot of integration here. So this is the case of generalized tonic-clonic seizure, and the drug of choice for generalized tonic-clonic seizure that we always see. Currently, we have 2 drugs. One is valproate, and other one is a lamotrigine. So out of them, the safer alternative is lamotrigine, and other one is your valproate. So these are the 2 drugs that will be used. Given the scenario that we have, I would go ahead with the lamotrigine. ठीक है, GTCS है ये. 51-year-old patient Parkinsonism being maintained on levodopa carbidopa therapy with adjunctive use of low dose of tolcapone. Tolcapone is a COMT inhibitor, but continues to have the off period. Now, for the treatment of the off period, we are having a drug by the name of safinamide, a newer drug. Safinamide is one of the MAO-B inhibitor. Safinamide is a MAO-B inhibitor. Then we are also having a drug that is entacapone, opicapone, tolcapone. Entacapone, opicapone, tolcapone, what are these COMT inhibitors? Although we are not using tolcapone now, but theoretically they have given tolcapone is a toxic drug, hepatotoxic. We are not using, right? We also have a drug known as apomorphine. Apomorphine has nothing to do with morphine. It's a dopamine receptor agonist. Dopamine receptor agonist. Huh? So non-ergot dopamine receptor agonist. So SEA are used for the off phase of on-off phenomena. FSEA. So given the scenario, which of the following drug is used as a rescue drug, but will provide only temporary. So temporary relief. Apomorphine is the drug, not the drugs like your carbidopa, Pramipexole or Selegiline. Selegiline, Rasagiline, what are they? They are the MAO-B inhibitor, but they are not preferred for your off phase. Off phase के लिए 3 दवाइयां हैं. Next, they are talking about a 73-year-old male with a history of recent changes in the treatment for moderate hypertension is brought to the emergency department because of fall at home. Antihypertensive drug causing fall at home, most likely it's a vasodilator drug, and the most risk is associated with the alpha-1 blocker. Now, can ACE inhibitor can also cause? Yes, but if you have to choose between alpha-1 blocker and ACE inhibitor, you will be choosing more alpha blocker. है ना? ACE inhibitor can be associated with the postal hypertension, but their risk is much lesser. है ना? Because ACE inhibitor will be inhibiting angiotensin converting enzyme. They can increase the level of angiotensin 1. Angiotensin 1 will increase the level of prostaglandin. Prostaglandin can cause vasodilatation. So थोड़ा सा इसमें कम risk है compared to alpha 1, which is directly blood vessel पे blood vessel के tone को it will reduce. Okay. A patient with hypertension and angina referred for the treatment. Metoprolol and verapamil is given. So these are all medicine integrated question with pharma, है ना? Verapamil, metoprolol दोनों दे दिया. So verapamil, metoprolol पहले तो यूज नहीं करते हैं. Why? Because they are associated with increased risk of heart block, or we say bradycardia, severe bradycardia or heart block. Now heart block in ECG will be seen as increased PR interval, not hypoglycemia, diarrhea or tachycardia. Please remember, metoprolol can cause diarrhea, verapamil can cause constipation. Verapamil is a calcium channel blocker. Any DHPs or non-DHP, this is a common side effect. DHPs और नॉन DHP उनके साथ एक कॉमन साइड इफेक्ट है, दैट इज दे बोथ आर एसोसिएटेड विद द कॉन्स्टिपेशन. ठीक है, सो इंक्रीज इन द PR इंटरवल इज द करेक्ट आंसर फॉर दिस वन. नेक्स्ट, 45-year-old man is brought to the emergency department with mental obtundation. Blood pressure is very high. Hypertensive emergency, critical, typical case of medicine, है ना? So retinal hemorrhages, तो क्या हुआ? End organ damage भी है. So this is a case of hypertensive emergency. Now medicine here is integrated with the typical general pharma chapter, that which of the following is used in severe hypertensive emergency is a short-acting drug and act by G protein. First and foremost, the drug of choice for hypertensive emergency is IV nicardipine. तो आपने दो चीजें यहाँ पे सीखनी है. One thing is that what is the drug of choice? IV nicardipine is a calcium channel blocker. It is not acting through G protein. Here examiner is asking which of the following acting through G protein, है ना? So the only one is your phenoldopam. It's a D1 agonist. This will be acting through D1 agonist, and D1 act through GS. Losartan is one of the angiotensin receptor blocker. Captopril is a ACE inhibitor. Now captopril not used in hypertensive emergencies, है ना? Aliskiren is a renin inhibitor. They are not acting through G protein. G protein वाला एक ही है phenoldopam. So ये typical integration है कहाँ से? मेडिसिन का जनरल फार्मा से. ठीक है. Next, a patient admitted in emergency department after overdosage of a drug. He is noted to have hypotension and severe bradycardia. He has been receiving therapy of hypertension and angina. Which of the following drug in high doses causes bradycardia? So I told you that high dose में beta blocker, verapamil, they can cause bradycardia. They will be causing bradycardia. But look at this. What is one thing common with them? Isosorbide dinitrate, they will be causing vasodilatation. Nitroglycerin nitrate causing vasodilatation, and prazosin is a alpha 1 blocker. They will also be causing vasodilatation. You see, any drug causing vasodilatation will be causing fall in the blood pressure. जब भी fall in the blood pressure होगा, तो this will be leading to what? Reflex tachycardia. This will be leading to a reflex tachycardia. I think इतना तो आसान है, सबको समझ में आ रहा है. So the only drug that is causing bradycardia will be verapamil, calcium channel blocker. 45-year-old man with hyperlipidemia and frequent migraine headache develop angina of effort. Okay, so there is angina of effort. We also call typical angina. Which of the following is relatively contraindicated because of our migraine? The answer to this question, nitroglycerin, because nitroglycerin can cause meningeal blood vessel dilatation. Yeah? Meningeal blood vessel dilatation, and therefore they can cause precipitation of migraine. They can precipitate always and always migraine. इसीलिए this will be contraindicated, not others. ठीक है? A patient who has been taking digoxin for several years. अब digoxin इसका आंसर नहीं होगा, digoxin केस में दिया हुआ है ना? तो digoxin बार बार आ रहा है तो कुछ इंपॉर्टेंस हो सकता है. Make sure that you read digoxin. You never know. Mindset of examiner. He is taking digoxin for several years for atrial fibrillation and chronic heart failure and is about to receive atropine. Now, digoxin, how do they work? They are mainly sodium potassium ATPase inhibitor. Because of sodium potassium ATPase inhibitor, they are going to increase the intracellular sodium, which is not physiological. Because of this reason, I have told you that there will be activation of NCX, sodium calcium exchanger activation. And because of the sodium calcium exchanger activation, there will be increase in the intracellular calcium. तो calcium अंदर आएगा और sodium बाहर जाएगा. Sodium will be efflux out. So only channel in your body which can act two ways will be NCX, sodium calcium exchanger. तो intracellular calcium जब अंदर आएगा, so they are going to increase the FOC, मतलब force of contraction. This is one mechanism of action. Second mechanism of action of digoxin that all of you should know. Second mechanism of action of digoxin is that digoxin is a drug that is also having vagomimetic property. It is also having vagomimetic property. That means it is going to increase the cranial of 10 tone at the nodes. So because of this reason, there will be decrease in the heart rate. See, एक तरफ से तो force of contraction को ये बढ़ा रहा है. It is increasing the force of contraction, but lesser rate. Heart rate को भी ये कम कर रहा है. ठीक है. Now, examiner is asking a common side effect of digoxin. So digoxin can decrease the heart rate. That can almost entirely be blocked by atropine. So atropine is a non-selective muscarinic antagonist, but main action is seen as the M2. है ना? So M2 blockade, it will increase the heart rate. है ना? M2 blockade of atropine can increase the heart rate. So one drug is actually decreasing the heart rate, and atropine on the other hand is increasing the heart rate. So which effect of the digoxin can be actually be blocked by atropine? Appetite, headache, increased atrial contractility of PR interval. So increased PR interval, because they are decreasing the heart rate, the PR interval will increase, and this will be actually antagonized by the atropine. Atropine will antagonize the heart rate wala side effect. So this was again a little tricky one. And typical question of USMLE pattern, because your examiner is slowly shifting towards that. A 60-year-old patient with a heart failure, supposed to be on long-term loop diuretic therapy, he has a risk of causing hypokalemia. Okay, so in order to continue the diuretic effect and to reduce the risk of hypokalemia, you have added one more diuretic. So what will you add? Diuretic effect bhi chahiye, and you want to avoid the risk of hypokalemia, you are going to add a potassium sparing diuretic. And potassium sparing diuretic, I told you that we are having SETA, SETA, that is spironolactone, eplerenone, triamterene, and amiloride. So that is your potassium sparing diuretic, and these two are actually aldosterone receptor antagonists, and these two below here, they are the epithelial sodium channel blocker. So very simple, you look for a potassium sparing diuretic, the only one is in the list will be eplerenone. Others are diuretic. I mean furosemide, chlorthalidone, acetazolamide, they're all diuretic. They can further aggravate the hypokalemia. Next, 55-year-old male presented with a long-term history of hypertension, and for which he was on maintenance therapy of the thiazides. Okay, hypertension with the thiazide therapy. BP is still very high. What will you add? So always remember that whenever they talk about the age, so less than 55 year or more than 55 year, they talk about the age. If age is less than 45 year or less than 55, you use either A or A. A matlab either ACE inhibitor or ARB. And if more than 55, you use either C or D. D matlab preferably diuretic, कौन सा? Thiazide diuretic, है ना? D preferably will be thiazide. If it is non-responsive, then you use either A plus C or you use A plus D. That means either ACE inhibitor or ARB with calcium channel blocker or ACE inhibitor ARB plus diuretic. Agar again not responsive, third line mein you'll be using a combination of A plus C plus D. If it is still non-responsive, then you are going to tag it as a case of resistant hypertension और वहां पे आप aldosterone receptor antagonist like spironolactone आप यहाँ पे use करोगे. Spironolactone you'll be using, right? So I hope all of you guys are following me here. That यहाँ पे spironolactone answer नहीं होगा. Many students I'm sure have marked spironolactone. This is not a case of resistant hypertension. They are simply telling एक ड्रग पे है not responsive, अब क्या करोगे? So we are going to add one more drug. So one more drug will be either ACE inhibitor or ARB. ARB is telmisartan. Next one. Hypertensive patient with ACE inhibitor visited your OPD with new onset pedal edema. So there is the renal component here. Serum creatinine level is also high. Again, it's confirming renal component is there. Which ACE inhibitor is most suitable? Now, all the ACE inhibitors are mainly excreted renally. ACE inhibitors are excreted renally. Okay? In a CKD patient, we use ACE inhibitor. But given the scenario that we have, which one will you prefer? You can use. All of them are 4. All of them can be used. But it's asking, कौन सा prefer करोगे? Now, all the ACE inhibitors are excreted renally. There are 2 ACE inhibitors except fosinopril and moxapril. Fosinopril and moxapril. तो इसको बोलता हूं मैं, याद करिए mnemonic radio FM. All the ACE inhibitors are excreted renally except fosinopril and moxapril. है ना? So moxapril will be the answer. Many of you have marked ramipril, but the correct answer will be moxapril. The next question is about a 55-year-old patient was treated in emergency for arrhythmia. Later, he developed neurological symptom like paresthesia. So whenever anti-arrhythmic drug causing neurological symptom, it will be none other than lidocaine. Lidocaine is what? It's a sodium channel blocker. It's a lipid-soluble drug. It will be crossing blood-brain barrier as well. And because of that, the patient will have multiple neurological symptoms like paresthesia, slurring of speech, tremor, lightheadedness. They can also cause convulsion as well. And so this will be none other than lidocaine. 60-year-old patient started on prophylactic anti-arrhythmic drug. So which anti-arrhythmic drug require monitoring of LFT and spirometry? ये तो मेरा favorite question है. बार-बार ये question मैं पूछा है. ठीक है? So with this one, the answer to this question will be amiodarone, because the most common side effect examiner says here will be your thyroid abnormality. So TFT भी लगेगा, thyroid function test और TSH भी लगेगा, है ना? They can also lead to pulmonary fibrosis. Because it's a class 3 anti-arrhythmic drug, they can also cause QT prolongation, hepatotoxic drug. They can also lead to corneal microdeposits. All of them have been a part of MCQ previously. So you already know the correct answer to this question. Correct answer is going to be amiodarone. A 65-year-old male with a frank symptom of heart failure visited your clinic. You started this patient on newly approved drug which is ionotropic action and vasodilating property. So इसको बोलते हैं ionodilator. We call them as a ionodilator. And ionodilator drugs are simply phosphodiesterase 3 inhibitor. We have the drugs like your Ambrinon. इसके नाम में ही सब कुछ है. Ambrinon, it's a ionodilator. Milrinon, Ambrinon, ionodilator. Levosimendan, Pimobendan, all of them, levosimendan, pimobendan, they are all ionodilator. They are third generation beta blocker. No, they are not. The beta blocker will not have ionotropic action. Adenylate cyclase inhibitor, no. Phosphodiesterase 3 inhibitor. Correct answer will be phosphodiesterase 3 inhibitor. Heart failure में use करते हैं ना. Metabolic modulator, यहाँ पे जो option दिया है इसको आपको जान लीजिए. There can be a potential MCQ. It can be 2 drugs, that is trimetazidine and ranolazine. Trimetazidine, ranolazine, they are the metabolic modulator. Please remember, they are mainly utilized in the treatment of angina. Which 2 drugs? Trimetazidine, ranolazine. Next, they are asking simply, there is a 73-year-old man, inadequate response to other drug, received digoxin for chronic congestive heart failure. Okay. So in this question, they are mainly asking, what is the best documented mechanism of action of cardiac glycoside like digoxin? What is the mechanism of action? What did I tell you? They are mainly blocking sodium potassium ATPase, and that is how they are going to increase the intracellular calcium. The cytoplasmic calcium level is simply increased. They don't have any action on the beta receptor, neither they are going to increase the ATP synthesis. They have no role in the ATP synthesis. Okay, remember. 72-year-old woman has long-lasting heart failure. Which of the following drug has shown to reduce the mortality? So reducing the mortality in a chronic patient with chronic congestive heart failure, always remember there are few drugs. The best among all of them will be ACE inhibitor. All of them are going to end with the pril. They are considered the best drug. Captopril, lisinopril, ramipril, all of them. Then there are others, ARBs, angiotensin receptor blocker, which are actually going to end with the sartans. Then we also have one more, that is aldosterone receptor antagonist. Aldosterone receptor antagonist, that is going to be spironolactone. Then we are also having a new class of drug, ARNI. ARNI में दो drug हैं, a combination of ARB, that is valsartan. Valsartan is one of the ARB, and neprilysin inhibitor, that is going to be sacubitril. Sacubitril is one of the NI. NI is neprilysin inhibitor. And beta blocker, low dose beta blocker, not at the optimal dose. The word is low dose, not at the optimal dose. This is important. So lot of A and one B, A, B, so these are the drug that is going to decrease the mortality in a patient with the chronic congestive heart failure. Digoxin can be used, especially if there is atrial fibrillation. Dobutamine in acute scenario can be used, furosemide can be used, but they don't have mortality related benefit. Correct answer for this question will be spironolactone. Spironolactone, eplerenone, they are the aldosterone receptor blocker. 5-year-old child vomiting, brought to the emergency department, sinus arrest and ventricular heart rate. Okay, ventricular heart rate is very less, 35. Empty bottle of digoxin. Okay, when the heart rate is so less and empty bottle of digoxin is found, you are going to use digoxin antibody. Very, very easy. If there would be arrhythmia, you would be using lidocaine or magnesium. So digoxin antibody, Fab fragment will be using as an antidote. 60-year-old patient comes to the emergency department with severe chest pain. ECG reveals ventricular tachycardia, occasional normal sinus beat, and ST segment changes suggestive of ischemia. A diagnosis of MI is made, and the man is admitted in the cardiac intensive care unit. His arrhythmia should be treated. See, there is a case of arrhythmia, actually they are telling you, in a patient with the MI. Now, given the scenario that you have, I will be going ahead with the lidocaine. Lidocaine is the drug of choice in a patient with a ventricular tachycardia. इस scenario में भी हम ये use करेंगे. However, there are recent reports that they are telling that in MI patient, we should be using more of amiodarone rather than lidocaine, because the risk of asystole that has been increased with the lidocaine. Lidocaine is class 1B antiarrhythmic drug that is mainly going to cause sodium channel blockade and is going to cause potassium ka opener. So sodium channel blockade, potassium opener, they will be causing more of a repolarization. They are going to decrease the action potential duration as well. So they have shown to cause asystole, especially in a patient with a myocardial infarction. Usually the drug of choice, particular tachycardia, in most of the scenario it is going to be none other than your lidocaine. Lidocaine is class 1B antiarrhythmic drug. Okay, so correct answer for this question, C, I would say. So I think this is all the question that we got in pharma, that we got integrated with many subjects. Like we saw one question of anesthesia, 2-3 question of ophthalmology. I think 2 question of anesthesia also, 3 question of ophthalmology, many question of medicine integrated, psychiatry integrated. So we cannot just say that this is all a case of just the pharma. Number looks more just because possibly a lot of integration. So there has been a pattern change in for your examination. Most of the question are going to be in the clinical pattern. So don't worry about that. I hope all of you guys have performed well. If you have not, just write it to us. We will be just one message away from any one of you to take care of and to guide you what to do in the last 8-9 days for your examination. Okay? So with this, thank you very much to all of you. I'll see you around.